If you watch this entire video, then you'll know more about injections than 99% of the general population. In fact, there's a good chance you'll even know significantly more about this topic than a lot of doctors out there. This video is your ultimate guide to learning all about musculoskeletal injections and is a compilation of multiple YouTube videos that I spliced together to make it easier for you to follow along and learn. I hope you enjoyed the video. Now let's dive in. The rehab and physical therapy and you as the patient are doing the vast majority of the work. And then I can come in with injections occasionally and just kind of help bump things along or kind of guide in the right direction. This whole season, we'll be talking about injections. So as a sports medicine doctor, I do a lot of various injections, and I kind of want to walk you through all about various injections. So, the first one we're going to talk about today is essentially when to consider injection. We're going to have lots of ones coming in the future here, but the first and foremost is, hey, who is a good candidate for having an injection, right? Not everyone's going to get an injection, and I don't recommend that for anybody. I'm pretty judicious on the injections I do give, and so it's definitely not for everybody. I'm not a person who's going to be like, oh, everyone should get an injection. That's fine, no, but today we're going to talk about, when should you consider getting an injection? So when we first start off and do that, the first thing I kind of talk about, I'll kind of go the opposite and say, when do you not get an injection? Most things being, common, I'd say we do not get an injection immediately after being injured, right? Like unless you're a professional athlete, that might be different. And like I said, all the rules go out the window for professional athlete. And we know that if you're a professional athlete, then, it's not the most healthy thing in the world to be playing that high level and you're going to have issues. And so that being said, this is for our everyday athlete here. Is that, we are not going to have an injection right after you get injured. That's typically not what we want to do in terms of, you had a strain or something simple like that, an injection right after, usually not necessary at all, right? It's just going to cost you money, time, and there's always potential side effects, which we'll talk about later. But that being said, it's something that I would say if you have an initial injury, like we are not going to start that right away. So, and like I said, also another time we're not going to do injections if you've done no therapy whatsoever, or you don't plan on doing any sort of rehab whatsoever. This is another instance here where if you have not done any like physical therapy, any rehabilitation, and have no plan on doing that, then I typically won't do an injection. Obviously, there are exceptions to this. If someone's like 85 and they have bad arthritis and they're just trying to have improved quality of life, that's a whole different conversation. But for most people, who are younger and are active and can move around and can do rehab, for me, I always ask them, if you are not planning on doing any sort of rehab, like for me, then injection is probably not ideal, right? If you think about an injection is a lot of times like a Band-Aid, potentially. If we inject some sort of anti-inflammatory medication, it's going to make you feel good for a little bit of time. But then if we don't get to the underlying problem of what's causing that issue, then injection is not going to do much because it's just going to come back in, a couple of days, weeks, months, however long the injection lasts. And so that's another reason that I wouldn't do an injection to someone if they have no plan on doing therapy, unless there's certain circumstances. But like I said, if I'm envisioning the, general weekend warrior, someone who is active, who wants to be active, and they say, oh, I just don't have time for therapy, I just want an injection. Like that's not a good reason to get an injection personally. In my experience, I haven't had a good success with doing that. And so I'll typically talk with patients and kind of counsel them there. So and then also another reason I will not give an injection is if you haven't had your treatment options explained to you, right? So this is this is not like I'm stopping you, but you might not understand all the options. A lot of times some people I've seen in the healthcare world where they saw their primary doctor and they got referred to me and they come to sports and they're told they need an injection. They're like, oh, I was told I need an injection. And I was like, oh, why do you need an injection? Do you want an injection? They're just like, I hate needles, but this is what they said I needed. And so I get to have that conversation with them. And that's my job as a specialist, as a sports medicine doctor. I get to have these conversations and talk about the risks, benefits, and all that fun stuff. But like I said, if you haven't heard all your treatment options, then it's not a great place to start. I usually don't jump right to there. In terms of treatment modalities, like I said, I'm pretty darn regular in terms of the first thing. If you have a pyramid of what treatments are, the first thing in the bottom is going to be rehab in terms of some sort of physical rehab, whether that's physical therapy, at home exercises, something like that. That's going to be the base of that pyramid, and then we'll move up to maybe injections and then surgeries if we need to and stuff. But like I said, I usually don't jump right to injections. And so also, if you haven't been explained what your options are, then it's not fair to just come in and do an injection. I know it can be done. And people do it where they come to a physician and right away they do an injection. And so that's just not how I practice typically. And so for me, this is kind of how my practice and what usually works well for me. So things to consider. Now I want to talk about when do you consider an injection, right? So we talked about people who are not good candidates. So people who, got hurt in just a really acute injury. It's not ideal. People who don't want to do any sort of work in terms of therapy or haven't had their options explained to them. So those are when I wouldn't want to recommend it. And then now let's talk about when we do consider it. The first things first is you're in pain, right? Most of the time people are getting injections when they have pain. I have seen some weird things on the internet where people get injections just for fun of random stuff. And for me, that's not necessary. But first things first is if you're in pain and not feeling well, that's the main reason people come and find me and talk to me. But that's a good reason why I think it's a very reasonable reason to have for why we consider consider an injection. Another reason I talk about is when people have stalled out with therapy, right? So like I said, on that pyramid I talked about before, the base is physical therapy, right? So if you've been doing that, religiously for a couple of months and we're still not getting any improvement, well, then I think it's reasonable to consider getting an injection, right? That's kind of my whole thing is like, I kind of talk about an analogy when I counsel patients on the risks and benefits, all that stuff. I say, if you live in the north, I use the snow example. If you live in the south, I use the mud. But I'm from the north, so if I say, if you're stuck in the snow, right, and you're just spinning your wheels, you have a buddy come over and they push you out. It's that nudge that gets you going, right? And then, but reality, the car spinning the wheel, that's what's providing all the power. Once you get that push, then you can make it out. I always say the injections are like your friend pushing that car, but the rehab and physical therapy is like the actual car itself. The rehab and physical therapy and you as the patient are doing the vast majority of the work. And then I can come in with injections occasionally and just kind of help bump things along or kind of guide in the right direction. That's how I view almost all of my injections, is that I'm just trying to be a guide and trying to help you get back and facilitate you to rehab so you can do more. Like I said, sometimes you just need a little bit more to get over the hump, and that's a reasonable thing to do as well. And so I said, like I said, going hand in hand with that as well, you'll see that all these things I talk about, we're doing therapy, we're taking time. So like I said, a good candidate also is someone who's had this for a while. And like I said, you might be like, oh, that's mean, Jordan, to let people suffer for a while. Like, first of all, I'll never let someone suffer. If something's really bad or going on, like there are options we can consider, and that's a whole different conversation, different podcast. But the vast majority of people who already worked through me have gone through, saw in their primary and then came to me, and maybe they did some therapy, maybe not. But like for me, my job is to decide, hey, have we done a really good rehab? Have we been, kind of off base? Have we been doing just a bunch of passive modalities in terms of stretching and stim or whatever? And so kind of determining, did we actually give true physical therapy and progressive overload a try or not? And so like I said, I'm going to have those conversations with people. That's my job, and we'll do that. But like I said, usually it's a chronic injury, something that's been going on for a while, and someone who's willing to put in the work. So that's kind of like my ideal like avatar of person who like, hey, you're a good candidate for injection. And when it comes to injections, we have a bunch of different options. Like I said, we're going to have more on these in the future podcasts. I'm going to break down pretty much each one of these injections and talk more about it. But in general, the main injections that we'll have are steroid injections, NSAIDs or anti-inflammatory medications, hyaluronic acid or viscous supplementation, they sometimes call it, dextrose prolotherapy, PRP, and stem cells. So those are kind of the big ones. And we'll talk all about those. I would say the vast majority of injections most people think about are steroid injections. And when I mean steroid, I don't mean anabolic steroids like you see in the bodybuilding community. Not like that. They're not the ones that'll make you jack. There's a different type of steroids, things we take when people have like flares for arthritis and stuff like that. So definitely not a like anabolic steroid, but those are the main ones, and we'll talk about each one of those and break those up into individual episodes, and we'll talk all about this so we can understand who to use these on, when they're a good idea. And then another question people ask is like, well, who should I see for an injection? Well, there's a bunch of different providers that you could see for an injection. First things first, obviously everyone thinks of orthopedic surgeons that they can do injections, and they can for sure, because they can do surgery. I mean, if they can do surgery, they can do injections, right? And yes, they can, absolutely. There's also non-operative sports medicine physicians. That's where I fall into. So I'm someone who's a fellowship in family medicine and in sports medicine. So primary care sports medicine. So I did my family medicine residency and then sports medicine fellowship. So I'm a non-operative sports medicine. And then also some primary care doctors do things. Sometimes they'll do more basic injections like a subacromial shoulder injection or a knee injection. And like I said, all those things, those two things can be done by a lot of primary care doctors, which can be helpful. But I said, those are the different kind of levels for most injections. Say I'm obviously very biased because I am a non-operative sports medicine doctor. And I would say, I think preferred would be a sports medicine doctor who's trained in ultrasound skills. So at the end of the day, what we can do when we're, trained in ultrasound is we can actually look and see the pathology. We can see the knee joint, we can see the tendon, we can see whatever, and then we can see the needle going in real time, so we know where we need to be. Like I said, and that's a big thing, is we can actually visualize our needle, so we know the medication is getting right where it should be, as opposed to a lot of times other physicians will do blind injections. Blind meaning not like they close their eyes and just guess, but blind meaning they're just going based off of landmarks, which can be accurate at times. There's some good data that orthopedic surgeons really know where the knee joint is. No surprise, they're doing surgery all day and putting scopes in there, so they know where the knee joint is. But then when they compare like shoulder, they say that ultrasound guided is more specific and have a higher chance of getting the medication where it needs to be when compared to just landmark. And so for me, if you can do it with an ultrasound, I typically do it with an ultrasound. There are some that are pretty straightforward enough where we don't necessarily need an ultrasound. Like I said, a lot of times knees and subacromials don't necessarily need them. And so that can happen. But like I said, most of the time I'm using the ultrasound on anything that's a little more complicated. I'd recommend, find someone who can have ultrasound skills to do that. There are also, I just not to be confused, physical therapists can do dry needling. And so dry needling, most people think, oh, that's an injection. It's not really an injection. It's just actually using the needle itself. And so they're not injecting any sort of medication in there. They can't do that. And so that's just something I do mention as well. And then kind of going back, I just want to talk about landmark versus ultrasound guided. So I mentioned, finding someone who does ultrasound guide injection. Typically, like I said, these are going to be our non-operative sports docs. It can be orthopedic surgeons as well. I have seen some use them, but a lot of times, like I said, they do surgery and they don't necessarily do as many ultrasound guide injections, but it can happen. But in most situations, ultrasound guide injection is going to be better in, like I said, almost every situation. There's not a lot of times where I think doing landmark is better. And so you don't necessarily need to use an ultrasound, but you're greatly improving your chances of getting medication where it should be. And so that's what I said. So even, like I said, mentioning again, studies have shown that even orthopedic surgeons can sometimes struggle in joints that aren't the knee. So like shoulders and stuff. Like I said, so anything that's not super basic, I think it's recommended to use an ultrasound. I think it'd be good. And the people who will do that, like I said, non-operative sports docs, this can be, physicians who train in family medicine, pediatrics, emergency medicine, or PM&R. And all those people can then do a fellowship and get ultrasound guided injection. PM&R, a lot of times those docs don't even necessarily have to go through a fellowship. They do a lot of ultrasound training during their residency. And so that's something to think about as well. But like I said, what you'd be searching for is a primary care sports medicine doctor or someone who has sports medicine fellowship. So it'd be CAQSM, which means, a certificate of additional qualification in sports medicine. If you Google that, that's someone who can most likely do ultrasound guided injections. And then when considering an injection, you always have to consider price, right? Some injections are crazy expensive. Things like PRP and stem cells, unbelievably expensive. And a lot of times these higher ones are not covered by insurance. Other ones, thinking like steroids, hyaluronic acid, those are kind of anti-inflammatories. Oh, those things are kind of a little more common, and usually they're covered by insurance. And so, like I said, if someone's, shelling out PRP or stem cells or, talking about those injections, the odds are it's not going to be covered by insurance. PRP, there's starting to be some procedures that are covered by insurance, but not a whole lot. It's looking like potentially knee osteoarthritis or lateral epicondylopathy. Those are kind of the two that are kind of making their way there. But like I said, a lot of times PRP and the stem cells are going to be not covered by insurance, and they can be crazy expensive, like, $1,000 for PRP, $3,000 plus for stem cells. So an insane amount for these injections. And we'll talk more about those later. But like I said, that's just kind of giving you the basis. But otherwise, ones that will be covered by insurance, usually steroid, hyaluronic acid, NSAID like ketorolac, that can typically be there. Dextrose prolotherapy kind of falls in between. Some get covered, some do not. So that's just, I want to mention that as well. That may or may not be covered. And so anytime I talk to someone about having an injection, I always have to talk about the risks, benefits, and alternatives, right? So you have to be a well-informed patient. I think it's their right to know what could happen in any sort of injection. So I always talk about risks first. The biggest risk we always worry about is infection, right? If I'm bringing a needle into the joint, I'm taking something from outside the skin and putting it underneath the skin, meaning the needle's coming out in, and we try to clean it as perfect, as good as possible, but there's, it's not a sterile field entirely. It's not like surgery. So there's always a chance that something from outside can get inside. The risk of what we call septic arthritis, which means a big infection in the joint that's kind of scary in an emergency when you get like a washout in surgery, the odds of that happening are exceedingly rare, like about 1 in 10,000 plus, depending on which study you look at. So pretty darn rare. But like I said, this is the one I always counsel patients on, saying, hey, if over the next couple of days you start to develop a joint, let's say your knee, it starts to get red, hot, swollen, maybe start getting fevers, like and the pain starts getting out of control, like that is not a normal reaction to an injection. So that is what we look out for a septic joint. And so like we would want to go to the ER, that's an emergency. So like I said, that's the biggest thing I always counsel about, and it can happen, but like I said, exceedingly rare, but it is on the list, and I always have to tell everybody that's a possibility. Then another thing I always talk about is pain, right? Unfortunately, a needle is a needle, and I found no way to make a needle not feel like a needle. Like they have some of the cold spray, which can be helpful as well, but like I said, it's still a needle. Usually they're pretty small. In terms of like gauges are anywhere from like 25 to 18, and 18 is a decently big needle. That would hurt. 25 is pretty small, and so usually people tolerate that really, really well, but sometimes it can be painful, especially if you're going somewhere sensitive like the hand or the foot. That can be bad. Another risk is you could have some excess bleeding. Like I said, there's a lot of small blood vessels in a lot of injection sites we do. Usually not a lot of big ones, but there's always a chance that, you're going somewhere and there's a big blood vessel, or there's a blood vessel where you didn't think there would be. So there is a chance of bleeding as well. Most of the time, if we do have additional bleeding, it's usually from a small blood vessel. Just put a little pressure on there and that's all you need. But like I said, that can happen. And then I also tell them it's possible to have damage to a nearby structure. A nearby structure meaning, hey, maybe there's some branch of a nerve we're not sure of. Maybe your anatomy is a little different and we could hit a nerve, or like I said, hit a small artery that we don't know about. That's always an option when doing an injection. And even on the ultrasound, even if you use the ultrasound, and there's some very small nerves, you wouldn't necessarily see them in ultrasound, so it's possible to get that. I say if we hit it, you might feel a zinger. Like I said, there's some pretty much experienced people said that if you readjust and move, like a lot of times it gets better, and most of the time that recovers fully. But there's always a chance, right, that we hit a nerve with the needle and it leads to lasting damage. That's just the way it works. Like I said, it's very rare for that to happen, but it's always something we have to consider. And like I said, I always talk about these risks, and like not to try to scare people, but just so they understand, like, hey, we're doing an invasive procedure, that something could happen. And that's why I take it so seriously that when we do an injection, I make sure it's the right person, because all those things could happen. I don't, they don't happen very often, but it's always a possibility. So I want to make sure. Then I always talk about, the benefits, right? So I've talked about risks, benefits. Well, hopefully they're an improvement in your pain and function. That's the ultimate goal, is getting you out of pain and helping your function, like I said. And it's, to me, it's not an idea to just say, hey, this is just get rid of your pain. Because like I said, a lot of times they're temporary. They're not going to necessarily get you better. I want to get your pain better so that we can help your function get better. That's what I go for. And then I always talk about the alternatives, right? So what are our alternatives to injections? Well, do what you're continually doing, which is either nothing or physical therapy, or another alternative would be potentially surgical options for some things. And so that being said, that's always, we kind of escalate things as needed. But like I said, we just talk about risks, benefits, alternatives, and it's always a patient's choice. To me, I kind of just give you information and you kind of let me know, hey, is this something I want to do? Is it not what I want to do? So I always put this in the patient's hand. And obviously we work on it together. We're a team when we decide something like that. Say, hey, this is what I think, this is what I do. And that can kind of help patient decide, like, hey, I give you this information, I can kind of help make sense of it. And hopefully you have a good understanding of, the condition you have, the treatment options, and what an injection might offer. And so that's kind of how I work through this. And at the end here, I just want to talk about my perfect injection candidate, right? So I've kind of talked about before, my perfect injection candidate is someone who has a chronic issue, right? Hasn't been there right away, has given a little bit of time, has been working hard on rehab and therapy, and maybe they've just stalled out with the therapy, right? They've been doing, really good work, trying hard, but just can't quite get there. That's the person I'm looking for. And then also they have to understand, the injection is not going to heal them. It's most likely going to help facilitate them to help your body heal it, but it's not necessarily going to heal them. And they have to be willing to put in the work. They have to understand the risks and benefits. And they also want to try the least amount of intervention possible and then progress from there. It's like, those are my perfect people, meaning like, hey, this is ideal. And obviously I do injections all the time on people who are less than ideal, because that's the real world, right? Things are never that cut and dry. They're like, oh, Dr. Rennicke, I've tried this, and we go there. That's just not how it works. But like I said, that's my idea in my brain, and the general framework is what I want. Someone who's been going for a while, really has been working hard, wants to work hard, wants to do the least amount of invasive procedures possible, and then kind of go from there. So that's, like, I think, ideal. And that being said, that is not the only person who's going to get injection from me. There are other cases that I'm going to, like I said, that I will give on a case-by-case basis, and we'll do that. But like I said, that's what I think about walking into it. Like, that's my ideal. And then everyone's different, right? I'm here to help people as much as I can. And I'm not going to say, like, this is my way or the highway. But like I said, this is usually how I think about it, how I go through that algorithm of like, hey, who's a good candidate and whatnot. But like I said, that is what I wanted to share today. If you're thinking of getting an injection, I hope you kind of walk through this and say, hey, maybe that sounds like me, I'd be a good candidate for it. Or maybe, oh, okay, I didn't realize that. Maybe it's not ideal. And as you listen to this whole, series and this whole season, we're gonna talk more and more about like when we should be getting injections, for what conditions, what are the success rates, and then all that stuff. We're gonna go deep dive in on all that stuff. So, and today we're gonna talk all about the different types of injections that are offered out there. So we're gonna kind of dive in a kind of 20,000 foot overview of what are these injections that are offered in the sports medicine community and why you may consider one versus another. But really, we're going to talk about the mechanisms behind them today. So like, how do they work? What's our understanding of why we do these injections in terms of what is the mechanism for causing their action? And how do they help with pain? How do they help with function? So that's kind of what we're going to deep dive in here a little bit. And like I said, we've talked about previously when a good candidate is, and at the end of the day, we're trying to build on top of that, right? So we talk about who's a good candidate, and then we're going to talk about, this is like helping understand which injection might be a good fit for you. But once again, if you aren't a good candidate, then it doesn't matter what you want from an injection, then it's not going to be, what you need to kind of heal in long-term have good success. But at the end of the day, we're going to kind of break it down here. There are 4 main groups of injections. So the first one is anti-inflammatory, right? So when you think of anti-inflammatories, the gold standard is steroids. So steroids are big, heavy hitters. They're essentially like grenades. Just throwing them in there, and they're going to have a huge impact of decreasing inflammation. Not without side effects, which we'll talk about in a future podcast as well. But on the other side of that, we have the steroids, and then we have NSAIDs, or what those stands for is non-steroidal anti-inflammatory drugs. So once again, in the title of it is saying non-steroidal, meaning steroids are pretty much the baseline, like, hey, this is like the gold standard, and then NSAIDs are non-steroidal anti-inflammatories, still working in anti-inflammatory respect, but different mechanism from steroids. So that's group number 1. Group number 2 is then viscosupplementation. So visco, when you think about something being viscous, it's nice and thick. Viscosupplementation typically are full of hyaluronic derivatives. So hyaluronic acid derivatives, these are, we'll talk about the mechanism there, but essentially the idea behind this is we're trying to create more quote unquote lubrication inside the joint. That's like what the general idea of viscosupplementation injections are. Then the third category is regenerative medicine. So this is a huge term, a broad term. It covers a bunch of different things. The main ones we're going to talk about today are things like dextrose prolotherapy, PRP or platelet-rich plasma, and stem cells. And then maybe there's some other stuff on there as well. But regenerative medicine is just an umbrella that it kind of falls under. One medication and one injection is not necessarily all of regenerative medicine. Regenerative medicine is this huge umbrella term covering for tons and tons of different things. And it's quite frankly the Wild West out there right now in terms of injections in sports medicine community. We'll talk about the issues that we have with regenerative medicine potentially as we go along here in the series, but understanding what that means by regenerative medicine, like I said, we're talking about dextrose prolotherapy, PRP, and stem cells. This is the general understanding of it. In the fourth category we're going to talk about here is kind of hydrodissections. And so a hydrodissection sounds really intense and it sounds like it's not a good thing. Like you don't want to dissect anything. But what we mean by that is a hydrodissection is typically a procedure where you're having some sort of injectate come in, go around a nerve and trying to free up or release that nerve. And so a hydrodissection is typically with some sort of more innocuous type solution, and you're going there trying to free up that nerve. But like I said, long story short, the vast majority of the time, this is nerve related. You can do it with a fat pad. So a lot of times like the patella or the fat pad behind the patella, you can do a hydrodissection there to kind of separate layers. So anytime you're trying to separate something from something else, you can use a hydrodissection for that. And so all right, so now we've kind of covered the big four categories. I kind of want to move on and talk about, what is the mechanism behind each individual injection. So first, we're going to start with steroids, right? We talked about that. These are not anabolic steroids, so they're not going to get you jacked. And the first things first, I have to say steroids, not anabolic. These are actually the catabolic type. So there are some effects there that can be, detrimental as well. But overall, these are the standard for anti-inflammatory medications. And there's a reason that non-steroidals are called non-steroidals, because these steroid injections or oral steroids, they work really, really well. They're very powerful anti-inflammatories. And so comparing medication to those can be helpful. Once again, they have different mechanisms. So the mechanism for steroids, typically, like I said, you might hear medications called like triamcinolone, dexamethasone, or betamethasone. Typically triamcinolone is the most common injectate that I've seen in terms of injections, but we also have seen dexamethasone used as well and other steroids, but typically you're going to see triamcinolone. And so all those fall under the category of steroids. And the mechanism for these take some time to take action. So the way I explain is when you inject a steroid or you ingest a steroid, what has to happen is the medication has to come into the cells, get absorbed, obviously into the circulation that gets into the cells, and then the medication has to make its way into the actual nucleus of the cell. So it binds to a steroid receptor inside the nucleus of the cells, and then what it does, it affects gene expression. When I say gene expression, that means inside the nucleus, kind of we're having, our genes being read, and then from there we're making proteins of it. And so what the steroids actually do is they go into there, kind of bind their receptors, and then affect what genes are coming out and how they're read and what proteins are coming out. So that's what it is. And like I said, this takes a while. So eventually, though, this produces an anti-inflammatory effect and also downregulates pro-inflammatory cytokines. So it prevents the release of prostaglandins and leukotrienes, and also inhibits the release of arachidonic acid. And all those terms are sound really fancy, like prostaglandins, leukotrienes. Long story short, it takes a while. So when you inject, it has to go in there, incorporate into the cell, and then kind of changes things from there. What it does is it produces anti-inflammatory effects and diminishes the pro-inflammatory effects. So that's kind of what's going on there when we think about it. And it inhibits things like prostaglandins, leukotrienes, and the release of arachidonic acid, which we'll talk about here in a second with NSAIDs. So long story short, powerful, takes a little time because it has to go in there and get incorporated and kind of hang out and affect what's being made. On the other hand, we have NSAIDs, or non-steroidals, right? So they're not like steroids. They're different. They're separate from that. Typically, you'll hear names like ibuprofen, naproxen, ketorolac. Those are the big ones. In terms of injection, I have not seen too many things other than ketorolac. There are some other NSAIDs that I've seen some papers on, but the vast majority of the time is going to be ketorolac. And like I said, from an injection standpoint, that's going to be the main one we see. And what do NSAIDs do? Well, NSAIDs inhibit cyclooxygenase pathway. So cyclooxygenase is a pathway that which kind of usually is pro-inflammatory. And what this does is it is a COX inhibitor. So NSAIDs inhibit this COX enzyme. And what does that? Decreases enzyme. Enzyme activations are decreased inflammation. But then what's nice about this is that it's a much more targeted pathway, right? So if you think about steroids, they're kind of decreasing a lot of things, a big group of things, whereas the NSAIDs are much more inhibited to just the cyclooxygenase pathway. So it's more targeted, have a narrower therapeutic target. And so we're not hitting as many things. And the big reason we talk about steroids, they kind of shut down everything, whereas NSAIDs are more selective, which can be very helpful as well. And you might be asking like, well, what is cyclooxygenase? So it's abbreviated COX, and COX actually converts arachidonic acid into thromboxanes, prostaglandins, prostacyclins, once again, all these pro-inflammatory things. So if we shut down COX, we're not able to convert this arachidonic acid into these thromboxanes, prostaglandins, and other pro-inflammatory things. And on top of that, COX can also have 1 and 2. So there's 2 different enzymes there. So COX-1 and COX-2, and NSAIDs are described as either specific or non-specific. All the ones I mentioned before in terms of like naproxen, ibuprofen, ketorolac, all those are non-specific, meaning they inhibit COX-1 and 2. And the differentiating factor is that COX-1 is found all throughout the body, including things like your stomach, your kidneys, whereas COX-2 is expressed in the body like when it's inducibly expressed. So what that means is like when the inflammation process starts, COX-2 is kind of ramped up, whereas COX-1 is like everywhere. So if we don't have inflammation, we don't have a lot of COX-2 activated, whereas once we start inflammation, COX-2 activates. And so what these selective NSAIDs do, sometimes there are a couple of them here that like celecoxib is an example for orally, is you just hit COX-2. And so instead of COX-1, the reason we like that is because COX-1 is, like I said, found all throughout the body. So if you're inhibiting that, you can have issues like can lead to ulcers. That's a big thing, can be hard on your kidneys. And so if you have selective NSAIDs, that's ideal. A lot of times from an injection standpoint, we don't have that. But once again, what these NSAIDs are going to do is they're going to inhibit these COX enzymes. So if you're non-selective, it's going to be both of them. If you're selective, it's just COX-2, but typically both of them. And like I said, it's going to decrease the ability to produce inflammatory cytokines and inflammatory markers. And so once again, decreasing inflammation, but by a more direct and narrowed pathway. And then moving on to viscosupplementation, once again, these are all hyaluronic acid derivatives. You might have heard hyaluronic acid before, probably heard it like in dermatology commercials for like, oh, this product has hyaluronic acid. So it's a very common solution and it's found all throughout the body. Like I said, there's various name brands to the injectable ones. I'm not going to necessarily name brands, but they're pretty much all the same. They're all hyaluronic acid derivatives, but they're pretty similar despite the advertising you might see. And the thing is, hyaluronic acid is found naturally in the synovial fluid and in the cartilage of each joint. And so the question is like, how does it work? Well, in osteoarthritis, it seems like the concentration of hyaluronic acid actually decreases, as well as the size of these hyaluronic acid molecules. So the viscosity of the overall synovial fluid decreases. So the idea is that by injecting that, we're hopefully increasing that viscosity back again. The thing is, what's kind of tricky is that it's actually clear from the joint in like 17 to 36 hours they've done studies on. So, when we say we're injecting and giving you a quote unquote lubrication shot, like, well, it's gone in pretty much a day. And so it can't just be the fact that it's there and we have more of it providing lubrication. So there are some various proposed mechanisms. One being that the injection stimulates actually the native hyaluronic acid. And another idea is that it has potential anti-inflammatory properties as well. And so we're not entirely sure how this mechanism works, but like I said, once again, the idea is that you natively have some of this in your joint. And so what we want to try to do is re-supplement that. And we found that we have a decreased amount in arthritis, and that's the main use case for this. But so we kind of look at saying, hey, okay, we have this decreased amount of this in arthritis. Let's try to give you some of that back and see what happens from there. So that's the general idea for viscosupplementation. All right, next we're moving on to regenerative medicine. Like I said, this is a huge umbrella term, and the 3 main ones we're going to talk about today are dextrose prolotherapy, platelet-rich plasma, and stem cells. And so we talked before, right, our anti-inflammatory ones with our NSAIDs and steroids, we're trying to calm things down and decrease inflammation. This is kind of the opposite of that. This is kind of a pro-inflammatory environment. The idea is to re-stimulate the inflammatory process to kind of start the natural healing process back. So before we're trying to quiet things down, and here we're actually saying, hey, we want your body, we want to stimulate things back up. We want to rev it back up so your body starts that natural healing process and go from there. And despite the name, there's actually no good data that anything's actually regenerative. Therefore, it's kind of like a big misnomer. There are some lab studies showing that, hey, we might have increased, these growth factors or this or that. But like when I say regenerative, we're not like injecting someone and they're just magically growing cartilage back yet. Like we're not there by any stretch of the imagination. So if someone, is kind of saying that is the case for regenerative medicine, I'd be skeptical for sure, because we definitely don't have the data for that. But like I said, it sounds cool, regenerative medicine, so that's why everyone goes with it. But it is not necessarily like regenerating anything. I think a better name is kind of a pro-inflammatory injection is the way I think about it. And the first one to talk about is dextrose prolotherapy. So this is a technique that introduces a small amount of an irritant kind of solution to your desired location. So what I mean by that is we're using a certain amount of solution, meaning dextrose, so sugar, right? We're just using sugar and we're injecting it to a desired location. Dextrose is the ideal injectate for this. I should say prolotherapy can technically be many, many different things, and PRP probably falls underneath the umbrella, but specifically dextrose we're going to talk about here. It's ideal because it's water soluble, right? You have it naturally, you have lots of sugar in your bloodstream, and it can be injected with large amounts that are really safe as well. So the idea is that, like I said, we have this solution and we inject it into an area and re-stimulate inflammation, kind of restart the healing process. And the mechanism behind it is unclear. Like most things here with injections, we kind of like shrug our shoulders like, I don't know, like we're trying this and it seems to work and there seem to be good outcomes, but we definitely don't understand all the mechanisms. One idea is that potentially dextrose dehydrates cells at the injection site, which leads to a local tissue trauma, which then in turn attracts a bunch of different healing factors. And like I said, at the end of the day, though, when we do these injections, so kind of stepping back to prolotherapy, a lot of times what we think about is we see three main sections, meaning an inflammatory phase, then a proliferative phase, then a remodeling phase. So the idea is that hopefully, phase one, inflammation, we just restart this process saying, hey, like reminding your body, hey, don't forget about this thing. It's here. The way I explain it to patients quite frequently is that our body does a good job of making things just good enough. Like you kind of get off the back burner, like, okay, like, this achy knee, like I've calmed it down enough. It's not my biggest priority. I've got all these other big things that I need to worry about. And it kind of calms it down just enough. And so our idea is kind of to inject these medications and then kind of say, hey, like, don't forget about me. I'm still here. That's typically how I explain it. Obviously, it's very simplified, but that's like the inflammatory phase. We're like restarting it. And then after that, we hopefully have some proliferative phase where we start having some growth factors and things growing and then remodeling and kind of making some changes inside that tissue as well. So we'll see kind of how it goes in terms of that's the general framework I think about. But at the end of the day, this irritation causes inflammation, right? And so when we have inflammation, this triggers the release of different growth factors and collagen deposition, which then leads to proliferation and strengthening of the connective tissue. That's the understanding. That's the kind of in the petri dish idea of what goes on. Do we have awesome evidence of that in a human being that actually happens? I mean, not really, but generally, that's what we're looking for. Like from our mechanistic standpoint, that's the idea is that we have inflammation, makes growth factors, then we have lay down collagen, leads to proliferation of connective tissue. That's the idea. From a dextrose prolotherapy perspective, also it's important to know that concentrations greater than 10% are considered inflammatory and less than 10% are non-inflammatory. I mentioned that because a lot of times the concentrations we use for certain things like tendons are about 25% dextrose, whereas if we use concentrations for what we'll talk about later with hydrodissections, a lot of times it's less than 10%. So 10% seems to be that threshold where if it's less than that, it's not inflammatory. If it's above that, it is inflammatory. All right, next we're moving on to PRP or platelet-rich plasma. This is kind of the hot new craze, and it's a pretty fancy procedure. What happens is we take out your blood, so we draw blood, and we spin it down in a centrifuge until we have concentrated platelets. So we discard the red blood cells, and then we have also some platelet-poor plasma, which you get rid of, and we're left with these concentrated platelets, or AKA liquid gold. I call it liquid gold because it actually has this like gold hue, and like when you're walking it across the room to the patient, you're like, this is a really expensive injection, so it's pretty much like liquid gold. The reason we do this, though, is that platelets contain lots of things called alpha granules, which inside of them have an abundance of growth factors. And so we try to have a higher concentration of platelets to get these alpha granules, which bring growth factors there. And then, like I said, on top of that, platelets are typically the initiators of the healing process, but not all the tissues have a large amount of them there. So we're kind of offering the body, hey, here is kind of like the scaffolding and the framework or the materials you need to kind of start the healing process. We're delivering it right to the spot where we need to do it. And on top of that, also platelets and PRP have various growth factors, chemokines, cytokines, and other plasma protein in it. So once again, we are still triggering that process, right? So we're going there with a needle in a foreign substance, we're injecting it, and that's kind of creating this inflammatory response, like, whoa, what's going on? And with that, hopefully this brings beneficial changes, right? So we are causing inflammation and giving, building blocks there. So kind of the analogy is we're starting a fire, but then we're also having the fire department right there. That's like the idea we're thinking for there. Hopefully it's not as bad as a fire and leaves the damage, but that's the general thought is that we're going to stir things up and then kind of calm things down. And last, we have stem cells for the regenerative medicine section. Stem cells, these are often obtained from either bone marrow or adipose tissue. Bone marrow, a lot of times, is from the hip, the iliac crest, and adipose tissue is usually from the stomach. So this is by far and away the most involved process. If you thought PRP was fancy, this is even more fancy. Once again, the idea here is to regenerate tissue through an augmented healing process. So, the bone marrow and adipose is full of what we call hematopoietic cells. So these have lots of different things in them. They can have supportive stromal cells. They can have stem cells, like I said. And these stromal cells promote the proliferation and differentiation of hematopoietic cells. And then they also contain other things like fibroblasts, macrophages, adipocytes, osteoblasts, osteoclasts, endothelial cells, and then these mesenchymal stem cells. So long story short, let's take a step back there. Inside of these bone marrow and adipose tissue, we have lots of things that kind of can be the foundation and the start of creating cells, creating bone cells, breaking down bone cells, building up things, lots and lots of things that we can do. And then we also have those mesenchymal stem cells. And mesenchymal stem cells, they're kind of progenitor cells, which means they have the capability of possibly becoming numerous different types of cells, like osteoblasts, adipocytes, chondroblasts, which those things make structures like cartilage, bone, fat, muscle, ligaments. So we take a step back. The idea is that these mesenchymal stem cells, they're kind of in this state where it's like, hey, I could go one way or another. So it's like a very, it's like a youth who's very impressionable, right? Saying, hey, I could go down one of these pathways. It just depends on the situation. So we have these stem cells. The idea is that, hey, these can become cartilage if we need to. These can become, ligaments if we need to. That's the general idea behind that. Once again, it's not as slam dunk on that, but that's the general idea behind injecting stem cells. That gives your body not only, the baseline scaffolding stuff, but it gives it the whole blueprint saying, hey, we have the understanding and we can become these cells. We know how to get there. And so that's what we're trying to do. We're trying to put all these factors and these stem cells at the right location at the right time to help your body heal. And it's no different. These are very expensive. We'll talk more about stem cell injections, but that's the general idea. Like I said, and that's the idea behind the mechanism, which is a little hit or miss in terms of whether that's actually happening in our body is questionable, but that's the general idea for why we would have that injection or why someone would do it. And then finally, our last section is hydrodissections. Hydrodissections, here we're using a fluid injectate to separate a nerve from a suspected area of compression. And like I said, it doesn't necessarily have to be a nerve, it can be any sort of tissue plane that we feel would benefit from some sort of separation. These are always ultrasound guided because you can't just go in there and just guess that you're hydrodissecting a nerve. So these are ones we always use. We can find the nerve, go in there, inject around it. And in this, they can have multiple different substances like lidocaine, normal saline, dextrose, all these things can be included. And at the end of the day, like I mentioned before, dextrose is pretty common for these, but it's usually much less concentrated. So it's about 5%. Like we talked about before, that 10% threshold, above 10% is usually inflammatory, below 10 is not. So we're well below that. So it's not in an inflammatory perspective. And the idea and the mechanism behind hydrodissection is that it's thought to separate nerves from the surrounding soft tissue, which may actually, release the nerves, some smaller nerves and some smaller nerve endings, which may help alleviate pain and also help the nerve potentially move or glide more freely. Like I said, that's the idea behind it. Whether that's actually happened, TBD. Outcomes can be pretty decent, but that's the idea. And then there also seems to be some sort of pharmacological effect on nerves due to the dextrose, which, like I said, it may decrease the inflammation, like neurogenic inflammation. The inflammation of the nerves may lessen the neuropathic pain by multiple mechanisms. So we found that actually the dextrose may have some sort of actual pharmacological effect rather than just mechanical, right? So for me, this is twofold. Mechanical meaning we're separating the nerve from some other structure or, one structure from another. That's what we're looking for. And then on top of that, we might have some sort of pharmacological effect. And with the dextrose, meaning that, hey, we might have may affect the nerves the way we sense pain. And so, like I said, at the end of the day, that's the general gist of the different type of injectates and why we think about using them. So we're never going to have a perfect understanding of what's going on, but I think it's very important to understand these so we can select the right medication for the right time. And so at the end of the day, when we're saying, hey, how do I select the right injection? First questions first is, what is the purpose of this injection? Is it trying to calm things down? Well, then anti-inflammatory, maybe steroid or NSAID is a reasonable approach. If someone's saying, hey, I have arthritis and I don't want to use something like steroid or anti-inflammatory, then maybe we consider viscosupplementation. Or you say, hey, actually this injury has healed for a while, but it hasn't healed fully. I want to try the regenerative approach. That's when I'd consider something like dextrose prolotherapy or PRP. And like I said, stem cells are on the list. They're always last on my list though, because of the cost for most people is just exuberant. And so I'm going to go deeper and deeper into indications and risks for things in the future. But I just want to say, hey, this is the idea for why we do what we do. In terms of here's the mechanism for each injection. This is our understanding as to why we would choose these. Rather than just saying, hey, everyone gets a steroid, we have lots of options and we can try these things in based off of, hey, what we think is best for the patient at this specific spot. And once again, I say that time and time again, every patient is different. Every patient is an individual. And so we're going to kind of tailor our treatment choice to the certain circumstances they have going on in their life. So today we're talking all about chondrotoxicity and injections and what's involved in that. And so the first question you might ask is, well, what the heck does chondrotoxicity mean? Well, chondro is the root word of cartilage and toxic is something harmful. So we're talking about things that are harmful to the cartilage. So we care about this so much because the loss of cartilage or damage to the cartilage cells is a hallmark of osteoarthritis. And if we have progression of that, then we ought to have lots of morbidity, mortality, pain, potentially, and lots of issues down the line. And so we care about how can we preserve the cartilage inside of our joints? Obviously, it seems like a very intuitive thing, like, yeah, we want cartilage, and that is very true. But the question is, are we doing damage to the joints when we're doing certain injections? And that's what we're going to talk more about that today. So we want to make sure that when we're injecting something, it isn't doing more harm than good. So let's talk about it a little more here. The first question is, how did we get here? Well, there's kind of like a landmark study where they showed repeated steroid injections when compared to saline injections saw a greater amount of cartilage loss. And so people saw that and got us thinking, well, what's causing this progression? Is it kind of like a chicken or an egg type situation, right? Like, is it, did the steroid injections cause the worsening of arthritis, or is that just the natural course of arthritis? Not really sure. And so the question is, that we saw that these people who got steroid injections, they were doing worse and had increased cartilage loss when compared to the people who got the saline injections. And so that kind of got us thinking, like, are we doing more harm than good when we do these injections? Is there something going on? Is there worsening of it because of the steroid, because of the lidocaine? Who knows what? And so that's kind of like got the ball rolling in terms of thinking, hey, there might be something to this that we need to look into. And so the first question is, I want to ask is, like, what substances are chondrotoxic, right? Like, Jordan, we just talked all about these different injections. What's chondrotoxic? Well, the bad news is that quite a few things seem to be chondrotoxic. And so, but the good news is not everything seems to be chondrotoxic. So we have lots of stuff. But first, before we go on and specifically talk about what the findings were, I kind of want to talk about the data we have for this. So what were the kind of experimental designs we did to find this information? So we have a couple different experimental studies, and usually they're involving patients either looking at serial MRIs or x-rays. And so a lot of times, what they're doing is they're seeing these patients, they're getting these injections and doing repeat MRIs or x-rays. So some sort of imaging to see, hey, is there a difference in the joint space? And obviously that's pretty subjective because one radiologist reads this, another radiologist reads that, kind of subjective. But that's one base of literature, like one body of literature saying, hey, that's how we can use one measurement to say, hey, is there something going on with these injections? However, most of the studies that we look here are kind of bench studies, meaning in the lab, looking at chondrocytes in vitro. So like looking at the cartilage cells in the microscope and kind of saying, hey, what's going on? Typically we have a petri dish setup. So we have some sort of fancy setup that like actually simulates a human joint. There's like moving fluid and pipettes and all this stuff going on and the right buffer and solution. And it's well beyond my knowledge. It's like I said, it's a chemistry experiment. And they kind of then bathe the medications that they're using in these experiments in this cartilage, in this, joint simulation. And so what they do is they kind of get that going there. They kind of bathe in there and they kind of assess over time, what's going on. They look at different things like markers of proliferation of the chondrocytes, cell death, so deaths of the chondrocytes, other biological markers. They use these fancy kind of markers and tracings and tactics to kind of look at, hey, what's the overall health looking like in there? And so, like I said, this is where the data is coming from. A lot of it is from kind of these, quote unquote, petri dish studies. And so obviously when we have a petri dish study, it's very helpful to understand mechanistically what's going on. And so that's kind of like our basis, the underlying physiology. But then we also have these potential radiology ones looking at the decreasing size of the joint space on x-ray or MRI. And so we kind of use them both together to kind of figure out, hey, is there a trend going on? But you're not going to find any RCTs in this literature at all. So I just want to let you know, if you're looking for RCTs, this is not going to be the podcast for you, but we're going to talk all about different substances now. And so first, let's talk about steroids. Steroids are definitely not on the nice list in terms of chondrotoxicity. They're not the best, that's for sure. There's some ambiguity. Some data shows that maybe steroids aren't that bad in terms of for chondrotoxicity, but the majority of the studies seem to show that there is some sort of damage that happens when we use steroids. So most of these studies show some chondrotoxicity. And in terms of what steroids are the worst, it's not entirely clear, but a couple of papers I read indicate betamethasone might be the worst. And so that one, there's a specific substance in the betamethasone, like the kind of the way they make an additive to kind of make the whole solution of it. It actually might be that ingredient that causes it. But either way, in the studies, it looks like betamethasone was the worst when they kind of compared it to other ones like triamcinolone or dexamethasone. And so, like I said, in my general practice, I think I would consider using either triamcinolone or dexamethasone first. And I would probably not use betamethasone because some of the studies is pretty significant how much worse the betamethasone did in terms of cartilage health. But like I said, all of them show chondrotoxicity. So when you inject a steroid, bathe the chondrocytes in that, it does seem to be chondrotoxic. But if we had to pick one, don't use betamethasone, using probably something else like dexamethasone or triamcinolone. And then moving on to NSAIDs, so things like we talked about ketorolac before, right? So a different anti-inflammatory medication, but a different from steroids, so non-steroidal. This is a little bit more touchy. There's a little bit more mixed data on this, whether or not NSAIDs like ketorolac are chondrotoxic at all. It seems to be a dose-dependent response with these NSAIDs, meaning that the higher the dose you go, the worse you go. And that's pretty consistent with like everything we'll see here, whether that's steroids or analgesics, whatever. The higher the dose, the more problems you typically have. So that being said, though, these NSAIDs, overall, the literature doesn't seem to be as obvious as the steroids. The steroids are like, yep, probably not good for your joint. Whereas NSAIDs are like, maybe, I'm not sure. And so they may not be the safest thing ever, but I think they're a potentially less bad option. So if I had to pick a diagnostic injection, I'll typically do this due to the theoretical better risk profile of it. So what I mean by that is, let's say I have someone who I'm not sure where their pain might be coming from in terms of I'm trying to figure out, is there a mechanical source of pain? Obviously, we know pain is much more complicated than just biomedical model, like, hey, this is where your pain is. But that being said, sometimes we can have some issues inside of a joint or something. And so I do a diagnostic injection. What I'll typically do then is try to use some sort of NSAID. So usually ketorolac is what it is. And I use that, and I'll talk about which, analgesic I'll choose, but I try to do this over a steroid. Like I said, for me, this is potentially doing less harm. Like I said, it's not a slam dunk that there's no chondrotoxicity with these medications. There's probably a little bit, but it does seem to have a better profile than the steroids. So for me, it's like picking a less bad option. And like I said, I'm really, really all about trying to have joint preserving injections. There's no point of accelerating arthritis or accelerating chondrocyte degradation if I don't have to do that. And so like I said, if I had to pick one, I'd probably choose this for a trial run just because theoretically it's better. Although I will say subjectively, I do get better results usually with steroids just because, like I said, they're really, really strong and it's like dropping a grenade in there and it usually takes care of it. But that being said, that's my general approach to things. Next, moving on to hyaluronic acid. This one actually seems to be not so bad. This is that kind of viscosupplementation injection we talked about, so kind of the lubrication injection. It seems to be pretty solid. Multiple studies have used hyaluronic acid with something else, like either a steroid or an NSAID, and it actually seems to lessen the chondrotoxicity of those other substances. So if you mixed an NSAID with hyaluronic acid, it seemed to decrease chondrotoxicity. Same thing with steroid. Mix the steroid with hyaluronic acid, don't seem to have as bad of an effect with the steroid. So that's actually something that's pretty cool and something to consider. And so overall, I think this is a solid choice. And I feel pretty good about this. If I'm doing this in a younger patient or someone I want to preserve their cartilage, like it's a really high priority, this is a medication I'll turn to. The problem is for me is it's kind of random when it'll work. I don't have a good prediction for when it's going to work for someone. And so I use it with a grain of salt, but I still think it can be very helpful at times. Then we're going to move on to prolotherapy. So like I said, prolotherapy, typically, this one we're talking specifically about dextrose prolotherapy, so that's sugar water. This seems to be another safe injection. It's just essentially sugar water, and there's some data in vitro that actually it might actually slightly increase proliferation of the chondrocytes, so it might actually increase the growth and reproduction of the chondrocytes, which is kind of cool. Like I said, I'm not injecting this thinking that we're going to regrow chondrocytes. Like, I don't think that's the case, but it doesn't seem to be a degradation of that. And so I think this is a good thing. Like I said, the problem with this is this doesn't make a good diagnostic injection, just because usually when I inject people with this, it actually like flares things up a little bit and makes them feel worse. Because like I said, remember we had the anti-inflammatory injections with the steroids and the NSAIDs, and now we have the pro-inflammatory injections here with the prolotherapy and the PRP whatnot. So we're kind of bringing in inflammation, and so people aren't going to feel good. And so like from a diagnostic perspective, like, hey, does it make you feel better? It's like, well, no, I hurt more, and maybe down the line it does, and it does seem to improve a lot of different conditions a little later, but it's not as reliable from that perspective. And so, like I said, definitely a viable option to do, can be a good option if we're looking for a broad horizon, meaning we got some time for this. But if I'm looking for really, really, really short term, this is probably not ideal. But once again, I do feel like this is pretty safe for the chondrocytes, and so I feel like it's a viable option. It's on the table. Next, let's talk about PRP, and this is another one that seems to be pretty safe. When we inject this, there does not seem to be a lot of chondrotoxicity. So it also may produce slight proliferation, just like we talked about prolotherapy, but overall just appears to be not very chondrotoxic. And so for us, that's kind of the big thing, which kind of makes sense, right? So for the anti-inflammatory group, if you think about it, we're just trying to calm things down and squash things. And so it makes sense that we're probably going to harm something along the way. Whereas we have kind of I think about neutral hyaluronic acid, which is kind of like given maybe some substrate to kind of help the joint situation going on there. And then we have the proliferative therapy or the regenerative med with Prolo and PRP kind of not causing degradation, but maybe even adding some proliferation. So that's kind of how it works. And that seems to be what the data shows. But before we end there, I also want to talk about our local anesthetics. So local anesthetics, this is the things like lidocaine, right? Lidocaine, bupivacaine, ropivacaine, all these local anesthetics, things that you can inject and then have some decreased sensitivity. So that's kind of the goal. But almost all of these appear to be chondrotoxic is what it comes down to, which is unfortunate. And then if you think about it, what our normal cocktail of injections are some sort of steroid and lidocaine or some sort of analgesics. Like we're really having a double whammy. And so that's like something that's been really practice changing for me, is kind of just questioning, thinking, hey, why am I doing what I'm doing? Why am I injecting steroid with lidocaine when both of those by themselves seem to be chondrotoxic? Add them together, it's a double whammy. It's kind of been practice changing for me to think about, do I need to do that? Do I just do that because it's standard of care? Or do I do that because there's a good mechanistic reason behind it? And that's kind of what I'm thinking about. And on top of this, we know it's chondrotoxic, but it also seems to be time and dose dependent. Time meaning the longer it's around in the joint environment, the worse it does, and the higher the dose, the worse it is as well, which kind of makes sense. If you're doing 2% as opposed to 1% lidocaine, you're going to have a more chondrotoxic effects, it seems like. And they've kind of compared these and said, hey, which one seems to be worse? Well, in terms of the least chondrotoxic, it seems like ropivacaine is the least chondrotoxic. You're looking at the AMSSN, the kind of regenerative medicine talk. They said this seems to be the one most people are going with when, like I said, we're trying to be conscious about the chondrocytes and the cartilage inside the joint. So ropivacaine, the least chondrotoxic, and then it moves on to bupivacaine and then lidocaine. So once again, lidocaine's kind of down the list. Very, very common, very cheap. So a lot of people do this. But like I said, when I'm putting this into practice, what we want to do is we want to do the least amount of damage to a patient, right? And so I think we should take this idea into consideration when making a choice. So like I said, if we have to do some sort of steroid injection, we're stepping back. I have to pick a steroid and I have to pick some sort of analgesic. I'd probably do something like triamcinolone and ropivacaine, right? The last thing we want to do is add on the higher ones, because like I said, as we add more and more saxylbetamethasone and lidocaine would probably not be a great combination, but something like triamcinolone, maybe dexamethasone and ropivacaine would be probably my choice if we have to do a steroid injection. However, if we do not have to do a steroid injection, then I'd probably try something like ketorolac or the Toradol and ropivacaine, meaning, like I said, the least chondrotoxic or the least bad things that I can think about. And at the end of the day, if you don't absolutely need to do a diagnostic injection, you can also consider using some sort of normal saline as the anesthetic. So what I mean diagnostic is sometimes initially you want to know right away, hey, did this injection work? And if you have that lidocaine or bupivacaine or ropivacaine or whatever have you, if you inject that and that area seems to be the problem, you might get some improvement right away. Say, oh, like, hey, this AC joint feels way better after that lidocaine. That might be some of my issue causing my pain. So if you're using a diagnostic purpose, that's what you're using the local analgesic for, is you're saying, hey, I want to see if I can get that right away. If you don't need that, then the question is, do we even need to use some sort of analgesic, or can we use normal saline? Like I said, the injections of normal saline don't seem to be chondrotoxic, and so that's something to consider about, maybe using that instead of our anesthetic. Like I said, overall, I feel pretty good about hyaluronic acid, dextrose prolotherapy, and PRP, and so those are the ones I'm always considering and kind of thinking, hey, how can I do this? Like I said, there is a time and place for a injection of Toradol or an injection of steroid. I think, like I said, it's definitely part of my practice still, and I think about it. A lot of times I use those not necessarily in joints, but like I said, it's still going to happen. That's definitely the way it goes in sports medicine. We're trying to always treat a patient, right? So we never treat someone based off of a study. We talk to the patient, see what their needs are, what their benefits are, what their desires are, and kind of work together as a team to kind of figure that out. So once again, everything is always unique, always individualized. It's never one thing. But I think this is something to think about when you're doing an injection. Kind of think, hey, how can I do the least amount of damage to this patient? And I want to do the most amount of good for them and the least amount of bad. And so, like I said, it's something that's kind of been interesting, and as I've been learning more about, the way we kind of do things in sports medicine, a lot of times is kind of passed down, right? Like I learned this from my mentor, learned this from their mentor. You look at some of the data, some people were injecting 10 cc's of lidocaine at some point, in some studies, whereas, the question is, why do we inject the volumes that we do? And kind of looked into it, and it seems like it's a lot of just institutional knowledge saying, hey, this is how I was trained and this is what I did, and it's not as data driven. And so I'm kind of trying to move and have a call, say, hey, can we as sports med physicians and practitioners, can we do better? Is there a reason that we're doing the things we're doing them, or are we just doing it because that's the way we've been taught? And so I'd like to challenge everybody who's doing this, said, please let me know if I'm missing something, if you disagree, if you are also on board with this, saying, hey, yeah, that makes sense, I've looked into it, and that's what I know as well. And so like I said, it's kind of been practice changing for me. I'm trying to think about how I can change my practice using this information, but that's enough for today. I think it's a short and sweet one, but it's I think really important. So thank you so much for listening. I really appreciate it. Today we're going to talk about hyaluronic acid. We're going to talk about what it's like as an injection, what are the indications for it, and when I think it'd be appropriate to use this. So let's get started. First and foremost, we're going to kind of review just a little bit here. We're going to talk about the action of hyaluronic acid. So action meaning like how is it working? So essentially what happens is hyaluronic acid or hyaluronate is a main component of cartilage and synovial fluid. So inside this cartilage and synovial fluid, we have this hyaluronic acid. It's naturally there. But instead, on top of that, it's not just there, it also gives us the viscoelastic properties to the cartilage, and also so it helps with shock absorption. It also helps in terms of it's a component of the synovial fluid, so it helps with lubrication and cartilage protection. So overall, going to find it in our cartilage and the synovial fluid, helps us with the shock absorbing properties of the cartilage and the lubrication of the cartilage as well. Hyaluronic acid is intended to restore these mechanical properties of the cartilage and synovial fluid. Like I said, it is found natively in our joints, this hyaluronic acid, but we're giving a synthetic version of that, right? So the idea is that we're trying to give back some of these mechanical properties, trying to get some of the spring back in our step here, essentially in the knee, trying to get some of that improved lubrication potentially, maybe potentially increasing some of the viscoelastic properties. So that's what we're looking for. The idea is that it binds to joint-specific receptors and acts in an anti-inflammatory role, an antioxidant role, and also may increase the cartilage cell proliferation, and it also may provide some direct analgesia by masking joint nociceptors. So nociceptors are kind of our nerve endings for pain, and so this may work in multiple avenues. So it may have a little bit of anti-inflammatory, maybe a little antioxidant, maybe it increases the cartilage proliferation, and maybe it actually increases the the masking of the nociceptors, so decreasing our perception of pain inside the joint. So might have a couple ways of working. And then they also, one of the ideas is that when we do this, when we inject hyaluronic acid, it actually may increase native hyaluronic acid production inside the joint. And so that might maybe one of the reasons why it has some more prolonged success. And so what do I mean by that? Well, I mean that our hope is that when we inject this hyaluronic acid, it may trigger your body to be like, oh, like, okay, I should make more of that. Like I said, this is not definitive by any stretch of the imagination, but these are different mechanisms we've seen in laboratory studies to think, okay, this might be something that might be playing some sort of role. So hopefully we have all these good things like anti-inflammatory properties. Maybe we're helping our body make some more hyaluronic acid. Long story short, we know that hyaluronic acid is native there, and so we're trying to replace some of that. And in arthritis, which is the pretty much only indication for hyaluronic acid, we do see a hyaluronic acid deficiency. And this is both in a quantitative and qualitative sense, meaning, the quality of it and the number of it. So for example, the normal molecular weight of hyaluronic acid in a healthy joint is like 4 to 5 millidaltons. So like I said, it's a super small measurement, but 4 to 5 millidaltons. And where in arthritis, it's about 2 to 4 millidaltons inside the joint. So we're not having as robust of hyaluronic acid, and we're not having as many. And so like I said, when we see that inside an arthritic joint, we have a diminished quality of the hyaluronic acid. That's where like the impetus comes for, okay, maybe if we inject this medication, maybe we'll improve the arthritis. And so that's kind of the idea behind it. And there are multiple different types of hyaluronic acid, right? And so, if you've ever been anywhere in the orthopedic world, or if you work in orthopedics, you'll know there's, 10 different injections you can pick for hyaluronic acid. And, people will market you that theirs is superior in this, for this reason, for that reason, whatever. We'll go through some of those things. But what it breaks down to is essentially low molecular weight ones, and then reticulated or higher molecular weight hyaluronic acid. So when we start with like the lower molecular weights, these are ones ranging from like 0.5 to 3 millidaltons. And typically these are ones they usually require multiple injections. So in terms of just giving one and done, these are not the instance for that. A lot of times they're multiple ones. Some brand names that I will include here just because it's important to know like what the brand names are, because they're all hyaluronic acid, right? And so, but there are some differences here. And there's no generics that I'm aware of. And so ones we think about are Euflexa, Hyalgan, and Orthovix for these low molecular weight ones that are multiple injections. And there is one single injection one called Arthroom monodose. And like I said, I have not seen that run across it, but it is an option. But the majority of these are multi-dose. And so when we move up to the reticulated hyaluronic acid, reticulated is just another fancy word for essentially higher molecular weight. And these are the ones that are greater than 3 millidaltons. And so what the idea behind here is a higher molecular weight, it has a slower degradation, and potentially lives longer, has a longer joint residence. So it's staying around longer. That's the general idea. The ones we see here are typically things like Monovisc, Synvisc, Synvisc 1, and Durolane. And it's like those are kind of the main ones here. So once again, that low molecular weight versus high molecular weight, we'll talk a little bit more about that, but those are the big, kind of categories you think about. In terms of the actual injection itself, obviously the indications for this are intra-articular, right? There are some other fringe uses for it that I've been starting to see in other places, but they're not really mainstream yet, so I'm not going to talk about it here. But the main indication is that we shove this intra-articularly, meaning inside the joint. So the vast majority of the time this is going in the knee, but it can be used in other joints as well. That being said, when we inject, it's super important. I've talked about this before. When we are injecting something, it's super important that we know where the medication is going, right? So if I'm injecting something into the knee, I really want it to be going into the knee. And unfortunately, about 10 to even 30% of injections that are landmark based can be defective, meaning they don't get where they need to go. And so that's why, once again, I am such a strong advocate of ultrasound guided injections, if at all possible. Like I said, or if you have an experienced clinician, like I said, those tend to have really, really good results as well, even landmark based. But if you just have the run of the mill, someone who does the occasional injection here and there, there is a 10 to 30% chance that's not where it needs to be. So once again, if you are seeing an orthopedic surgeon or a sports medicine specialist, you're probably gonna be okay with landmark, but I always prefer ultrasound if possible, just because I said that way we can see the medication going where it needs to go. If we are going to do landmark, they kind of talk about doing the lateral approach. There's a couple different lateral approaches. There's a lateral patellar, and then a superior lateral. Lateral patellar we talked about in the specific articles that I was looking at. That's essentially going under the patella. That seems to have the best results. And then, like I said, on top of that, other literature indicate that a superior lateral approach tends to have better results as well. And like I said, in terms of these injections, those are what we were looking for in terms of location. Are we using ultrasound or not? And that's what we think about. And next, I do want to talk about the different locations that it can be used in terms of, the location we can inject, how much we can inject, and the timing of it, the timing how many times. So we're going to start off with the knee, which is by far and away the most common. So the knee, like I said, we're injecting anywhere from 2 to 6 milliliters. Once again, these come in these pre-packaged formulas. So essentially, you have a syringe and you just add on your own needle and then you inject that syringe into the joint. And so it kind of comes in prefabricated amounts, anywhere from 2 to 6 for the knee. I said these injections can be anywhere from single injections up to 3 injections. A lot of times they'll do series where they'll do 3 injections of 1 per week. So they do one week and they bring you back for another week and then bring you back again. That can happen. I'm a big fan of the single injections just because one and done. I mean, nobody wants to come back to the doctor's office 3 weeks in a row. That's not ideal. Nobody signed up for that. But typically, like I said, in the knee, about 2 to 6 milliliters, anywhere from a single injection or 3 in series. So another area we can use this is the hip. Hip is becoming more and more common. The typical amount there is about 2 to 4 milliliters, so pretty similar to the knee. And once again, you can do either a single injection or maybe 2 to 3 of that injections. The data here is more like 1 per month, as opposed to the knee was 1 per week for 3 times. This is more like 1 per month for 2 to 3 times. And like I said, the data is not fantastic on any of these in terms of, should it be a 1 time? Should it be multiple time? But like I said, it can be done. It's not insane. So if your doctor says, hey, I want to bring you back again in a month, it's not necessarily them being like, I just want to give you an injection and bill for it. Like, no, that might be the series or the sequence they do it. So like I said, lots of different ways to do it. So additionally on top of that, we can also have the shoulder, can inject in the shoulder. Usually it's about 2 to 4 milliliters there. So like I said, we've kind of seen this range here, 2 to 6 for the knee, 2 to 4 for the hip, 2 to 4 for the shoulder. So anywhere from like 2 to 4, you're probably gonna be pretty good. And once again, this can be either a single injection or, once per week or once per month. So it's kind of variable here. We pretty much just goes to show you like the less and less data we have. Like knee, we have the most data, like hip. And then like as we get to the shoulder, the other ones like, I don't know. So anywhere from 1 to 3 injections, either once a week or once a month. And then we can also, there's some data on the ankle. Ankle's about 2 to 3 milliliters, so a little less. And like I said, usually they'll kind of series that once per week. And then finally, we have the metacarpophalangeal joints in the hands. And this is a small amount, anywhere from 0.5 to 1 ml. And usually what this is 1 to 3 injections once again. So the long story short is you're going to get these in a series potentially, or you might just do it singly. So I'm kind of talking with your doctor, kind of figure out what's going on there. But like I said, as we see, the fingers are going to have a very, very small amount. And as we go up into the larger joints, we're going to have more amount. So like I said, it's going to be the biggest kind of in the knee and hip and kind of going from there. So, and like I said, in the intervals of when do we administer these, right? What's the schedule? It's going to vary. It can be anywhere from 1 to maybe 5 injections, anywhere from 1 to 4 week intervals. Like I said, that's where you go. My personal practice is using a 1-time injection just because, like I said, most people don't want to come back once a week. It's hard to have access to all that. And so for me, it's just like, hey, let's just do this with 1 and done, get it done with. So another question some people might ask is, can I mix this with a steroid? And the answer is yeah, for short term, you can do that, but not a long term. This is not a long-term solution, right? So if you think about mixing a steroid, sometimes some people say, hey, if there's some signs of like synovitis there or inflammation or lots of swelling, we'll talk about that indication-wise, but they think, hey, maybe this will help as well. And so you can do that, but long-term, we don't necessarily think that's a fantastic idea because of maybe other things we talked about, like our chondrotoxicity lecture. And one question for orthopedic colleagues that they'll kind of ask is, hey, if we do this, does this affect your surgery timing? Meaning, hey, if I get this injection, would it delay any surgery? The reason we ask this is because it's pretty common knowledge and common practice that if you get a steroid injection, the orthopedic surgeons will wait at least, 3 months before you go have that surgery. So anywhere from like 12 to 24 weeks. And the reason is because when you get a steroid, we've talked about this previously, and the mechanism of action, it kind of decreases everything, inflammation, but also your immune response. And so the concern is that if you get a steroid injection before a surgery, may increase your risk for an infection or postoperative complications. And obviously we don't want that. It's a big deal. Does the same thing happen for hyaluronic acid? Doesn't really seem like it. So if it's just hyaluronic acid, there's no real consensus, but typically people will recommend waiting about 4 weeks before you can have that surgery, but it does not seem to have the same consequences as having a steroid injection. So this would be one, if you're like in the short term, you're like, oh, I really need something before the surgery, you could try this. Although, like I said, that may or may not be any benefit, but we'll talk about that in a little bit as well. And so indications, we talk about when do we get hyaluronic acid injection? Well, like I said, the only real indication that's been approved for is osteoarthritis, which is the vast majority of the times that it's used for. On top of that, though, there are a couple different subsets of things that you should look for before you have the injection. First things first, we do not want to have a swollen knee. So if someone comes with a huge swollen knee, that's not ideal. If it's inflamed, we should manage that first, whether that's through toradol injection, steroid injection, aspiration, take an oral NSAID, something like that. But we should kind of manage that before we inject it, because it's recommended against not to do that. On top of that, if you see signs of synovitis or inflammation of the synovial fluid and the synovium in there, that is also an indication where we do not want to do that. Actually, that can be chondrotoxic as well, having that inflammation in there. We know like inflammation in the joints is not good, right? So that's the kind of question. It's like, okay, we have this synovitis. Do we calm it down with a NSAID, which may also be chondrotoxic? So it's once again, there's no free lunches here. We're kind of trading things off there. But if we see synovitis, we're typically not injecting hyaluronic acid as well. And also on top of this, there's no real data that this is preventative, meaning, hey, if I inject this, I'm going to have a chondroprotective effect, meaning, hey, it's going to help my cartilage and it's going to protect me from any future injury. We just don't have data on that at all. So that wouldn't be an indication. Like I said, it doesn't seem to be chondrotoxic, but we don't have evidence that it's chondroprotective. And on top of that, if someone has like ligamentous injury saying, hey, there's some sort of meniscal pathology or the ACL or MCL, that doesn't seem to be effective as well. And it's not indicated for that. Moving on to the hip, the times we use this in the hip is when we have moderate hip arthritis without sort of effusion, any sort of joint effusion or swelling. And then if there's been some data showing that if you have dysplasia or femoral acetabular impingement or FAI, it might be beneficial to try this injection. But long story short, what they find is like if you're long end game arthritis where you have essentially super high severity of arthritis ready for a joint replacement, there doesn't seem to be any benefit from the injection. From a shoulder perspective, once again, the theme keeps showing up here is moderate arthritis. And so you can do this with or without a rotator cuff tear. And so once again, you'll keep seeing this thing, moderate. That seems to be the sweet spot, right? Mild to moderate arthritis. Severe arthritis, typically not as ideal. Once again, probably not going to do anything bad, but probably won't be as beneficial. For the ankle, once again, they talk about moderate talocrural arthritis, so ankle joint arthritis without an effusion. And then potentially, if we have OCD lesions with osteochondral defects, that can happen. That's a whole other podcast to talk about there, but that's essentially what's happening is an issue to the cartilage inside of the joint. So that might be beneficial there as well. And we move to the hand, once again, moderate thumb OA. Also, they said maybe trigger finger, which is interesting. So hyaluronic acid for trigger finger could be something to consider. I think we have a bunch of pretty effective injections for trigger finger, so I haven't used this yet, but it's something to look into that I'll have to learn more about. In terms of results, you might be asking, okay, cool. I passed that. I've got some mild, moderate OA. There's no effusion there. I just want to try this. I'm a good candidate. Well, what are the results? Well, the majority of the studies are in knee OA, which is, probably the most debilitating in terms of the most common and most debilitating, so it's easiest to study. And about 60 to 70 of patients are responders, which I'm not gonna lie. When I read that, I was a little surprised. In my practice, it's about 50-50. It seems to be like a coin flip if someone's going to respond or not. But seeing that 60 to 70% of patients respond, that's pretty cool. I'm really kind of optimistic about that. And when compared to placebo, they had about a 20% improvement. And like I said, we've known that when you get a placebo injection, you can also improve. We've seen that in the study as well. So when we have a 20% improvement above the placebo, well, that makes me think that, hey, there's something real going on. It's producing some real effect. And so if you have a knee OA and we get this injection, I'm feeling a little more confident now that we're going to have some good benefit from this. The one thing I mentioned before, saying like, oh, if you can do the injection and then have surgery 4 weeks later, the reason that might not be advised is because it typically takes about 4 weeks before efficacy to start. So like you do the injection and then you wait a little bit. Like I said, with a steroid, we say, hey, this is going to probably feel better in about a week or so. But this has about 4 weeks where it's going to go. So you want to think about it, like give it 4 weeks of runway. It peaks the effect of about 8 weeks, but it seems like in most of the studies, they last about 6 months. And so it kind of has this prolonged effect. And like we talked about, we're not sure why that is. Maybe it's because we're proliferating some chondrocytes in there. Maybe it's because we're creating our own natural hyaluronic acid. Not sure, but either way, it seems to kind of have this slow onset and then it kind of stays there for a longer time as opposed to steroid, which is quick on and then quick off. And like I said, Overall, from a pain perspective, it does seem to be improved when compared to placebo, but also comparable to like oral NSAIDs. But like I said, once again, this is a better risk profile. You can't just take oral NSAIDs all day, every day. It leads to lots of issues with the stomach, kidneys, heart, stuff like that. And so this seems to be a better option, but you get similar effects of, if you take ibuprofen, similar effects with this, but without the side effect profile. In terms of compared to steroids, right? That's kind of our gold standard. We've been doing it for a long, long time. It has similar pain improvement, like I said, but lasts significantly longer. Once again, steroids work fast, within 1 to 3 weeks, but do not last long. Where steroids in the studies in the head-to-head with hyaluronic acid, they seem to be better at 2 weeks, but hyaluronic acid was better at like things like 8, 12, and 26 weeks out, which kind of makes sense, right? We said that, hey, you're going to feel better right away with steroid. It's just like going there, knocking things down, calming it down. But long-term, hyaluronic acid seems to have a little bit better. In other ones, like I said, that is the vast majority of the data is the knee. For the hip, it's kind of controversial. What's better? Once again, does not seem to be chondrotoxic, whereas hip steroid injections seem to be. Shoulder appears to be effective as well. Ankle, mixed results. Not really sure. There's not a lot of data on that. And so one question you might ask is who responds well to this? And like I said, the overall answer is it's hard to tell for sure. You might be saying like, well, this is a waste of a podcast, Jordan. You're not telling me anything. Well, I'm just telling you what the data says, unfortunately. But that being said, it is very reasonable to try these things, but it's hard to say for sure if it's going to work for you. Like I said, it's worth a shot for most people in these who are the right candidates for it, but we're not sure. It seems like the patient who has mild to moderate arthritis seems to be a good idea for it. If it's in the knee, typically the arthritis that's femoral tibial, meaning kind of going between the thigh bone and the leg bone, and not patellofemoral, so underneath the kneecap, that seems to respond a little better. And like I said, we're not quite sure. So on top of it, doesn't matter which type of hyaluronic acid you use, meaning, the molecular weight, is it the low molecular weight, high molecular weight, doesn't appear to be predictive as to who's going to respond to that. Not necessarily sure. And there seems to be discordance in data everywhere, like, oh, people responded to this, but not that. And so not quite sure. And on top of that, also data shows that 1 versus 3 injection, they kind of have similar results at 6 months. So once again, we talked about that sequence, right? You do it once, then come back in a week, or do it once, come back in a month, come back in a month. It seems that when you do just 1 injection versus the 3 series, it seems to be similar at 6 months. And so, like I said, I'm not sure if it's the 1, 2, 3 every week or every month. I would imagine if you did it every month, you kind of start the clock and buy yourself some more time. But it seems like if you do the series of, once every week for 3 weeks versus 1 injection, it has similar results. And that's kind of what I've seen as well. And the $1 million question is this chondroprotective, right? We've kind of shown that it's not chondrotoxic, which, hallelujah, praise the Lord, that's great. It's not, but is it chondroprotective? There's been some in vitro and animal studies that show there's some possible chondroprotective effects and report slower disease progression of arthritis. So when you put it in there, disease progresses slower, which is great. And the jury's still out though, because there's not a lot of human data. So like I said, once again, not necessarily sure, but does not appear to be chondrotoxic, which is great, but it's not a magic pill that's going to regenerate anything. In terms of when you get it, people tolerating it, a lot of people tolerate this very, very well. Like I said, there are some avian derivatives, meaning derived from some sort of bird, cell line, things like Hyalgan and Synvisc, and it can potentially produce some sort of like fatigue, weakness, or reaction that seems to be mitigated. They used to be like the older derivatives. It doesn't seem to be as prevalent anymore, but it's possible. Obviously, anytime you do an injection, an infection is always a risk, but it's a small risk. The main risk is kind of a painful inflammatory local reaction. About 2 to 6% of knee injections, there has some sort of local inflammatory reaction. It's not crazy awful. It's not usually some sort of inflammation at the injection site. It's usually early, not too bad, and then transit, so it comes and goes. A much smaller percentage, anywhere from 1 to 2%, have something called a pseudoseptic presentation. Like a septic arthritis is a big thing we worry about. Obviously, any injection we always talk about and counsel about, hey, this is what we look for. We look for, make sure we're not having a septic joint. And you can occasionally have a pseudoseptic presentation, meaning that they have a lot of pain, maybe some redness and swelling that looks a lot like a septic joint. Obviously, it'd be impossible to tell it just by looking at it. So you'd still have to probably go to the emergency department, get that drain, and kind of look at the fluid to figure out what it is. But the one differentiator is usually this happens within 24 hours, which would differentiate from a septic joint, which usually comes on a little bit later over a couple of days. And so something to think about. But once again, if you're like, oh, this only happened in hour 24 as opposed to 48, so it can't be septic, I would never take that risk. Nobody recommends you take that risk when you get that checked out, but that can happen as well. So it's a very small chance of that happening, not very common at all. Overall, well tolerated. And at the end of the day, like I said, how I use this is, once again, we talk to our patients. When you are a patient considering an injection, we'll talk about all the things. Like I said, if you have, in this setting, mild to moderate arthritis, to me, this is starting to move towards the top of my list of something I would try. The more and more I learn about injections, the more and more I read and study, the more I want to protect people's joints as much as possible. I want to do the least amount of damage possible. I want to do the most amount of good for them. So like I said, when I'm comparing steroid versus this, I'm going to probably lean towards this versus steroid. The problem is that steroid injections just feel so good, and people tend to get a really good response to that, but it's short term. And that's why we can hopefully kind of help them understand that longer term, this seems to be better for them. That might be great. But once again, they seem safe, they seem efficacious, and they do not have that chondrotoxicity, so it's a very viable option. Obviously, it depends on what your insurance is going to cover, or if you're paying out of pocket, anything like that. So obviously, there's lots of considerations, but overall, my takeaway would be worth a shot, no pun intended, but it's worth a shot to try if you have it. Like I said, it's relatively efficacious, it's safe. You could probably just do the one series, make sure you get the ones that's made for just the one, and then go from there and see how you do. But that would be my recommendations, and that's kind of how I practice as well. And so today we're talking all about steroid injections. This is our most common injection. It's the oldest type of injection. It's done all the time, but the million-dollar question is, should we be doing it that much? Well, let's dive in today. First, let's talk about the mechanism, right? So this is a strong anti-inflammatory and immunosuppressive agent. Obviously, the doses we're giving at, the main effect, we're not trying to have immunosuppression, but you will have some of that goes on with injection. What the steroid does is it acts on the nuclear steroid receptor, so it goes into the cell, right? Incorporates kind of into the DNA process, making proteins, and essentially it produces things that inhibit inflammation and your immune response. So essentially, you are going to decrease the inflammation and immune cascades. It does this by reducing vascular permeability. It inhibits the accumulation of inflammatory cells and mediators, things like prostaglandins, leukotrienes. It kind of inhibits all those. And like I said before, this is really strong. So what we're doing is kind of just dropping a grenade in to calm things down, meaning a huge amount of things are going to be taken out, right? You can't really specify, hey, when I drop a grenade, I just want this one thing. It's like, no, anything in the radius is going to take it out. And that's kind of how I think about it with steroids. It's a little not quite the same, but that's kind of how I think about it. And I kind of think about it also as like shutting off the water main if there's a problem. So, if you're having a problem with your plumbing, you shut off the water main, everything's going to get shut down. That doesn't mean necessarily fixing the problem, but it's going to probably help temporarily the situation that you're kind of in. So some big side effects we talk about steroids. The first thing we talk about all the time, like we talked about in episode 3, is chondrotoxicity. So we worry that steroids might have a chondrotoxic effect, meaning that it's bad for your cartilage. Obviously, we care a lot about that, so we want to be careful and be judicious with that, but we'll talk all about that later. Another thing that can happen is something called avascular necrosis, which is essentially killing off of the bone cells. And when you have a steroid injection, this can happen to that area. Specifically, we see this in the hip more likely than not. And that's the area that's most likely to have it. As I said, it is rare, but it is possible, and it increases the more you do it. So if you do lots and lots of repeat injections, you have a higher risk there. Obviously, anytime we inject into a joint, there's always a risk for infection, but with a steroid, that's what we always worry about in terms of we're having that immunosuppression. So we're always worried about some sort of joint infection. Huge, big concern. That's the biggest thing we counsel about, right? Like, we do not want this because it can be devastating. Things to look for in terms of like, well, Jordan, I don't know if I have an infection. Well, you'll have things like the joint will be red, hot, swollen. Usually this comes on a few days after the injection, like I said. So if you're looking, you get an injection, and then over the next couple of days, you start getting a huge joint. It's super painful. You get fever, stuff like that. That's not normal. Please go to the emergency department. But that's what we're looking for. And with a steroid, we always worry about that. On top of that, also, you can have some effect with your blood sugar. If you're a diabetic patient, when we inject a steroid, like I said, it's not like we're doing systemically, but some of it does get absorbed throughout your body. So you can have increases in your blood sugar. So like patients who have diabetes, they know that if they take steroids, it raises them. That can happen. So on top of that, we can also have something called a steroid flare. A steroid flare is essentially when you have an increase in pain after the injection. A lot of times this comes on maybe a couple hours after or the next day, and you start having some increased pain. It's not like the worst pain in your life. It's not like you're having all the other things like you have with the septic arthritis or the risk of a joint infection, right? You're not having fevers, chills, anything like that. But you just have more achiness, and just kind of, for some people, it can be a lot more than that. And so you have just increased level of pain, usually right after the injection within the next 24 hours. And that's kind of how we differentiate from an infection. So, but it can happen. Also, you can have some flushing as well. You get facial flushing, so you can get a little red there. If we inject around a tendon, it can weaken that tendon, potentially lead to rupture. Obviously, we care about that. If we're injecting close to the skin, we can have thinning of the skin around the injection site. And on top of that, we can also have lightening of the skin around the injection site. So these are things that I'll counsel about, all these different things. It sounds like really scary when you say that, like, oh my gosh, like why would anybody do this? Like I said, the odds of these things are not very common, especially the big, bad, scary stuff. Not very common that's going to happen. But I want to make sure that every patient I talk to and every patient that I provide care for understands these risks, so that if they do happen, they're like, oh yeah, I remember hearing about that and this is a possibility. And so I just want everyone to be well informed. So Moving on to indications. Like I said, if you go through the literature, if you search long enough, you're pretty much going to find it's used for almost any sort of musculoskeletal problem you can think of, really. Like I said, if you think about it, there's probably a case study showing a steroid injection there. The biggest indication is probably arthritis still. If you look for literature, you can find it used in the toe, ankle, knee, hip, shoulder, wrist, finger, elbow. I mean, you name it, there's probably a joint you can inject it into. In the back, there's lots of back injections as well. So there's lots and lots of areas that we can use it for. Like I said, a lot of times OA is still the big thing. Like I said, I think at the end of the day, we understand what this should be used for, and that's short-term relief, right? And so it's not like there's a lot of debate out there like, oh, like if you get a steroid injection, is it going to like regenerate anything? Like, no, we know that this is used typically for short-term relief. There are some other indications that might get longer response, but typically the way I think of this is that if we're getting a steroid injection, we are buying time for something else, whether that's buying time to do physical therapy more, buying time till we need to get a procedure, like an operation, buying time to get to this event. I don't know, but essentially that's what we're buying time. That's kind of how I think about it. So we're not doing anything other than kind of kicking the can down the road a little bit. Like I said, this is usually not a long-term fix. Occasionally it can be, but usually it's not. So like I said, anybody who gets an injection, I want them to think about, hey, this is something that's going to be a short-term. And so in addition, obviously we know that's chondrotoxic. And so we kind of have to think about, we're giving something that's chondrotoxic, so maybe degrading the joint cartilage. And then we know it's not going to be long lasting. So we really have to consider if a steroid injection is right for someone, right? This is not right for everybody in every situation. It can be used. I still use these quite frequently in the right situation. But like I said, we have to have a good conversation with everyone. They have to understand the risks and benefits. In terms of indication around tendons, there's lots of data looking at tendons, but overall, that doesn't mean it's a good idea just because there's lots and lots of data for it. The big ones they specifically look at are the lateral epicondylopathy, so tennis elbow. We have lots of studies showing that we're probably going to have good short-term improvement with an injection. Like most things, when you get a steroid injection, it calms down and feels good. But pretty much all those improvements are gone by 6 months, and at 12 months, it actually may be worse than just placebo. So if you did nothing, 12 months later, you might actually be worse. Rotator cuff too. A lot of times people say, hey, let's get a rotator cuff injection with steroid. My shoulder's hurting me. Once again, possible short-term benefits, no real long-term benefits. If we move down to the Achilles and plantar or patellar tendon, once again, we see these short-term improvements, but we do not see the long-term ones. And so, like I said, I really, really try to avoid tendons with steroids because, as we know, one of the side effects is we can potentially weaken that tendon. And so if you're coming to me with a tendinopathic tendon, meaning that it's something's going on, we have some sort of pathology in the tendon, and then I inject steroid into it, it's not a good combo because we got a weakened, potentially, tendon already, and then we make it more weak with that. It just makes it more prone to rupture. And so this is something I always have to talk and consult patients on. I'm pretty much never going to do this on a younger athlete, and younger meaning anyone who's still active and really working pretty hard and doing all that stuff. Like, to me, that's just not, the juice is not worth the squeeze. I think we have other better injections for tendon issues. But like I said, some people still get them, and there is a time and place as long as we're counseled appropriately. But man, I'm just really cautious about this. I'm also really cautious about this when we are doing a weight-bearing tendons. So specifically like, quad tendon, patellar tendon, Achilles tendon, like, man, that's just a recipe for that I'm concerned for and I worry about. I think there's other injections we can try, and therapy works really, really, really well. And so these are ones that I'm kind of a little cautious about. So another condition that I can use for is for frozen shoulder, also known as adhesive capsulitis. It seems like an intra-articular steroid injection is a little bit more beneficial than just range of motion activities. So it looks like there's some benefit there. That's a very challenging condition to treat, and so sometimes we can do that. Another indication that we're moving on here, talking about trigger finger, and this is actually like one of the few times where I'd actually consider a steroid injection first line. Like, first line means like not the first thing you walk through the door. If you have a trigger finger, I'm going to immediately do that. There's always other things we can do like splinting and occupational therapy, that. But like I said, this is not one where I'm like, hey, we really have to try everything before we do a steroid injection, because the data is pretty decent that it works really well. About 50% of people get a cure with the first injection of their trigger finger. So like I said, 50-50, that's pretty darn good in terms of getting a cure lasting a long time. Like I said, that is not the case for arthritis. It's not like we're injecting in your knee with arthritis and getting a cure. That's not happening. So we get 50% on the first injection. That's pretty good. And then about 70-90% have a cure after more than one treatment. Like I said, and with follow-up in these studies I looked at, were anywhere from 18 to 44 months. And so, like I said, this is not necessarily curative forever, although that can be the case sometimes. But in terms of kicking the can 18 to 44 months down the road, like, holy cow, that's a really, really good improvement. And that's something that I would definitely consider for most people. So Like I said, and by the way, if you hear thunder, I apologize, but can't control the weather. And so trigger finger, one I think about too. Another one that I think about that I will do quite frequently is de Quervain's tenosynovitis. So this is in your wrist. This is the first dorsal compartment, essentially inflammation of that tendon sheath, sometimes known as mommy's wrist. A lot of times we see this in postpartum women who are now breastfeeding, carrying their baby all the time. They hurt it just right on the dorsal side of the wrist. Very, very common. Like I said, it's an injection where I will do steroid pretty quickly because there's pretty good data that it works and that it works for a long time. And like I said, that's kind of my threshold. If I think, hey, this is going to work for quite some time, then I'm like, hey, I'm good to go. Let's try this. Whereas if I say, oh, like this will, give you a couple months, then like I said, we'll talk about things. But like I said, these are ones, the trigger finger and de Quervain's, that I'm like, oh, let's absolutely do this. Another indication we can talk about is carpal tunnel syndrome. So like I said, it is efficacious for this when you get this injection. Like I said, may be able to potentially delay surgery. Sometimes, in some cases, found that they actually didn't need to have surgery after having steroid injections. And once again, there are other options as well for carpal tunnel injections, but steroids seem to be pretty beneficial for that. And obviously, it's not like I'm just repeating this all the time. We're going to have conversations, right? We'll talk more about each condition if we want to in future podcasts, but my theory is never like just keep injecting. We always have an exit plan, right? Like if we're having to do that over and over, then we're probably talking to a surgeon about a carpal tunnel release. Once again, may be effective in carpal tunnel as well, which I've had good success with. And on top of that, like I said, it's always going to be a personalized choice, like we've talked about. But like I said, those are kind of conditions. The general idea is if we're going for like arthritis type things or just aches and pains, usually we're not going to get long-term from it. Things like trigger finger, de Quervain, we actually might. And then carpal tunnel seems to be effective as well. Like I said, and you can go find steroids for literally everything. I mean, just think about a condition in the body. There's probably been a steroid injection done there. So like I said, there's lots and lots of data on it, but those are like the main use cases that I do in my practice and that I see in the literature. And so moving on to our dosing, we talk about what's a typical dose of the steroid. Well, here's the problem. There's no standard. It's a huge problem. There's so many formulations, right? There's so many forms of steroids, things like betamethasone, triamcinolone, dexamethasone, and each one comes with varying dosing. So we don't really seem to have a general consensus. And also there's no real rhyme or reason for it. Like I said, people will inject what they know, right? I've seen some people write notes saying, hey, I injected 80 milligrams of triamcinolone, which is quite a bit. It's like 2 big vials, so 2 cc's usually, which is a lot of steroid. And we've seen in a lot of the data that the more steroid you inject, the more effects you have in terms of like the chondrotoxicity and the weakening of the tendon. So like when we're injecting more, yeah, it's probably gonna be a little more powerful from an anti-inflammatory perspective, but it's also gonna be more powerful in terms of like weakening things. And so, like I said, you'll see a wide variety of who does what. And unfortunately, a lot of it's just like institutional knowledge. It's like, oh, this is how I train. This is what I do. And that's not a great way for why we do things, that we shouldn't be doing it that way. But unfortunately, that is the way sports medicine kind of is sometimes. And so trying to understand, standardization, that would be a huge problem, but we're working on it. And it's like I said, just very difficult. So once again, my overall take for steroids is, like I said, we have to understand the typical results and the mechanism of steroid. Like I said, our typical results gives us a little bit of time, improvement, and eventually comes back. And then the mechanism of steroid is going to be, like I said, short term. We're decreasing inflammation, but also immunosuppression, so we have to understand that. Typically, when I think about this is used as a stopgap, temporary stopgap, not a long-term fix. And we have to counsel our patients appropriately. So I'm going to talk to everyone and say, hey, this is not fixing anything, but I might calm things down. Like I say, a very use case, very common thing that I'll say is, hey, we're just really angry, right? Like something's flared up and, they're just like, I can't like do anything. It hurts so bad. Like this is one where I was like, okay, like it's reasonable to get an injection. We talk about it, talk about the risk benefits, understand, hey, this is a bridge to get you going. This is kind of the analogy I talk with patients all the time. I ask them if they're from the north or the south here in America, because it kind of helps change the analogy. So if they're from the north, like I am initially, I say, have you ever been stuck in the snow before? And most people say, yeah, I've been stuck in the snow before. Everyone knows that when you're stuck in the snow, you're hammering down the gas pedal and your wheels are just spinning. And all it takes is a friend to come up behind you, give you a little push, and then you get out and you're good to go. That being said, did that push do everything? Well, no. The vast majority of the work was done by the car, right? We just need that little push. That's how I explain physical therapy and injections, with physical therapy being the car and injections being your friend coming to push you out, right? So the car does most of the work. Physical therapy does most of the work most of the time when we're getting better from injuries. And every once in a while, we just need a little push, right, from our friend, or in this instance, a steroid, to kind of help get us in the right direction. Because sometimes we kind of stall out. People are on therapy. They're not quite getting there. They're just really sensitive and really kind of just flaring up. We put a little steroid in there that calms things down. It helps them progress better. Then they move past that plateau. That's like my ideal use for steroids. Can definitely do that. Like I said, I think it's very reasonable. How often you're doing that, that's another question. If you shouldn't be doing that a bunch of different times, but it's something to consider as well. So like I said, overall though, the biggest things I'm going to recommend in terms of, hey, like I'll pull this before other things is things like trigger finger to quercetin tenosynovitis. Those are the two where I'm like, okay, I think it's pretty darn reasonable. Everything else have risk and benefit discussions. Like I said, they're not unreasonable for most things, but those are the ones where I'm like, I think we'll get really good effect, and I haven't seen amazing results in other things. So like I said, I'm not eager to inject steroids on anybody, but we will if it's right for the right situation for the patient. And once again, everyone's different, and everyone deserves kind of a thorough discussion and understanding of the risks and benefits, and that's kind of how I approach this. So today we're talking all about NSAIDs, or non-steroidal anti-inflammatory drugs. So we're going to talk all about these injections more specifically. So we're not talking about the oral medication, but talking about these injections. So we're going to talk about things like the pharmacokinetics, the chondrotoxicity, when to use them, what my thoughts are, all about that. So let's dive in right now. So first, let's talk about pharmacokinetics, right? So pharmacokinetics is a fancy word for essentially how these drugs are metabolized in our body, right? So pharmaco meaning, the medication, kinetics, and how it works, and so how it moves. And so this is talking about stuff like half-life and bioavailability, all this fancy stuff. But all it's really saying is, hey, when we take this medication, how does it work? And so first, let's break down the root word, NSAIDs. That is non-steroidal anti-inflammatory drugs. So we've talked about steroids, right? We talked all about that last time. These are non-steroidal, so there's a different mechanism for how they work. What they do is they prevent the conversion of arachidonic acid into things called prostacyclins, prostaglandins, and thromboxanes. So we are inhibiting these being made, and they're done so by inhibiting the cyclooxygenase pathway, or the COX pathway. Like I said, sorry this sounds a little deep, but we're just helping differentiate why we choose one injection versus another and what the mechanism is. So once again, when we are on these NSAIDs, we're trying to inhibit the pro-inflammatory things like the prostaglandins, prostacyclins, and thromboxanes. And we do that by inhibiting this COX pathway. And it's not just one simple enzyme. There's actually two main enzymes, COX-1 and COX-2. There are others, but those are the main ones. And the different medications we have, some are more specific to which COX they inhibit at the end of the day. So like I said, the COX-1 inhibitors that we think more like in terms of hit those receptors are the ones like diclofenac, naproxen, aspirin, ibuprofen. So our most common NSAIDs. They'll do both actually. Like they'll inhibit 1 and 2. Like I said, it's not specific, but the reason why we talk about these thinking about 1 is because the other COX-2 inhibitors that are more selective do predominantly only COX-2. So like I said, you are going to get 1 and 2 with the common ones like ibuprofen, naproxen, diclofenac, all that. But then when we talk about COX-2 ones that are more selective, we're talking about celecoxib and meloxicam. These are more likely to inhibit COX-2. Once again, we will also have some COX-1 inhibition as well, but it's actually like they're 50 times more preferential for COX-2. So like for every one COX-1 that's being inhibited, 50 COX-2 are being inhibited. So once again, that is why they're more COX-2 selective. Those are not as common, in terms of going over and getting those, picking up at the pharmacy by over the counter. Not going to find those necessarily. Whereas all the, ibuprofen and whatnot you'll find there. So the question you might be asking is like, well, Jordan, this is super nerdy and boring. Why do I care about this? Well, we care about it because specifically COX-1 is expressed everywhere pretty much throughout the body. So kind of all over. The things we really worry about is they're expressed in like the gastric mucosa, so the lining of our stomach, and our kidneys and other places as well. And so, like I said, we have some spots there where it can lead to issues, and we'll talk about those. The reason we care about COX-2 inhibition only is because it's limited to fewer tissues. It's not as diffuse as COX-1. And like I said, and COX-2 is usually increased, the expression is increased during inflammatory processes. So when we're having inflammation going on in our body, we have, an increase in COX-2. And so if we are just selectively going for COX-2, we're saying, okay, we're not going as widespread in the body. We're maybe not hitting the gastric mucosa, maybe not hitting the kidneys as much, and we're going directly for the inflammation. Like that sounds like a win-win. Like I said, we care so much because if we continually take NSAIDs, even with injection form, like I said, but this is more, the data is more on the oral forms, but if we take NSAIDs over and over, we can have irritation of our stomach. It can lead to ulcers. We can also be hard on our kidneys, can lead to kidney injuries. And so we care about that because, man, that's not a good thing to have. We don't want to be taking one medication and create more problems. And so that's what we worry about. And that's why when we have that COX-2 selective ones, we're hopefully decreasing the side effects that we have, and then also focusing on the pro-inflammatory COX pathway that's known to happen during inflammation. We're trying to block that as well. So we'll also talk about the half-life during pharmacokinetics. Half-life is essentially how long it takes till about half the medication is gone in your system. And so specifically, we're looking at, what they look like from injection versus oral form, right? So ibuprofen, half-life's about 1 to 2 hours, right? So how do all this compare though with when you take it by mouth or when you inject it? So like I said, about 1 to 2 hours normally, that's fine. If we look at the bioavailability, meaning how much that's available, it's actually pretty similar between an intramuscular injection and an oral pill. So there's about 90 to 100% availability. So like I said, it's pretty much the same with oral or with an intramuscular. Like I said, that being said, about 25 to 50% of that bioavailable medication is found in the synovial fluid. So let's take a step back here. If we're getting some sort of NSAID by either an oral pill, so we take some ibuprofen, or an injection intramuscularly, like I said, the bioavailability is about the same. That's going to be good. But of that bioavailability, only about 25 to 50% of that concentration that's available is found in the synovial fluid. So what we're saying is, the medication we're taking, we're not seeing nearly as much in the synovial fluid, but that's pretty normal because it's not as widespread, right? It's not that close to the blood supply, and that kind of makes sense. And so what about topical NSAIDs as well, right? We have topical NSAIDs, thing called, it's a diclofenac gel. Usually you can buy it over the counter now. This also is an option for us because it has less systemic exposure. So we talked about before that percentages, right? There seems to be only about 6% of that concentration is absorbed systemically by these topical ones. And then on top of that though, we actually have an increased percentage in the synovial fluid. So overall systemically absorbing only about 6%, but inside the synovial fluid that we sample, about 50 to 80% of that concentration is seen. So it might be like a lot of words, like what's going on? What I'm saying, just to reiterate here, kind of going back and forth, is take oral or you take into the muscle, their bioavailability, really good. It's going to get there, but you're not going to have nearly as much in the joint. You do topical, you're going to have less systemic absorption, so less without throughout the rest of your body and at other sites, but you're going to have more in the fluid at the joint that you're putting it at. So like I said, that's kind of where we're looking at. And it's like an overall, like I said, if we kind of take a step back, 10,000 foot view, the exposure of NSAIDs is similar between if you give it in your muscle, if you get it in IV, if you take it orally, and so there's all those different factors. And what about though if we inject it into the joint? Well, into the joint's a little bit different. We do see about a 2 to 3-fold increase in the maximal synovial concentration compared to oral for a one-time dose. So if you're saying, hey, I'm comparing a one-time injection of a non-steroidal medication versus, hey, a one-time dose of oral NSAIDs, you're going to see a 2 to 3 higher increase inside the synovial fluid. So like I said, we're going to see more, which makes sense, right? If we're injecting into a joint, we're probably going to see a higher concentration there. So that's what we expected. But here's the big caveat. So we have 2 to 3 when it's only one for oral or one for intra-articular. But if you take oral NSAIDs for about a week, which is a pretty standard way of doing it, right? You say, hey, let's take this for a week, kind of calm things down. So let's take it for a week. The dosing there would actually produce 10 times more synovial concentration compared to the one-time injection, which kind of sounds not intuitive. But like I said, if you do an oral one for a week, the concentration is going to build up enough where we actually have more concentration exposure to the joint than just a one-time injection. And so once again, I do want to make sure that I'm cautious in saying that just because we find a higher concentration inside of the joint does not necessarily mean it's going to be more efficacious, right? Doesn't mean it's going to work better necessarily. But that being said, we're talking all about, are we getting this? And so that's just something to think about. One dose versus one dose seems to be less in the joint with orals, but then if you give it for a week straight after just that one injection, if a week of orals is probably going to lead to a higher concentration. But that being said, I also want to mention that systemic absorption, right? So these NSAIDs, if you inject it in the joint, is it just going to stay in the joint? No, that's not true either. There's about 80% of bioavailability that we find, or kind of 80% concentration inside the systemic blood system. So once again, if you inject it into the joint, you're still gonna get it systemically. So it's not just gonna stay in one spot. And so like I said, all the side effects that you could have from any other NSAID also still applies to an intra-articular injection, which seems weird, but like I said, that seems to be what the data shows. And then I also want to touch on chondrotoxicity. So we've talked about this before, had a whole different podcast about this, but chondrotoxicity meaning damage to the cartilage inside the joint. Are these chondrotoxic? We know steroids are chondrotoxic, right? We've talked about that. And so are NSAIDs? Well, there's some studies. Let's look at oral NSAIDs first. There's some studies showing there's an association between oral NSAID and the medial joint space loss when comparing on X-ray, right? So it took a study where they said, hey, we're going to put these people on some oral steroids for a pretty prolonged time, and they're going to repeat X-rays and see what happens. And they found that there seemed to be a decrease in the joint space of the knee. So saying, hey, if we see decreased joint space in the knee, that means the cartilage must be getting worn away. So that's what we're kind of saying might be happening there. But the question for that is, are we capturing the people who use them because they have worse disease to begin with? So like, is it the NSAIDs actually causing it, or do they have a worse disease, therefore causing them to take NSAIDs more, right? And then there, because of that, we see progression of the arthritis. So it's not necessarily clear, but like I said, there's some association with it, and I just want to talk about that. And then from an intra-articular perspective, there is a positive research. There's not a lot of research saying, hey, does intra-articular NSAIDs lead to chondrotoxicity? There was one study that showed that single doses of Toradol did show significant in vitro chondrotoxicity, right? So once again, we talk about how those work. We kind of take out some usually cartilage cells from a surgery they're doing, put it in a petri dish, kind of simulate the environment of a normal joint. And then from there, they inject different medications, and they did seem to have an increase in chondrotoxicity when we inject Toradol. So overall, it appears like there might be some chondrotoxicity, although the data is not as robust, right, as steroids. And so there's just a lot less research. So it's hard to make heads or tails of anything. So when I kind of think about it, right, I think that this is a lesser known, right? There's not as much study, but it potentially doesn't seem to be as slam dunk. And so it might be an option where it's less chondrotoxic than steroids, but we're not quite sure. I can't confidently say that at this time. And so now we're going to talk about, hey, how do these compare to NSAIDs or to steroids? I'm sorry. So we have our NSAIDs, right? And then our steroids. Under that umbrella of anti-inflammatory injections, we have steroids, we have NSAIDs. How do they compare? Well, like I said, once again, the theme here is there's just not a lot of data, unfortunately. Like, holy cow, I was looking through this, expecting to be pretty robust, and it is not. There's not a lot. There's some studies here and there looking at things, but not a lot, which is very unfortunate. But one I did find was looking at hip osteoarthritis. So we looked at steroids versus NSAIDs in the hips. The dosing they were looking at was 40 milligrams of triamcinolone versus 30 milligrams of Toradol, which are both pretty standard dosing. I mean, essentially, usually triamcinolone comes in 40 milligram concentration. So 1 cc is usually 40 milligrams versus Toradol, 1 cc is usually 30 milligrams. So pretty standard dosing there. What they're looking for is that both treatment groups were successful. So there were successful treatment groups, and they were not significantly different in their outcomes at 1, 3, and 6 months. And like I said, and usually these outcomes are pain and function. And, they said about 70% of people had improvement at 1 month, 52 to 56 at 3 months, and then 41 to 46% of people had improvement at 6 months. And so overall, though, greater than 50% of people had improvement in pain, and greater than 20% had improvement in function at 6 months. And so once again, very similar results, though. And so, like I said, though, one reason I consider this as a kind of a worthwhile study is because we know, like I said, the chondrotoxicity of steroids, and there's actually some concern that when we go specifically in the hip, we tend to have an increased risk of avascular necrosis or breaking down of that bone a lot faster. And so if we can do an NSAID, which may not be as chondrotoxic potentially, that might be an option, which would be kind of cool. But like I said, we know that steroids in the hip are kind of a high risk procedure occasionally, especially if we repeat them over and over again. And so, like I said, it's not necessarily at the one-time dose, but repeat dose is really when we worry. But like I said, it's an option to have something there. So you might be picking, a lesser of two evils potentially by doing an NSAID. So then let's talk about knee osteoarthritis, right? So once again, looking at steroids versus NSAIDs at knee arthritis. Once again, not a lot of studies. I'm shocked. I was actually shocked that there wasn't a direct comparison of NSAIDs versus steroids, but that's what it is. They kind of had a different design where they had viscosupplementation used with either a steroid or NSAID, right? So we talked about the hyaluronic acid derivative injections. So they did that injection with either a steroid or an NSAID, and then they did that once every week for 3 weeks is what it was. And at the end of the day, there was no difference in pain or functional outcomes when compared at 3 months. And so not a whole lot of data going on there. Once again, doesn't seem to be substantially worse than an NSAID anything. And once again, no direct comparisons, which I thought was generally shocking. There was also one study that kind of showed similar efficacy looking at oral tenoxicam versus intra-articular. So they're saying, hey, if you take oral medication, so oral NSAIDs, which tenoxicam is not a very common NSAID, so I don't know how translatable this is, but studies showing that if you take oral tenoxicam versus an intra-articular injection, which the injection was each week for 3 weeks, said at the end of the day, the takeaway was that they had similar results, which meaning that they had, similar pain and functional outcomes, and maybe had some less systemic effects with the intra-articular injection as opposed to 3 weeks of steroids, but that's something to consider as well. Once again, should we be doing intra-articular or should we be doing oral? It's a really good question. Also, talking about trigger finger next, there is a couple articles on trigger finger. There's actually a Cochrane review on that enough, which, like I said, Cochrane review is usually like, whoa, lots and lots of stuff, but it was just a couple articles they looked at. But I was excited about that. I thought this is pretty dope to have a Cochrane review on intra-articular. It's a subsection of trigger finger general treatment, but hey, I'll take it. And they looked at NSAIDs for trigger finger and then looked at it specifically for injections. And they showed by 24 weeks, results from 2 different trials show that NSAIDs offered little to no benefit when compared to steroids. No real difference in resolution of symptoms, recurrence, total active motion, residual pain, patient-determined success, or adverse outcome. So essentially about equal, which, the way you look at it, you could say, oh, it's no better than steroids, or you could say, hey, it's just as good as steroids, kind of depending on what lens you're coming with there. So this is kind of how I approach this, right? So you're saying, oh, well, Jordan, that was once again, a really depressing episode. There's not a whole lot of takeaway there. And once again, I'm just bringing, don't shoot the messenger. I'm just bringing up what I see in the literature. And like I said, I think it's a call for more literature in the sports medicine community. But like I said, I'm very thankful for what we do have and the people working really hard. But like I said, sometimes we do the things that we do, and are they evidence-based? I'm not sure. And that's why I'm trying to dig to the bottom and figure it out. So how do I approach this? Like I said, there's actually no FDA approved indication for toroidal arthritis, which is kind of shocking. Steroid is approved, but we're essentially using everything off label. So we kind of have to be aware about that. Like I said, I do think it is reasonable to use these. I think there's enough data showing that, hey, they seem to be safe. So I don't think it's a dangerous experimental injection by any sense of the imagination. But like I said, the evidence base on this is not very high. We are not just going to be sitting on mountains and mountains of evidence to defend what we do. And so we're kind of going off in the weeds a little bit here. But like I said, we do have some rationale and some evidence base for like why we do the things we do. And you have to have a rationale for why you do things, right? So I do think it is reasonable to use this in place of a steroid injection, right? The way I think of this is a potentially quote unquote less bad option. Like I said, I do not have enough data to say this is definitely better in terms of chondrotoxicity. Like I said, but multiple different studies have shown that, hey, it does not seem to be inferior to steroids for certain things, like, short-term outcomes for arthritis. And so it is reasonable to do that if someone has a contraindication to a steroid, right? So we're going to use steroids and NSAIDs pretty much for the same reason, right? We're just trying to get temporary pain relief. And so that's kind of what we're thinking about. When we use these with that frame and that lens of mind, it's okay to kind of use them as needed. And once again, we're going to use our brains here, right? We're going to talk with our patients. We're going to talk with your doctor. We're going to do that, try to figure out what is the best option for you. And one thing I want to talk about too is who shouldn't get one. Well, I think if you have a history of heart disease, right? Cardiac history, NSAIDs are usually not a good idea. If you have a bleeding history of kidney issues like chronic kidney disease, or history of ulcers, I would probably stay away from these injections. Like I said, NSAIDs still have that systemic effect, can have issues with that. It is a one-time injection, so not nearly as problematic as if you're taking oral NSAIDs every day. But like I said, something to steer away from. And so my practice, how do I use these? Once again, like I said, I kind of use these as an adjunct or an alternative to steroids. So let's say someone, maybe steroids doesn't seem like a good idea. Like they're super young, and we're worried about, hey, we want to make sure that the cartilage is preserved as much as possible. We know steroids are bad, right? We do not know that NSAIDs are necessarily better by any stretch, but like we don't have any data saying they're worse from that perspective. And so it's one of those things that might be the better of two bad things. I'm not sure. But once again, we're doing it for the same reason that we are just trying to get temporary relief to allow someone to get back to do what they want to do. This is not a long-term fix for pretty much anything. And so we have to consider that always. On top of that, maybe I'll use someone when I think a steroid is contraindicated, someone who's having poorly controlled blood sugars, right? That might be an issue, or someone who has, some other reason for they don't want to get steroids. And so this is something I would think about. Like I said, we're going to still use it from the same lens. If we're choosing between anti-inflammatories, then this is the option that we're going to choose. And so just something to think about. So like I said, that's kind of how I've used these. This is the literature that I've seen. Not very impressive literature, but like I said, I just want to share that with everybody so we can kind of make some more informed decisions. Today, we're talking all about prolotherapy injections. Now, these are kind of a more niche injection that aren't as widely known as steroid injections, but there's a really couple good use cases for them. We're going to talk about the definitions today, the mechanism, when we use them, how we use them, so all that stuff. So let's dive right in. First, let's have a definition, right? So a definition of prolotherapy is an injection of an irritant into a joint space, tendon, ligament, or soft tissue structure as means of improving pain. So like I said, that's kind of a generic catch-all of everything. But what we're doing is we're putting in an injection of something in your body that your body's going to recognize as an irritant and then try to stir things up. So the whole idea behind this is we're putting something that's going to irritate that tendon, joint space, structure, whatever it is. We're trying to irritate it so that your body says, hey, what is that? Something's going on here. Let's put in some work and try to get this to calm down. And so that's the whole idea behind that. We're trying to stir it up. In terms of how it works, we're not entirely sure on that at all. It's up for debate. Like I said, there's lots of literature about like why we might think it may work or some ideas. There's a couple of ideas, and some main ones we talk about. It might be chemical trauma, mechanical trauma, or nerve involvement. So we're going to break each one of those down. So we're talking about chemical trauma, mechanical trauma, and nerve involvement. So from a chemical trauma perspective, right, we are injecting something. Typically, it's dextrose. This is the most common prolotherapy. There's been some older studies using various other things, but right now, I'd say dextrose prolotherapy is probably the biggest injection, injectate that is being used. And what the idea is behind this is, dextrose, which is essentially sugar. This dextrose gets transported via GLUT1 or 4 channels in the cells. So if we go back to like carbohydrate metabolism, like how glucose is taken up by cells, these are these GLUT transporters, and these GLUT transporters take this dextrose into these cells, in the area around the injection, right? So let's say we inject in the knee joint, the tissues and the cells around the knee joint start absorbing this dextrose, right? So what this might happen is this leads to an osmotic effect, which increases the release of water and lipids from nearby cells, and then essentially creates low-grade inflammation in the area, right? So we are, once again, sugar's getting taken in by the cells. Cells are like, whoa, what's going on? They kind of produce all these lipids and some inflammation. And then what that low-grade inflammation locally does, this produces cytokines and activates fibroblasts, chondrocytes, and nerve cells. So like what that means is essentially step 1, injectate, right? So something that's stirring it up. Step 2 is that then we say, oh, like this is kind of going on. They kind of create some low level inflammation, and then your body ramps up and says, okay, well, let's bring in the big guns. We're bringing in some cytokines, fibroblasts, chondrocytes. So fibroblasts are responsible for, creating growth factors. Chondrocytes important for making, cartilage and whatnot. And so like I said, it's kind of just trying to stimulate all these things there, trying to irritate it, saying, hey, something's going on and we need, to bring in the reserves. It's almost like we're triggering an immune response. It's not an immune reaction. I want to be clear on that. It's not like, hey, this is a foreign immune response, but essentially your body recognizes something's foreign, right? And that's essentially what's happening here is that, hey, like something's going on, and then your body produces inflammation because that's the best way it knows how to handle anything. Hey, there's an irritant, boom, inflammation. It just brings everything around to trying to get it better. Like I said, it's not as specific as, hey, brings this one thing, but your body's really good, like an on-off switch. Like on, hey, there's trauma here, something's going on. Let's get some help. And that's essentially what they're doing. There's been studies showing that a 12.5% dextrose solution is kind of, the area where we start to see inflammation or not, meaning if it's below that, we tend to not have the inflammatory response. If it's above that, we tend to see that. One study showed that a 12.5% dextrose solution triggered chondrogenesis, which is chondrogenesis essentially ramping up of the cartilage cells, which is pretty cool. Like I said, that has not been reproduced a ton of times, and that's just kind of mechanistically. So I'm not saying if you get prolotherapy injection, you are going to increase your cartilage back. But like I said, that's kind of the idea, is that we're putting in this irritant, so this higher concentration of dextrose to kind of create this inflammatory response. That is chemical trauma, right? So mechanical trauma now, this is going hand in hand with that injection, right? So anytime we're bringing a needle into the area to drop off the injectate, we're going to do some mechanical trauma as well, right? We did the chemical by injecting what we had in there, and now mechanical is like, well, you're rubbing a needle on there, it's going to cause that. But a lot of times with this injection, we'll also have additional needling. So we'll do direct needling with the needle kind of going multiple passes through the area just to kind of irritate it specifically. And the idea is that when we do that, it may stimulate repair by releasing certain healing factors, things like gene-related protein, bradykinin, prostaglandins, once again, just releasing all this good stuff. And so the idea is that we get chemical and mechanical trauma together to essentially just make whatever area we're going at really angry. And that's like the big thing. That's why this falls under that pro-inflammatory injections that we talked about before, in terms of this is essentially kind of making it angry and it's not going to feel great, but that's the whole intended mechanism behind it, right? And then we also have nerve involvement, right? So like when you might be saying like, well, nerve involvement, how does that make sense? Well, we're not entirely sure, but sometimes the way we kind of been seeing here, the prolotherapy may actually activate pain receptors and then down-regulate them via things like substance P and CGRP and nitric oxide. And so the idea is that for whatever reason, this dextrose, this foreign substance, kind of might actually down-regulate our nerve responses. So that might be why we get some of the pain response from these. Once again, these are all theoretical. Nothing is set in stone in terms of prolotherapy literature. It's not the most robust thing in the world. So there are a decent amount of studies, but if anyone says they completely understand the mechanism of this, they're probably lying. But the general idea is we're creating chemical and mechanical trauma to then bring up inflammation and healing factors and trying to just help your body augment its natural healing response. And there's also been some literature kind of saying, hey, could it possibly strengthen or tighten tendons? Like that is very not clear at all in terms of, it's pretty far-fetched in terms of the data doesn't necessarily support that. There's some data that say that may or may not, like I said, but I'm not thinking there's gonna be some magical property. But once again, what we might be doing is augmenting the structures in the area and creating this inflammatory response. Then we see kind of that tightening of the tendons there as well. So moving on to that, what we want to talk about is the different techniques, right? So there are various techniques and protocols. If you see one person do this, you've probably seen one person do this. This, like I said, it's not the most widespread injection. And so it's kind of like who you've learned from, right? So like these disciples of this program do it this way, and you learned here, so you do something different. So Just something to consider. Everyone's going to do a little different. At the end of the day, usually the injections are around 10 to 25% solution most of the time. That can vary, obviously, depending on different use cases, and we'll talk about that later, but about 10 to 25%. A very common thing is you mix in a 1-to-1 ratio of D50, so you get one of those vials of D50 that you use for when you have hypoglycemia in the hospital. Mix that with lidocaine or saline or what have you, whatever combo you want, and then you dilute that down so it becomes a 25% solution, right? So we go from that D50 down to the D25. Can also dilute all the way down to a D12.5, 10, all these random things. So that being said, and then obviously on top of this, we are injecting with a needle. So the needle is combined with this and commonly used as an irritant. There's a technique called peppering, where essentially you take the needle, get down to the bone, and just hammer away with the needle. So you make multiple passes in and out. You're touching the bone. Usually we do this with lidocaine. So as we're going, we're putting lidocaine so it becomes numb and you just feel pressure. But that's kind of what we call peppering. And a lot of times that's at origins of tendons or insertions of tendons. Meaning when I say just to the bone, not just randomly go into the bone, but there are some people that do that in different protocols around the knee, like I said, but that is one idea is peppering, where we're essentially really doubling down on that mechanical trauma and just going there with the needle, multiple passes and whatnot. In terms of timing of this, also it's usually done in a series of injections. So not a one and done. So like a lot of the injections we talked about before are, hey, you get one, you come back in whatever, how many months, 3 to 6 months or a year, whatever you need. This one is usually in a series. The idea is that we're going to probably inject this, anger things up, things will start to calm down, and just as it's starting to get back to normal, we re-anger it again. And so usually we bring it back for 2, 3, 4 type of injections, and a lot of times it's in a series, and bringing it back anywhere from every 3 to 6 kind of weeks is how we go. So a typical protocol for me, just because we're booking out a little bit, will be, hey, we'll get you doing this and we'll get you back in 4 to 6 weeks depending on clinic availability. But like I said, once it starts to kind of calm down, we'll re-trigger things to kind of get going. So usually we try to give a couple, and like I said, it's not torture when we do these. We do the peppering, but like the needles are usually not too big, so it's not like we're going in necessarily with a huge needle. But that being said, if we are going with a big needle, we'll try to get some lidocaine or an anesthetic there because we're not trying to torture anybody. But that's the general idea for tendon stuff, right? So that's tendon stuff. Other injections, you can use it for arthritis of the knee. You can just inject it like normal, right? So you go into the joint space, inject it, bada bing, bada boom, you're done. But this is like kind of the unique one I wanted to talk about, was this fenestration and kind of peppering and this kind of needle tenotomy is what it's called. When we talk about patient considerations, risks, benefits, all that stuff. Risks are like any other injection, right? Pain, bleeding, risk of infection, could have damage to a nearby structure. But the new thing is kind of we could have some nerve irritation from a chemical agent. So that dextrose can sometimes be irritating. And once again, when we are doing this injection, it is never just a standalone treatment. It's always with PT, kind of get stuff going, make sure we're getting the body moving, be strong, kind of working on therapy and an end goal there. So it's not a standalone injection as well. In terms of literature, we're going to talk about this. There's not a ton of data. There's lots of small sample sizes. And at the end of the day, though, the big buckets it kind of falls into are tendons and osteoarthritis. So the most data that we have is either for tendons or osteoarthritis. For tendons, overall, it seems to be beneficial for many different tendons. The best data is usually on lateral epicondylopathy, or tennis elbow we call, rotator cuff tendinopathy, Achilles tendinopathy, and then also kind of group plantar fasciopathy into that as well. It's not a per se tendon, but that's kind of where it goes in as well. So like I said, those are the most studied ones, but the general idea, and a lot of times what we do is we extract this idea that, hey, you're having this tendon issue here, let's try it there. Obviously, lateral epicondylopathy is common, but it doesn't mean we can't try it on the medial, right? It's still the same idea that, hey, we have an inflamed, irritated tendon on the medial side as opposed to lateral, we could try it there. So like I said, it's really endless. Wherever there's a tendon, we could try it, but that's where the most data is really. On top of that, for OA, there's some decent data on hands and some data on knee as well. Both, these have had solid outcomes, just not a ton of data on those, but like I said, it's a reasonable thing to try. From a injection mechanism perspective, this is one of those ones where are we getting that pain and those nerve fibers kind of decreasing their sensitivities? That's what's happening. Is that why we're having any effect at all with OA? Because it doesn't really make sense. Like, hey, I just put sugar in the knee. Why would it, I'm not doing anything in terms of irritating, but the idea is maybe, hey, we're creating irritation. It's bringing some healing factors. Maybe we're desensitizing the nerves a little bit. Once again, mechanism's not sure, but it seems to work and it has some decent data on it. There's also a decent amount of studies on low back pain, so what we call, quote, non-specific low back pain, which is back pain we can't truly identify where it's coming from. They're kind of mixed results on that in terms of where they're injecting and what they're doing. There's just a lot of heterogeneity in the data itself, so it's difficult to necessarily know. It seems like, though, the best use case seems to be SI joint injections. So the sacroiliac joint, we can have sometimes pain there, and sometimes prolotherapy injections can be helpful. So I want to talk about a couple comparisons as well in terms of prolo versus random things. So there are, various studies looking at prolo versus saline, right? And so a lot of times for saline, it did seem there's some slight improvements at 6 months to a year with prolo versus saline. And that's like always my always the funniest thing that I think is we look at these studies and look at this injection versus that injection, or this injection versus saline. It's like, and saline still gets benefit for a lot of patients. So that's one of those things, like, we clearly don't understand completely what's going on there. Anyone who says like, hey, we're doing this because we don't understand completely, like, they're lying. There's no way. Because like, we can inject saline in the knee and people get benefits from it. And that's like, I'm not saying that's wrong. Obviously, if you're injecting saline, not telling your patient and telling it something else, that is ethically, questionable for sure. But that being said, like, it seems like just by injecting something into various knees or tendons or whatnot, like, people get benefit. It's essentially a placebo effect potentially, but there may be something to actually just causing irritation inside the knee. I'm not sure, but long story short, it seems like at 6 months of the year, Prolo is a little bit better. When they compared Prolo versus exercise, both seem to help. So that's important there. Hey, if exercise is still really good for you, but Prolo also seems to help. And Prolo seems a little better at 1 month to 12 months, but not necessarily right away. So like the first couple weeks, that seems to be a common theme, is that like prolotherapy is not going to make you feel awesome. Like if you do get a steroid injection and then check like a week or two later, like they're probably gonna be feeling better. Prolotherapy, that may not be the case. And so that's why we usually give this a series in sequence. I've had people come back to me at like 4 weeks and say, it's not doing anything. I say, okay, let's give it a try. Let's give it one more. And then they have really good benefit from it. So it kind of goes hit or miss there for everyone. But like I said, one thing I will constantly say is like, hey, I don't expect this to be awesome right away. That's not what I expect at all. And so when we're talking about Prolo versus PRP, so Prolo versus PRP, there's similar kind of results there. No significant difference at 6 or 12 months. And so that can be also kind of considered a good thing. Obviously, PRP is super expensive, and obviously it all depends on the use case, right? So some studies will show it's inferior in this case and better. Like just overview here, I'm not breaking down specific studies, seems to be kind of similar to PRP in a couple studies that I've seen. And when compared to steroids, also similar effects to steroids is what they're saying. So when I say similar effects, means, hey, pain control is essentially the big things I'm looking at there. And steroids, we know what they can offer, and they can be really helpful for decreasing pain, but also can be obviously chondrotoxic, can have all the different issues we have that decrease the immune system. So it's one of those things. So at the end of the day, like the most common use cases are going to be tendon and arthritis, and they seem to work pretty decent for that. Like it's worth a shot, pun intended. And that's kind of like that's our motto. Hey, it's worth a shot. We can try this, and it's what we can do. But that being said, we have to understand the limitations to this, right? There's not a huge, robust ton of evidence, but I think it is something that most people can do and tolerate really well. Like I said, the cool thing is it is very well tolerated. It's safe. It's easily accessible. That's the one thing that I really like about that. It's dextrose, right? Like everyone has this in the hospital. Although there was a big shortage during the pandemic, it was hard to get. Now they have it. And like the thing is though, it's also not covered by insurance a lot of times. That's the bummer. But it should not be as expensive as PRP. Like I said, on the open market, like I said, I currently don't work on the open market. I work in a government system. So I can't necessarily say this is exactly what the price is, but from what I've talked to my colleagues is, PRP is anywhere from like $1,000 plus, and prolotherapy can be like $200 to $500. So it's not nearly as expensive and can be something you can try. I would pretty much always try this before trying PRP. That's just me personally. PRP is, like I said, a little less accessible, more expensive, and this should be less expensive and more accessible. And so I will pretty much try this as like a gateway into like PRP. I think you can save money and time, and a lot of times you might get really, really good benefits from it. So, I think that people will start using this more and more as we learn more about it, potentially as an alternate option. Obviously, PRP is getting really popular. We'll talk about that in a future podcast. But for me, this is kind of that like sweet in between, right? Like we're hitting the regenerative medicine injection, but we don't have the huge cost associated with stem cells PRP. But also we feel good about it because we know like it's just dextrose, right? Like people get sugar all the time. We eat it, we get it like injected, like I said, if we're hypoglycemic. And so we're really comfortable with using this. And so that kind of gives us a little more leash to use this in various ways that maybe we don't have a robust literature set on. Hey, maybe it's like I said, for that medial elbow issue, we can try that. Hey, I've got this rotator cuff issue here. I've got the subscapularis instead of supraspinatus. All these things that we can try, and we understand that, hey, mechanistically, this should be fine. Side effect profile wise, this should be safe. And so kind of gives us a little more leash to say, hey, we can try this and use it. And so, like I said, I think it's very reasonable to try. I think personally, the best results that I've seen and the data are probably with tendons. And this is usually my bread and butter. And so with this, we're doing something called a needle tenotomy. Like I said, that's where we go, bring the needle in and out and kind of fenestrating and peppering the bone. That whole thing is a prolotherapy injection with needle tenotomy. And we can talk more about tenotomy techniques if you want to, but that's kind of my bread and butter for using this. It kind of irritates the tendon, kind of helps it. And once again, any injection that you're doing, it's going to do better when you're physically active as well. We're kind of getting things rolling. I never want to just inject you and you just sit there and do nothing. Obviously, There's certain cases where that has to be the case, but that's not what we're going for. And so, like I said, at the end of the day, that's what I use for. I think I said, I like the fact that it's widely available, that people tolerate it really well, and we can use it for a bunch of different things and feel pretty good about that. So today we're talking all about platelet-rich plasma, or PRP. We're going to talk about the definitions, the mechanism, how we think it works, when we use it, all that fun stuff. So let's dive right in. All right, so let's get started with the definition, right? So the definition is formally, it's an autologous blood product acquired from part of the plasma fraction created by centrifugation of the whole blood. Holy cow, what does that mean? Let's break it down. Well, autologous meaning coming from the same patient, right? It's not coming from someone else. This is coming from your own blood. Not, autologous blood products means you are getting that blood taken out from you, and then we spin it down in a centrifuge, and we get these different components which we'll talk about there. But essentially, that is the definition. It is something that's coming from you. We spin down your blood to get concentrated platelets. That's the long story short of it. Like I said, there's that fancy term that we just talked about, the definition, but long story short, taking out your blood, spinning around a centrifuge, getting concentrated platelets, and then injecting that back in you. So, but let's just step back a little bit first, kind of talk about some more basic physiology and kind of walk through the blood layers and what's inside of blood, right? So we talk about all that fun stuff. So first of all, blood is made up of bunch of different things. First of all, is plasma. Plasma is about 55% of your blood volume, and plasma is mostly water with some proteins and some electrolytes there, but plasma is kind of like the fluid, the majority of the fluid you have there. And then on top of that, we also have, we have plasma, and then we also have like specific cells where we have something called like a buffy coat. Inside the buffy coat, we typically have white blood cells that are known for, fighting off infection, and then platelets, which are responsible for clotting, inflammatory response, all that stuff. And then outside of the buffy coat, the last layer we have is red blood cells, and the job for those is to carry oxygen throughout the body. So if we think about it, we kind of break it down into plasma, and then this buffy coat with the white blood cells and platelets, and then red blood cells. Those are like the main components of the blood that we have. So that being said, we're understanding, hey, where are we getting these platelet-rich plasma from? So we talk about platelet-rich plasma. Plasma is, like we talked about, mostly the water, kind of the fluid portion of that. And then platelets, we are concentrating those down. Those are coming from our buffy coat, kind of that in between that has the white blood cells and the platelets. So we are taking that, spinning it down, concentrating those platelets, mixing it with a little bit of plasma, and doing it in. So like I said, by definition though, like I said, the whole thing with PRP, we have to have a higher concentration of platelets than normal physiologic levels. That's why it's platelet-rich plasma. It's not just normal platelet plasma, it's platelet rich. So we are spinning down and getting higher concentration than we normally would and injecting that. So that's kind of what gets it going. That's kind of how we define it. So let's move on to preparations. The biggest caveat I'm going to talk about here, like if you take one thing away from here, it's that there's no standardized protocol for anything about PRP. It's the general idea is, what we call differential centrifugation, right? So centrifugation is a machine that spins around super, super fast and makes various components of the blood settle at different depths based on their specific gravity, or basically their weight. So like I said, we take out that blood, draw it back, and then we put it in this machine that just goes around super, super fast. Like it's super, super fast. You can't even see it. But with that process, with the gravity there kind of working when we're spinning, it brings things down based off of their specific gravity or size. And so we get these different components. So when you pull it out, you'll see distinct layers in, like the test tube that you put in with. And so when we are preparing things, there's two main methods. There's one that's called the PRP method, and the other one's called the buffy coat method. We'll kind of talk about each here. The PRP method is probably a little more common. What happens is blood is taken and then put in that centrifuge, and then you kind of have a soft spin to separate off the red blood cells. We found that red blood cells tend to not do fantastically. We don't tend to have a lot of great outcomes that we've seen. They're not that studied, but they tend to be irritating to wherever we inject them into, so we don't typically use that. And then so we do kind of that first soft spin to get off the red blood cells, and then what's left is called the supernatant. That's the fluid that remains on top, and then that is then spun down again at a more vigorous pace to get the concentrated platelets. So once again, this whole PRP method, what's happening is we are spinning it down once, getting the red blood cells off. We don't want that. Then we have the supernatant left, and then we spin that again to get that concentrated platelets. That's what's typically happening. And the other method is called the buffy coat method, where we have whole blood is stored at room temp, and then it undergoes a hard spin that separates into three layers, which are the red blood cells, platelets, and white blood cells together, aka the buffy coat, and then platelet poor plasma. And so, like I said, on top of that, we do have the spins that kind of matter. So we have in there, we have three different categories, right? We're going to get rid of the red blood cells. Some people say, oh, do we keep the PPP, the platelet poor plasma, or do you use the platelet rich plasma? It's kind of here and there. But like I said, those are the two main ideas, meaning we can have those layers in different settings. Like I said, for the long story short, PRP method, spin down, get rid of red blood cells, have what's left, spin that down, get the platelets. The buffy coat method, we're essentially spinning it down and then having those three levels, getting rid of the red blood cells, and you can decide if you want to use the platelet poor plasma or the platelet rich plasma. So like I said, that being said, the spin is really important. It kind of provides various platelet yields, so the spin's going to dictate a lot of things. Usually you'll have two spins, but how many revolutions per minute you have will determine the concentration. So there's various protocols on what they're doing, but usually they're anywhere from 1,000 to 3,600 RPM. Lasting anywhere from like 4 to 15, 20 minutes, depending on what you're spinning. And like I said, lots of variability with all the different literature out there. And typically, slower spin rates will yield higher platelet counts. Theorizing, the theory is that if you spin too fast, it might cause clumping or disintegration. And so that's kind of why we're not having way high RPMs, but kind of keeping a little lower around that, like I said, 1,000 to 3,600. So that being said, what also affects the yield is patient factors, right? Can be if someone's fasting or not. So fasting patients in studies that looked at had fewer platelets than those who had a high fat meal. Something to consider there. Is that standard protocol? We're saying, hey, don't eat before or have a big fatty meal before. No, not necessarily, but just something to consider. And on top of that, we also have to have anticoagulants ready when we're preparing this. I'm not saying you have to be on anticoagulants or taking, a medication like that, but it's important to have an anticoagulant in the preparation so that it prevents clotting, right? So we're trying to prevent clotting of those platelets. That could be bad. There's a common anticoagulant called EDTA that is super common and actually may cause platelet degranulation, so we recommend not using that one. Heparin, also another common one used with blood draws, may cause spontaneous aggregation of platelets, also not recommended. The big one that's used predominantly is called anticoagulant citrate dextrose A, or ACDA, most common one used. It maintains an optimal pH around 7.2, and the citrate binds calcium, which inhibits the clotting cascade. And so, like I said, we're trying to prevent things from clotting. So if they're clotting up, they're not going to be as active. And that's what we're going for. And so at the end of the day, is there a best protocol for preparation? One study recommended a potential thing, but there's no uniform recommendations. They'll say the one that was recommended, saying like, hey, they kind of did the review, some review of it and say, hey, is there a best one? They say, incubated at 4 degrees Celsius or 39, Fahrenheit. And then we have supplement with cryoprecipitate, which is another component of blood. And it kind of got fancy. Long story short, that has not caught on in any degree, and nobody's doing one standardized protocol. We have lots and lots of different things. Like I said, the reason they suggested that is maybe we have increased angiogenesis or, our blood vessel creation, increasing VEGF, other growth factors, fibroblast growth factors, all these things. But like I said, it's definitely not there. And so the problem with this is there's so much heterogeneity. You'll hear me say this over and over again. Heterogeneity meaning we have so many different models, different, systems of PRP, the way they spin, do they spin or do they not spin? How many times do you spin? Do you take off the bubby coat? Do you take off the platelet board plate? So many different options that we can do that it's just not unified. And so some people have tried to come up with classification systems, and I'd say there's been multiple of them, but the most recent is called MARSPIL. Essentially, it's a acronym for method, activation, red blood cells, spin, platelet concentration, is it image guided, and then leukocyte concentration or light activation. So that's a whole lot there, but those are kind of the main things that we've learned. Method meaning how did we collect it? Is it, the PRP method is the buffy coat. Activation, are you quote unquote activating them? What do you do with the RBCs? How fast do you spin it? What's the platelet concentration? Are you going to use an image guided injection? What's the leukocyte concentration? Because there's always going to be some white blood cells. Some people say they want leukocyte rich or leukocyte poor. That's a thing. And then light activation, does it get activated with light? Once again, it's overwhelming. There's that many factors to think about. It just gets overwhelming. But once again, there hasn't been any wide uptake of this classification system either. I think it'd be a solid idea to kind of have that every time you say this is what we have, which would be fantastic. But it's gonna be tough, because the reason why I want that so much is because this really limits our ability to study it, right? That's going to be a common theme I talk about over and over again here, is when we don't have this uniform standard protocol, we have no idea what's causing the results, right? Is it the PRP? Is it the platelet concentration? Is it the leukocyte concentration? We're not sure. There's all the things that we're working on here. And so we're kind of trying to figure out and kind of going off the seat of our pants a little bit here, trying to figure it out. So that being said, let's move on to our mechanism, right? So why we think this works. And I say think this works because, once again, this is not set in stone by any stretch of the imagination, but this is kind of what we're thinking about here. First of all, let's talk about the properties that platelets have. Platelets contain something called alpha granules, and these contain lots of growth factors, which then influence inflammation, angiogenesis, stem cell migration, and cell proliferation. Also, potentially we think that these alpha granules and everything going on there and platelets themselves are kind of the initiator of a healing process. And so that's kind of one of the big reasons we think is, hey, we get these platelets where we need to go, and that kind of starts a healing process. And some areas don't have a lot of exposure to platelets due to poor blood supply. So think like tendons, ligaments, cartilage, we may not have the best blood supply. So if we provide a stimulus there with these platelets and then these alpha granules, that may start a response in a place that normally wouldn't have that because of lack of blood flow. So that's kind of the idea. And so the idea is to make it a super physiologic concentration of growth factors to certain areas to kind of stimulate resolution of this chronic pathology, whatever's happening there. So when I mean stimulate resolution, I mean, hey, this is an area that's kind of been roped off. because, there's no blood flow there, but in reality it's kind of roped off, but someone kind of goes under, the rope there and to a restricted access area and kind of helps out and re-triggers this area. So that's kind of what we're doing. We start the injection, we put the injection where it needs to be, and that's kind of starting the process all over again. And once we're recruited to this area, the idea is that, platelets then start to clot. So we inject them, they start to clot. And once the clot is formed by the platelets, this activates a release of tons of growth factors from the alpha granules. And so once we get that clotting, we go. And that's why it's so important for our anticoagulants. We do not want to clot too early, because if we clot too early, we're activating them too early and we might not get the response we need. So that's the general idea for why we're doing that. Like I said, some of the growth factors that we see inside the platelets include platelet-derived growth factor, VEGF, something called transforming growth factor B superfamily or TGF-beta, fibroblast growth factors, insulin-like growth factors. Well, that's a hard one to say that 10 times. So like I said, long story short, lots of different growth factors, not a big deal there. On top of that, platelet-derived growth factors may activate chondrocytes and stem cells and can play a role in angiogenesis. And so like I said, this is kind of that holy grail. Everyone thinks like, oh, this is going to restart regeneration. And there's some data showing like, oh yeah, maybe it does help increase activity of chondrocytes or the cells inside the cartilage. Maybe it recruits some stem cells potentially, we're not sure, but definitely not like a slam dunk. This is what's happening. And so lots of stuff going on. In terms of other things there, the TGF-beta we talked about may also be a promoter of chondrogenesis. So we've talked about so far chondrogenesis, angiogenesis, we're getting blood supply there, we're increasing our cartilage. Those are all really good things. And on top of that, another thing, other than just bringing all the goodness there of growth factors to where it needs to be, there's an idea that PRP kind of may help form something called a fibrin gel. And this fibrin gel, if you think of it kind of like a scaffolding, it serves as a bioscaffold to allow incorporation of migrating cells into this tendon healing. So essentially it's like, hey, it's given an environment, say, hey, you've come to kind of help out with this tendon healing or whatever. Let's give you a spot where you can kind of hang out and then really kind of do your thing. And that's kind of what I think about there. On top of that, though, there are some potential negatives to this. Everyone's always like, oh, this is like a holy grail. It's so perfect. It actually may increase pro-inflammatory cytokines. Like we know that it increases inflammation. We know that, but it also gets things like matrix metalloproteinase, IL-1B, and some of these may be chondrotoxic. That being said, at the end of the day, most of the studies don't seem to show that. It seems to be overall, seems to be a net benefit for the cartilage. It doesn't seem to be chondrotoxic like we've talked about in previous podcasts, but overall, it's not like a free lunch, like there's nothing going on. So also, I want to just mention a couple nuances in terms of like mechanisms and stuff. Sometimes NSAIDs are softly contraindicated, meaning they're not dangerous. So it's not like hard, contraindication. If something's like contraindicated, it's like, don't do that. It's like definitively bad. But this is like, we don't know. So some people say don't take NSAIDs because they think it may make things less effective. NSAIDs are known to inhibit platelet function. So theoretically, this could decrease the effectiveness of it. Like I said, it is theoretical. There's no real direct data saying like, hey, this is worse with NSAIDs versus not. There's some data that it potentially could inhibit things starting. So like I said, it's more of a, hey, this makes intuitive sense. Let's try it. But once again, no real direct studies showing anything at all. And so now let's move into applications, like when we actually use this. You're like, all right, cool. We're done with all the nerdy stuff. Let's talk about, when we actually get it. But that being said, we'll cover that here, but it's a wide use case. There's lots of areas you can use it. Overall, like I said, very safe injection. We're not having lots of bad outcomes. This is your own blood products. And so we feel pretty good about that. We're not going to have a bad reaction to it. So overall, very well tolerated. So one of the big ones is lateral epicondylopathy or tennis elbow. There are systematic reviews showing it has improved. Like I said, it does seem to be delayed outcomes though. So compared it 2 years, better than steroid for sure, is what it seems like, but it takes a while to get there. That's the thing. Like if you check someone in at 1 month, like steroid might be significantly better, but longer term seem to have better outcomes. And that seems to be one with the better outcomes and more data. So lateral econdylopathy seems to be a good use case for it. Another one is Achilles tendinopathy that we looked at. It doesn't seem to be significantly better than a placebo or eccentric exercises. We've talked about eccentric exercises for rehab. That's super important for tendons. It doesn't seem to be significantly better. When we looked at the patellar tendon, it did seem to be better than dry needling or extracorporeal shockwave therapy. Didn't really see much data about like comparing it to exercise therapy, but better than other modalities that are known to be effective in terms of shockwave therapy. Also looked at the rotator cuff. Those were kind of mixed results. There were some that showed when compared to saline and dry needling, it was like comparable, and that's never what you want to hear, because if we're injecting saline, what are we doing? And once again, this keeps coming back to this. We mentioned every single podcast that we get improvement from symptoms with saline injections. So like all these fancy mechanisms, we think, oh, we're starting inflammation or we're doing this and that. Like, does it really matter? Like, does it really matter? Who knows? And so that's why once again, I'm always like cautiously skeptical about all this stuff. I kind of think about what is the actual mechanism. But once again, does seem to be some potential improvement at rotator cuff stuff. Not sure, but we're still working on it. From a cartilage pathology perspective, so talking about potentially things like osteoarthritis, or essentially chondrocyte issues, it does seem to be that there can be some help with that. The body data seems to be, there's some improvement at 12 months, seems to be better with younger people, specifically with less advanced OA. So like the person who here is like, maybe you're a younger person with some early onset OA might be a good thing, and here they talked about leukocyte rich PRP seems to be the best version. And like I said, everything seems to maybe, because there's just not definitively anything showing that one specific type is best for anything. And so we're working on it once again. But it does seem to be worth a shot. And kind of, once again, the outcomes seem to be more like 12-ish plus months. And that's kind of where we see the differences. Short term, not necessarily as good, and long term seem to have a little bit better benefit. So when we talk about next one is our acute muscle injuries. So when I say that, like, hey, had a hamstring strain or something like that, like we're going to say, hey, does this seem to be beneficial with that? And so what they found was, for some people, return to sport was significantly shorter by about 7 days in a PRP group. So there were about 6 RCTs. However, only one study was double-blinded. And in that study that was double-blinded, there was no difference. So meaning we had 6 studies, only one of them double-blinded. When the double-blinded one means someone got injection of X and the other person got injection of Y, when compared to them, there's no difference, but the other studies showed there might be a difference. So you may have a marginal return on, decreased time to return. But once again, that also depends on lots of different factors. And, does 7 days make a big difference in your life? If you're a professional athlete, it might, absolutely. College athlete, professional athlete, that's something we can consider. If you're an everyday person who's just like, oh yeah, it's got to spend 1 more week not going 100% full bore there, then I'm not sure if that's necessarily, beneficial. But hey, that's something we can decide together. So next, there's also consideration for using this for surgical augmentation. So use after surgery to help expedite healing and recovery. Most of the studies are on rotator cuff and ACL, and that's kind of what it looks like. And overall trend seems that it may be helpful for rotator cuff. When they have big, large rotator cuff tears, it seems like there's actually 20% reduction in the re-tear rates, which is pretty important. ACLs mixed, though, may show some benefit. Once again, it's probably not going to harm you. That's like the biggest thing we take away from here is like, but is it going to benefit you? And, price-wise, we'll see. And then I want to talk about the issues with, PRP injections. Not that like from a safety danger standpoint. Like I said, I want to just first kind of touch that first, that it seems very safe. These are well-tolerated injections. Obviously, in terms of, there are different protocols you have to use for NSAIDs, no NSAIDs. We'll kind of talk about that in future studies if you're doing it for tendon stuff specifically. But like I said, seems very well tolerated for most people, and it has the same risks that every other injection has: pain, bleeding, infection, hidden nearby structure. All those things still count. But like overall, like from a side effect profile, seems to be pretty minimal and well tolerated. So that's really cool, at least like that we know, hey, this thing we're doing, we feel pretty good about that. The problems we have, though, is there's so much heterogeneity. There's so many studies that show different things. There's just a mix of, a lot of times the studies soft tissue stuff with osteoarthritis, and sometimes they don't include the PRP concentration. And so we just don't know like what we're actually looking at, we're studying. And there's no studies specifically looking at PRP formulations for any indication. So we can't make definitive conclusions. So like I said, it's not like, hey, this specific concentration, we can go from there and do that. So it's just kind of crazy. And obviously, one thing I also want to talk about here is the elephant in the room, is the cost. This can be anywhere from $500 to $1,000+. I mean, we're talking some places, depending on where you live, can be up to, I don't know, even $1,500. It's just crazy. And so that's one thing that we do think about in terms of, hey, this is a super expensive injection. And is it worth it for everybody to get the super expensive injection? I don't know. It has to be part of the discussion. And when something's this expensive, like, you have to counsel, understand it perfectly. And that's why I'm spending 20 minutes talking about these injections, is because I want you to understand exactly what you're getting yourself into if you're going to get this injection. So that's like one thing. Very expensive. With shoulder shrug emoji, is it going to work? I'm not sure, but we'll see. That being said, also you have to think about, why is this so expensive? You might ask. You're like, oh, this is just people trying to get rich on people. And like I said, I want to at least provide devil's advocate on both sides, saying, yeah, does it have to be this expensive? Probably not. But some of the reasons why it is so expensive is because, one, it takes time. So time is valuable in terms of, if you're in there for 45 minutes for a procedure, that is, it limits the amount of other patients that can be seen potentially. And so, like I said, you're getting in there, got to get checked in, got to draw the blood, got to spin the blood once, maybe twice, depending on things, and then actually do the procedure, which takes time in itself. So it takes a lot of time. And so that's kind of built in there as well. And on top of that, the kits are really expensive. So there's various big name, companies that make various kits. What they essentially have are these fancy tubes that connect to these fancy kits and then do the centrifuging and spin down, all this fun stuff. And, the kits themselves, when you buy them, are anywhere from like $200 to $300+. And so that's like part of the cost why it's so expensive is because the kits that are sold are so expensive. And it's kind of a travesty because the kits are pretty simple in terms of like the components. It's like syringes and tubing, and then, you just put it into a centrifuge and spin. But like I said, it's just the convenience of it, like trying to pull it off, and then it pulls off specific layers like we talked about the supernatant and whatnot. So like I said, it is kind of a little bit complicated, but the kits are super expensive. And so that's why a lot of times like it's built into that as well. And so overall, like I do in all these podcasts, I want to give you my take. So kind of like I said, this is my professional opinion, not formal medical advice, but also not consensus from anybody or anything. So it's just kind of my experience, what I've seen. Overall, PRP seems to be a pretty safe injection though. Like I said, not worried about it from a side effect profile. I think it's well tolerated. Obviously, yeah, you can have interactions or bad things happen at any sort of injection. That's possible, but PRP seems really safe. I think it's inconvenient though, and that it can take anywhere from 15 to 30 minutes just to spin it. And then you got to do the procedure and all that stuff. So it's an inconvenient injection, takes time, going to get, pretty much have to chunk out a big part of your day. You always have to get poked twice. So you get the blood draw and then the injection. So that's something. And also this can be a really painful injection. A lot of times people recommend not having NSAIDs, right? So not taking it before or after. And if we're going to a tendon with this, man, it is not a fun injection. Anytime I do this, I feel bad because it is not a fun injection for people. And like I said, a lot of injections, not that bad. This one, when you're doing tendon specifically with PRP, it's not a good time. It's not fun. And there's some theoretical things that we shouldn't inject with a small gauge needle or smaller needle, meaning like a 25 gauge needle. You should use like a 21 because if it's really, really small, it could inhibit how effective the platelets are. And so like you're using a bigger needle, and you can't use lidocaine potentially. Some people say that might deactivate it. You can't use NSAIDs. So just a really painful procedure that we have to think about it. And then, but that being said, all that stuff, it does seem to have some clinical benefit. Specifically, the ones I look at are like lateral epicondylopathy and knee osteoarthritis. Those are kind of like the ones that seem to have the best evidence. And so overall, super expensive. Is it worth it? I don't know. Like it's a $1 million question. This is one where you're just gonna have to kind of talk and kind of have the discussion with your physician and say, hey, is this something that works for you? Like I said, I have had multiple patients, many patients who said, oh, this is fantastic. It worked really, really well. I love it. Like I'm pro PRP. And I have other people I've talked to who say like, yeah, it did nothing for me. Absolutely nothing for me. And that's like where kind of we are. And that's like, seems to be like literature. That's like some things are no better than, saline injections. Others say, hey, this is way better. So, and I think it's kind of just the human condition that some people are going to respond well to something and others aren't. And that's very unfortunate. Like I said, that is any medication or any treatment or anything we do, like even exercise or physical therapy, like some people won't respond the way we want them to. And that's just unfortunately how it goes. And we have no way of predicting who that's going to be. And so when I think about it, it's like, okay, how can I counsel patients appropriately to understand this and give them the risks, benefits, and potential pros and cons of this? And that's what this podcast is for. Like I said, this is a long discussion about, hey, I want to have a resource people can talk to and like, hey, if I'm getting this injection, this is what I understand. So like I said, for $1,000+ this injection, like what's my recommendation? My first recommendation would be obviously making sure it's the right indication, right? It's something that's been going on for a while and you're ready to do the work in terms of physical therapy. You've either done that or want to continue to do that. And then also think about like, hey, are there other options? Would a prolotherapy injection be a good trial injection for you? For me, that's like usually my like, hey, let's try prolotherapy first and we can work to PRP. Like I said, just because it's inconvenient, it takes longer. It's more painful and is really expensive. And so I'll try prolotherapy first. And then if we have some results from prolotherapy that are good, maybe not fantastic, then we can work our way up to PRP is kind of where I go from there. So like I said, that is kind of my framework and my thought process. And like I said, if you have any questions, please let me know about that. I'd be more than happy to answer them. But it's not a magic injection. Some people on the internet will say it's magic. It restores cartilage when you're bone on bone. It does this, that. Like that is not the case at all. It can be a tool in our toolbox that we have to offer when people are having pain or have issues with something or decreased function. So like I said, that's kind of where I place it. It's another tool that we have among our toolkit of multiple things that we can try. Today, we're talking all about needle tenotomy. So a procedure we kind of referenced earlier in our prolotherapy and PRP injection lectures, but we're talking about needle tenotomy today, its use cases, the procedure itself, and the recovery for it. So today we're going through a specific paper. So we're kind of going through one article that was kind of a review about this topic, and we're going through it kind of systematically. So kind of a little bit of a change of pace, but I kind of wanted to dive through this because I think it's a really nice article. So let's dive into it. We're going to talk about this article here. All the article will be linked in our show notes if you want to take a look at it, but it will be there. First, kind of overview in terms of tendon issues, right? So tenotomy, the root word of that is teno, which is talking about tendon. So we're talking about tendon injuries today. And essentially, tendon injuries were 12% of PRP use. So this study that we're going to talk about today talks about, hey, what's the recovery process? What is the offloading we have to do after we do a needle tenotomy with PRP? So looking at that specifically. We'll talk about how we extrapolate that and whatnot, but we're looking at PRP and tenotomy and kind of how we take our post-procedure process, how that works. So PRP was used for about 12% of all PRP injections. So obviously the majority of it's probably arthritis, but still used tendon for a decent bit. And overall, as we've mentioned in our previous PRP lecture, the data is super heterogeneous in there. There's lots of stuff that's going on, lots of factors that could affect treatment in terms of, the platelet concentration, the leukocyte concentration, the spin times, all these various things that we've talked about previously, but it's very heterogeneous. So it's hard to know definitively here. There are also differences in terms of like the onset of when we start to see improvements from PRP versus other injections, right? We tend to think this is more of a slower onset and has a longer follow-up in terms of we see benefits later. And so compared to steroids are usually pretty quick in terms of we're just dropping a grenade on everything, calming things down, and then we feel good right away and then not as good long-term. And PRP is kind of the opposite where we stir things up, doesn't feel good. I'm going from there. But like I said, when looking at PRP, it's hard to know what causes what and how much of an effect the specific formulation of PRP had because everything is so heterogeneous. There's so many different ways to do it. The formulations are different. Like I said, that leukocyte rich versus poor and all that stuff. And that being said, there's so many post-PRP protocols. So when we talk about all the different variables, this is just another variable we need to talk about in terms of some people say you should not use NSAIDs. Others are like, it's fine. Some have a specific physical therapy regimen that you're starting right away. And so there's just a lot of heterogeneity. This is not looking at the specific PRP they use. That is a whole different study. This is looking at, hey, of the literature that's out there, what does it show in terms of getting that kind of post-injection protocol? Like, what are people doing? That's really what this review was looking at. So the goal was to systematically review these protocols utilized in the setting of PRP injections for tendinopathy. So looking at, hey, what do people do and go from there? Things they were looking for, they looked at things like weight-bearing restrictions, meaning, hey, are we actually having non-weight bearing? Are we taking people, putting them on crutches? Are we not letting them walk? Are we activity modifying them, saying like, hey, you can't do this level of activity? Are we putting them in braces? Are we starting them with physical therapy? Are we putting them a use or restriction of a certain limb, meaning you shouldn't use it? So like I said, all those different things they talk about, and NSAIDs as well. Should we use NSAIDs? Should we not? So lots of different variables and lots of different combinations that we see throughout the literature. And you'll see here, semi-spoiler, that there's a whole lot of it out there and there's no one big thing, but let's talk all about it. So first and foremost here, let's talk about the methods, right? So the inclusion. So the inclusion criteria here, this had to be done on humans that were 18 and older, and we're looking at PRP for tendon treatments, right? So obviously not for arthritis, that wouldn't be a good use case here, but for tendon treatments, looking specifically for that. These are either going to be randomized controlled trials, case control, or case series papers. And we're looking at some primary and secondary outcomes. Primary being where they're trying to categorize the protocol based on the use or restriction of NSAIDs, physical therapy, bracing, weight-bearing modifications, and activity modifications. So once again, all those things we talked about, can they be on NSAIDs? Are they in physical therapy? Are we wearing braces? All those things, that was their primary outcome, where the secondary outcome was looking at the timing of those different mentions. So like I said, primary is, hey, what did you do? And secondary, if we had that, was, hey, when did you do that? Overall, the results of this, there was a total of 84 studies included in this review. There were 43 that were RCTs, 8 case control, and 33 case series. So decent bit of data there. And predominantly, like it's a decent split. There's 37 in the upper body, 42 in the lower body, and 5 looked at multiple tendons. So kind of throughout there. And like I said, what they looked for here, specifically with post-procedure rest, weight bearing, did they wear orthoses, were there activity modifications, all that thing. At the end of the day, for those, 80% of people didn't report any specific post-procedure rest, weight bearing, or orthosis use. So in terms of recommendations, it was just like, yeah, we did this, and we don't really necessarily know, but of that, those studies, 20% did recommend a period of immobility of that affected limb. So when we mean period of immobility, what we're not saying is you don't do anything, just sit in the bed. What they're saying is, hey, if this is like an Achilles issue, we're probably going to immobilize that in a boot in some way, shape, or form. So it doesn't necessarily mean they're non-weight bearing, like on crutches, but it might just be, hey, we're going to limit how much you can move, so we might put you in a boot or something like that. On top of that, of those studies, of the 20% that did, have a period of immobility, 71% of those specific studies limited mobility to less than, 30 minutes right after specifically. So like they categorize it even more in terms of immobility, saying, hey, should we immobilize them in a boot? But then also they talked about a post-procedure immobilization, where it's just saying they're sitting there after they get the injection, waiting for 30 minutes. The idea that theoretical. Once again, everything in PRP is technically like theoretical, right? Is they want someone to sit still for about 15 to 30 minutes to let the PRP quote unquote bind to the tendon. That is a general thought. The thought behind why they wanted to do that. Like I said, is that a super common procedure? I don't think so, but like I said, it is in literature and they want to mention that. So like I said, of the 20% that talked about immobility of an infected area, meaning not moving, whether it's at home long-term or right after, like I said, 71% of them did talk about having that. They had a mobility less than 30 minutes. So nobody's just sitting there for hours letting the PRP bind. So that is something to consider as well. And however, of the overall studies, 88% didn't report any weight bearing restrictions. So like we talked about weight bearing restrictions, can they walk on their leg? Can they use crutches? Do they need to do that? And anything like that. So only 12% mentioned any sort of form of weight bearing. Most of these are lower body, and they typically range, if they did do non-weight bearing or some sort of weight bearing restriction, is usually a short term, like 2 to 7 days, which I think is pretty solid. I mean, convincing someone to non-weight bear for more than 7+ days for a tendon issue seems a little extreme. Like I said, but hey, we're still trying to figure this out. In terms of orthoses, so like foot orthotics or inserts, did they use those? 82% of people did not report the use of that at all after PRP. And like I said, that was the vast majority did not. But of those that did, there were 4 in the upper body use either a sling or tennis elbow strap for tennis elbow injections. And then for the 11 studies that were lower, for Achilles, there were about 53% of the studies that actually did do some sort of bracing or whatnot. 53% of them used a crutch or walking boot, and then 24% did the same for plantar fascia as well. So, about half the studies for Achilles and a quarter of it for plantar fascia. Once again, not all the studies, the vast minority of the studies mentioned this, but for the small percentage of ones that did talk about orthoses, the majority of them did either a boot for Achilles or crutch, and then for plantar fasciopathy, also a boot as well. And so of the studies though, about 50% did mention some sort of activity modification. So that's kind of nice as well. They might not have talked so much about immobilization or anything like that, but for in terms of activity modifications, it did seem like about half of them mentioned that. For activity modification and activity limitation, I should say, is 26% of them were limited for less than 2 days, about 57% for 2 to 7 days, and then 17% for more than 7 days. So about the majority of people were sitting in that 2 to 7 day range. And once again, this is kind of activity limitation, not necessarily modification, because they'll be modified for much longer. But a limitation wise, what we're talking about is, hey, I really want you to take it easy for the next couple of days, most likely, in terms of, hey, no heavy lifting, none of this stuff, no even like significant strengthening work, anything like that. So that's generally what we're thinking about, is we're kind of given a period to kind of calm down. So 8 of the 84 papers mentioned no activity restrictions whatsoever. And so of those 8, they're just like, all right, go for it. I assume they did not give those instructions to their patients, but they didn't mention it in the specific study. In terms of rehabilitation, obviously a lot of people talk about getting into rehab and doing, physical therapy after PRP. I'm a big proponent of that. There are 2 main phases that we seem to be recommended after this. So, first being range of motion and the second being strengthening. And in the studies, 51% mentioned range of motion and 54% mentioned strengthening. And most people in their sequence did phase 1 before phase 2, meaning that the majority of the times they started range of motion training and then after that started strengthening. But there were a few that mentioned doing them together, meaning we started range of motion and strengthening together. 43 total papers specifically mentioned a formal rehab activities, and 30% of those initiated phase 1 within 2 to 7 days of post-injection. So once again, phase 1 is that range of motion. So 37% of those started that within 2 to 7 days post-injection, and phase 2 was commonly initiated between days 14 and 21. So about 56% of the protocols started phase 2. So once again, breaking it down into real life terms, what this means is, hey, you get your injection and they start phase 2 or phase 1 to stay within 2 to 7 days. So like I said, they'll probably have activity limitation for, it looks like 1 to 2 days. And then once the activity limitations kind of go off, we start potentially working on these range of motions within 2 to 7 days. And then after that, we start phase 2, which is strengthening exercises, anywhere from like 14 to 21 days. And so this is the general thing. And then in terms of recommendations for removal of the restrictions and return to play, 42% of the papers discussed return to play protocols and had it about 4 to 6 weeks. And so like I said, that's kind of out there. If you think about the framework there, it's 2 to 7 days for phase 1 range of motion, then maybe 2 weeks-ish we're starting for strengthening, and then 4 to 6 weeks for return to play. So not the most aggressive return to play protocol, but once again, it's a protocol, and these are the averages, and this is studies what we're looking for. Like obviously everyone's going to be very different, and depends on the level of play for your athlete and the level at which your athlete's competing, but that's the general idea. Another topic looked at was NSAID restriction, meaning, hey, did they allow people to take NSAIDs? 80% of the papers didn't report any restriction on NSAIDs prior to the procedure. Of the 17 papers that actually did, 10 withheld NSAIDs 7 to 13 days prior to the injection, whereas 7 restricted for at least 2 weeks. I mean, that's some dedication to say, hey, for 2 weeks before this procedure, I don't want you to take NSAIDs. So that's a pretty big buy-in by the patient. Like I said, you have to get a lot of buy-in. And if they're in a lot of pain for some reason, it could be challenging potentially to do that. That being said, 56% of the protocols restricted NSAID use in the post-procedure. So like I said, pre-procedure, 80% didn't report that. So it was like, didn't really have much of that. But post-procedure, 56%, for about half of them, did mention some sort of NSAID post-procedure. And about 13% of them restricted it for 13 days or less, and 38% restricted it for anywhere for greater than 13 days. So there are some papers that like restricted it for up to like 6 months, which I mean, how can you possibly do that in terms of like, did this person never get a headache or anything like that? So that's a little extreme, but that was something we saw as well. So that was like the raw data. We're going to kind of work into the discussion now, and then we'll talk my take at the end here. So overall though, we're going to talk about the most common features, meaning present in greater than 50% of the studies. There seemed to be a short period of weight-bearing restrictions for lower limb weight-bearing tendons. So meaning like a patellar tendon or an Achilles tendon, those are kind of weight-bearing tendons. There seemed to be a short period of weight-bearing restriction, not necessarily non-weight-bearing, but say altered in some way, whether that's a boot or crutches or anything like that. Typically, stretching programs were initiated within 1 to 2 weeks following the injection, and then strengthening programs initiated about 2 weeks after the injection. So like we talked about that phase 1, phase 2, that's kind of what will make sense. And that's kind of the general principle for most rehabilitation programs in terms of injury. We want to make sure we have range of motion first, and then after range of motion, we move into strength, and then strength and proprioception, yada, yada, yada. But it kind of follows just general principles that, hey, let's get range of motion first. As we work through that, then we can consider working on strengthening. So about range of motion at about 1 week, and then strengthening about 2 weeks. Most of the studies also talked about NSAID restriction for about 1 to 2 weeks following the injection, which I think is reasonable. That's not unreasonable as well. So like I said, that's kind of what we're working on. And the reason that, like I said, we just want to touch on NSAIDs as to why we consider that is because, you might be like, well, what the heck? Well, if you go back to our NSAID lecture, talk about what do NSAIDs do, they are all about turning down the inflammation process, right? So when we have inflammation, when something needs to heal, what happens is we have inflammation first. That's the first thing. Your body's just like, oh, what's going on? Let's bring everything. It brings all the inflammatory markers there and kind of starts that process. And then when we have that inflammation there, then eventually we have proliferation. So kind of growing of the substances we need, whether that is, growth factors, tissues that we need to regenerate, anything like that. It leads to proliferation of those things. And then we have remodeling, which remodel is changing the actual structure. So let's say we had like a hamstring strain for some, you pulled your hamstring. Essentially you have inflammation there. That's when we can get bruised up and swollen, and everything's just coming there to kind of help it out and say, hey, something's going on there. Let's bring in what it needs. Then it starts to proliferate the actual substances we need. So inflammation is just kind of like a signal like, whoa, what's going on? And then these bring in these other factors that kind of help this proliferation of these factors, the things that kind of get ready. And then we remodel. So essentially this is the process where we're having, an actual change. We're trying to helping and heal up that, either tendon or muscle, what it is, kind of making physical changes there and changing how it looks to kind of help strengthen again. So that's what we generally see. So inflammation triggers that, right? So inflammation triggers that response and that whole remodeling response. So we want inflammation for healing response. And that's why in this theoretical model, giving NSAIDs might inhibit that. Who knows? Is that definitively true? I'm not sure. We don't know at all. But like I said, that is something we kind of think about. And so overall, though, like I said, NSAIDs depends on what you read, and some people will limit it, some people won't. Like I said, that's your mileage may vary. And so overall, though, like the general theme of rehab is typically rest, and then range of motion, strengthening, and then return to play. Like I said, just like other return to play, we kind of make sure in the acute injury we're not in there doing anything active. We're kind of just letting things calm down for just a little bit, and then we get that range of motion back. We strengthen it up, and then once we strengthen it up, we think about return to play. And obviously return to play is a whole different podcast series that I'll probably talk about in terms of rehab and getting back ready from an injury. But obviously that involves more than just strengthening. You have to use your specific sport measures or your specific activities that you want to do and kind of slowly work back there. But that essentially lines up for what's going on in terms of this post protocol or post-injection protocol. I think at the end of the day, majority of the times that we have these situations going on, we're making our best effort of guessing, right? So we're not exactly sure. And when you think about it, we are trying to we're trying to facilitate the PRP as much as possible. That's the idea. They think that the majority of the growth factors of PRP are released within 15 minutes of injection. So the idea that we want to immobilize kind of shortly after is because it may help decrease the spread of PRP and keep it where it needs to be. So that's one idea is why we're doing that. And then there is another reason why we're doing the boots for some people potentially. There's the thought that, hey, if I'm disrupting a tendon, right? So we've talked about previously in a tenotomy, what we were doing is we are going in and we are taking that needle fenestration or needle tenotomy. We're taking the needle and passing it through that tendon multiple times to start irritating that tendon from a mechanical. And then when we inject it inside from a chemical perspective, when we are going through a tendon, we are damaging a tendon. So there's a theoretical risk that we're making it weaker and that it may rupture. There's not a lot of strong evidence to support that. There's not really a connection between PRP and tendon rupture. But like I said, people still err on the side of caution because the last thing you want to do is inject someone's tendon, tell them that, hey, you don't need a boot or you don't need to take it careful, and then they rupture their tendon. That would be a bad look for sure. And so we're kind of thinking about what we do, when we mobilize and we exercise. There's no specific exercise selections we're talking about, but the majority of the people, like I said, started that range of motion anywhere from 2 to 7 days, started on strengthening at about 2 weeks, and it's not sure. And from an NSAID use perspective, like we've talked about, just kind of circling back, like I said, a lot of them didn't limit anything pre-injection, but some of them had some sort of restriction after. And like I said, it's just, we're trying to figure out, hey, are we going to inhibit our platelets by using NSAIDs, which the platelets have lots of good stuff, as we talked about in the PRP lecture, in terms of relieving those alpha granules and the growth factors, all that stuff. And so that's what we're thinking about. So kind of to wrap up the study limitations, obviously there's so much heterogeneity inside of a PRP with so many different protocols. We've talked about that. And there's no direct comparisons of, even the injection protocols or the rehab protocols. So we don't know, hey, this study reported, hey, we do this and we boot them for this many days and then we get them walk in and then we do straight. That's like, and versus non-boot, like we don't have any comparisons like that. It's just literally, this article was just to try to say, hey, what is going on in terms of what are the general consensus going on? And I think they do a good job of saying, hey, this is what the literature shows. And they're kind of bringing it up and saying, hey, these are the faults in our literature in terms of, hey, we don't have a lot of data and we need to do a better job. And that's why I love this paper, because it kind of gives us a baseline of, hey, what are people doing? And a lot of times best practices are what we have to start until we get more and more data. So this is kind of a way of getting best practice. And so overall, though, like I said, relative rest for a couple of days, anywhere from 2 to 7 days, and then starting our stretching and range of motion. And then strength starts about 2 weeks with hopeful full return to play in about 4 to 6 weeks. And, my takeaways here, once again, looking at PRP, this is fascinating to see, but I also think, like, can I extrapolate this to prolotherapy? And it may be a bit different. Obviously, prolotherapy works a little bit different in terms of that we're not injecting platelets in there, but or still having the same idea that we're going into a tendon, potentially using the fenestration technique, and we're needling that tendon and still causing trauma to that and injecting it with something that is a foreign chemical. And we can have also chemical irritation as well. So it's very similar. And I kind of think of, hey, when I do a prolotherapy injection, I do something specific there. And I kind of think about, hey, I should probably limit this as well. One issue with the study as well, not necessarily the study, but in terms of the data that I looked at, is they don't specify what gauge needle they're using a lot of times. Some people use a 21 gauge, sometimes an 18 I've seen, some a 25 gauge, and that'll make a huge difference. And when I talk about gauges, I talk about, that means how big a needle is, right? So the bigger the gauge, the 25 gauge, the smaller the actual needle. And so a 25 gauge is pretty small. And if you're passing through a tendon with that, it's probably gonna do a lot less trauma than a 21 gauge, which can have some, is much bigger and may lead to some more damage inside the tendon. So that makes a difference in terms of that protocol as well. And so, but when I think about prolotherapy, I still do something in terms of activity restriction, kind of relaxing a little bit. My general protocol, like I said, for most things that I've seen for prolotherapy, I'll do about a week of kind of, hey, keep her easy. And then we can start getting in some stretching and then some isometrics. And then by 2 weeks, we will probably be starting our strengthening as well. And that's kind of how I work here. I'm a little more, starting a little before 2 weeks, but like I said, we're really just kind of giving our best guess. There's nothing that we have there. So like we're kind of extrapolating it to Prolo, and also you're extrapolating it to your practice, because these are, like I said, best practices that people have done, but it's not even best practices based off of literature saying this is better. It's just kind of the general idea of what's going on. So overall though, like I said, talking about needle fenestration recovery, we've talked about that with PRP, and this is just a general idea of, hey, if you get this injection, they might be talking to you about non-weight bearing or limited restrictions. So I want you to have this information so that you know, either as a physician or practitioner, that, hey, this is what I should be thinking about, or if you're someone who's getting this done to you, you can have an idea of what you're walking into. So today we're talking all about stem cells. So stem cells are such a hot topic right now. Everyone's talking about, you've probably seen ads online or heard someone on the radio or the internet talk about stem cells. And we're gonna talk all about stem cells in terms of what actually stem cells are, what are the ideas behind how they work, when we use them, and the evidence for them, and kind of my take on them as well. So let's get started. So first, obviously these fall under our regenerative medicine umbrella, as do prolotherapy and PRP. But the idea is that regenerative medicine, the idea is that we're trying to support the body to form new functional tissues to replace either degenerative or defective areas or tissues. The human body does have an endogenous system of regeneration through stem cells. So what they're saying there is, typically your body says, hey, like, eventually your cells kind of run their course and have to kind of die off, and they get replaced with new cells of the same function. And this comes from stem cells. Stem cells kind of have this option to say, okay, like we'll just keep making these, and they just keep going. They make what they need in terms of the different types of cells, and they can make a bunch of very different types of cells. We'll talk all about that, but that's essentially what happens. And today we're going to talk about two main types where we get them from adipose tissue and bone marrow. So like I said, let's start back. Stem cells, how do we define them? This is a type of cell that is non-specific and not specialized in its function, unlike mature tissues. And so the main types are embryonic and non-embryonic. So when we kind of talk about that, we talk about these stem cells have the capability for self-renewal and can differentiate into different lineages under the right conditions. And what do I mean by different lineages? Well, let's say this one stem cell can become 7 or 8 different types of tissues. When they're undifferentiated, they saying, hey, haven't specialized, right? Is essentially what it is. So stem cells are non-specialized cells, meaning they can fill a lot of gaps and do a bunch of different things and be turned into many different types of cells. And breaking it down from that embryonic and non-embryonic, obviously embryonic is talking about working with embryos. Those are some cells that are taken from 5 to 12-day-old embryo and are pluripotent, meaning they can make any cell in the body. So pluripotent means can make any cell in the body. We're not going to be talking about embryonic stem cells today. They are not legal to use for any intents and purposes for a stem cell injection, but that is what we're talking about when we talk about embryonic stem cells. They are pluripotent, can become any cell in the body. But that's what we're talking about. And then non-embryonic are what we call multipotent. So they can still make multiple different cell lines. And that's really important. Can you make lots of different tissues coming from that one single stem cell. And so essentially what we're talking about here is when we're talking about the ones that can be injected, they're called autologous non-embryonic adult stem cells. So breaking down those words, autologous means it's coming from you. You are taking your own blood out or bone marrow or adipose tissue and spinning it down and getting stem cells. And we're taking from adult patients, and they're essentially undifferentiated, but they're no longer pluripotent like the embryonic stem cells. So when we take the ones from fat or from adipose tissue, it is not completely, not every single cell is an option, but it can still turn into a bunch of different ones. And so, not pluripotent, but it can turn into multiple things. And like I said, you can get these, these underdifferentiated ones. So not pluripotent, but the ones you can get, we talked about adipose tissue and bone marrow specifically, but you can get them from amniotic fluid or the umbilical cord as well. That is all for research purposes, though. They've kind of said, you can't really do that anymore. And the FDA actually has some pretty strict standards on this. Unlike, necessarily PRP, where there's kind of like, it's the Wild West. FDA does mandate in terms of there has to be quote unquote minimal manipulation to any sort of stem cells. And this does not allow the use of amniotic fluid or umbilical cord stem cells at all. So that is not an option. It used to be an option in terms of injections, but that is not what happens anymore. And so that is what a stem cell is. The overview is that it's a cell that hasn't quite made up its mind yet. It can change and become whatever it needs to be for the body, whatever it needs at that time. And so, like I said, our body's full of them because we have to keep regenerating cells. And it's magical that the fact that it can just sit there and kind of wait and say, okay, it's time to make this cell. So that's what it generally is. It's really cool. And now let's talk about the mechanism, how it works. So mesenchymal stem cells, that's kind of what we're talking about here. There's mesenchymal ones that are we're getting these, and these are the ones we're going to talk about. They can give rise to cells of the mesodermal lineage, including osteoblasts, chondrocytes, tenocytes, endothelial cells, myocytes, fibroblasts, nerves, and adipocytes. So basically can make anything. So like step back there, stem cells, this calls mesodermal lineage. So there's different types of development. This goes back to, if you think about developmental biology, we're talking about like the mesoderm is a specific, separation of, as our body's differentiating, we can go into mesoderm, endoderm, ectoderm, these kind of the very, very, very basics of when a baby's forming. It kind of separates in these layers, and these layers can become other things. And this mesodermal layer, like I said, these are the things that become osteoblasts or bone. Chondrocytes can make cartilage. Tenocytes making our tendons. Endothelial cells are throughout our lining and the cells there. Myocytes can make muscles. Fibroblasts are kind of the support cells for a bunch of things. Nerves and fat cells. So once again, this whole lineage of these mesodermal lineage can make all those different things. So it can make lots and lots of different things. And that's kind of like the mechanism for why we think stem cells are potentially useful, is that, hey, if I put stem cells into your knee with arthritis, it can maybe make the chondrocytes better. That's like the general idea behind it. Is that actually happening inside of live human bodies? Probably not. But we're working on it. We're trying to figure out, is it actually happening? But that's what we're working on. We're trying to get better there. So first, let's talk about bone marrow concentrate. So we're going to talk about bone marrow concentrate first, and then we'll talk about adipose-derived stem cells later. So first, so this bone marrow concentrate is found in trabecular part of the flat and long bone. So trabecular bone, there's kind of two different types of bones in your body, essentially, cortical bone and trabecular bone. And trabecular bone is like a honeycomb inside of your bone. It has lots of remodeling going on. It's very active, lots of cell turnover, and it's much less dense than cortical bone. And these are kind of found, like I said, a lot of times in the flat part of, or potentially long bones, and there's usually portions of it here, but it's the trabecular part is much more metabolically active, and lots of remodeling going on, less dense than cortical bone. And we use these bone marrow cells. They're kind of used because it has mesenchymal stem cells and their progenitor cells called myeloid and lymphoid cells, which play a role with tissue regeneration. So long story short, we find these tissues in things like the posterior iliac spine. So like that's where we get that from. What happens is we're drilled into the bone marrow. So obviously we have to go in there and do that, which can be a whole process in of itself, and it's a whole procedure with sedation and whatnot, but it's prepared similar to PRP where it's spun down and extracted, and that's kind of how the whole process works. And so where can we find this stuff? It's actually, like I said, a fluid very similar to the blood inside the bone. So bones are not just like bone, like just like you think a rock, right? You think a bone is just a rock. That is not the case, actually. Bone is actually very metabolically active. There's fluid inside there. There's bone marrow, as we're talking about here. There's lots of stuff going on in your bones. Your bones are not just steady. And that's why we talk about, so it's so important to weight lift early in your life and kind of lay down that bone, because the bone is metabolically active and we can be stronger. The earlier, we work with resistance training and whatnot, we can build up bone strength. So that's how we build up bone strength, because it's metabolically active, not just sitting there. But that being said, for this, in all intents and purposes, the most common location we use is the iliac crest, particularly the posterior superior iliac spine, as it has the most abundant source of these stem cells. There are various pockets of bone marrow, and you want to make sure you don't go too deep in there to get peripheral blood, which could then dilute the stem cells. So there's like a perfect little layer. Most of the regions where they have it are called the endosteal and subendosteal region, which are the two outermost regions of the bone, and that's where we typically drill in. So you don't want to go too deep, because it could actually get kind of more peripheral blood and could dilute out the stem cells. And so when you are doing this procedure, you're typically going under some sort of sedation, because I know I would not want to be sitting there and get part of my bone marrow taken out without some sort of sedation. It would not feel good. There's a big aspiration needle then placed into the hip bone, and then the fluid is taken out. And once again, spun down similarly like PRP. Usually there are two different spins. The first spin kind of produces bone marrow plasma fraction with a buffy coat and red blood cells. We've talked about buffy coat before. Buffy coat contains white blood cells and platelets. And then, like I said, the plasma fraction is typically the plasma. And then about 2 cc's of blood is taken to get any extra stem cells out on top of that. And then it's added to the bone marrow plasma fraction and then spun down. So the idea is we're taking, some of those red blood cells there, which might have some of the stem cells to the bone marrow, taking the bone marrow plasma fraction, which may have more of that, add those together, spin them down, and that's how you get our stem cells. There's no real consensus on stem cell dosing or aspiration technique. Once again, this is a issue that we had with PRP that we also see with stem cells, that, there's no real consensus on this is the way to do it. And then moving over to adipose tissue. So adipose tissue concentrate, this is found in adipose tissue. So it's similar to bone marrow in terms of ultimately what they can produce, but they do differ slightly in their differentiation potential in terms of what things it can turn into. But for all intents and purposes, they're very similar. When you get adipose tissue, a lot of times what you do is you get a 3D multicellular scaffolding. So on top of that, we also get adipose stem cells, stromal cells, or support cells. And so what's nice here is like when you get this fat, they kind of give this scaffolding for potentially things to grow on. So like, you have the scaffolding or kind of this base layer that allows you to kind of have all of the new cells come in, whether it's chondrocytes or fibroblasts or what have you, come in there and they kind of lay on it. And that's where they kind of just like bathe in that. And that's a good medium for them to grow and kind of produce things. And so we can have that and produce all those cells. And then of these, the adipose can differentiate into osteoblasts, or cells that make bone, adipocytes that can make more fat, chondrocytes makes cartilage, and then neurons as well can become nerves. And so once again, the procedure for this does require some sedation. Essentially, adipose tissue is harvested with sedation from a process similar to liposuction, actually. So it's like you're getting liposuction, taking out some subcutaneous fat. Obviously, it's not going into your abdominal cavity super far and getting like visceral fat, but it's getting that kind of superficial fat. However, you can't just use the fat as it is. The adipose tissue has to be emulsified or digested to kind of break down the stromal-vascular fraction. And then this stromal-vascular fraction is collection of cells within the adipose tissue, which can then be isolated and then spun down like PRP once again to create a stem cell layer. There's multiple steps in the process, but it's overkill in this podcast to go through step by step. It is a very involved mechanism. Like I said, it's not a thing that I typically do. So I was reading through it and I was like, wow, this is very involved. So there's definitely a lot of thinking going on. People put a lot of thought into it, but it's lots going on. And how does this work? Well, like I said, there are some immunomodulator effects as well. There's immunosuppressive effects, but at the end of the day, it must be triggered by some sort of inflammatory cytokines and then move to the damaged site. So like what I mean by that is you can see some potential like immunosuppressive effects, but we're trying to trigger this inflammation and creating this inflammatory cytokines, which then brings, additional healing factors or kind of activating the stem cells. These stem cells may also have an angiogenic effect, which may proliferate like blood cells and the vascular supply. Also may inhibit or start cellular repair, which may stimulate various stem cell reparative functions as well. And so long story short, we're trying to do a bunch of different things with this. We're hoping that, hey, maybe it triggers some blood vessel growth to bring blood to the area. Maybe it's stimulating cellular repair. Maybe it is starting this healing process back over again. Lots of things. That's what we're thinking for. And in terms of bone marrow versus adipose tissue, there's no real consensus on preparation standards, validity, or quality. Like, why would you choose one or another? Well, at the end of the day, adipose is a less invasive procedure, and there's typically less pain than bone marrow. And I think you get a higher amount of stem cells that can be procured from that because you can take a pretty large volume as opposed to just inside of the bone marrow inside the bone. They have pretty much similar differentiation ability, and so it's not like there's one huge dramatic one that I've seen, at least in the literature. Maybe there's, and maybe other people who do it more will speak differently to that, but it seems like they're generally similar in terms of differentiate potential. And so now let's talk about when do we use this, right? So Jordan, that's really boring, and you just bored the life out of me for the last 12 minutes. What's going on? Well, let's talk about when we can use it. So one thing they talk about is full cartilage thickness lesions, right? So people who have either a knee injury or whatnot, a lot of times they talk about either the talus or the knee. We have a full thickness cartilage lesion, so a big piece of that cartilage is gone. Looking at our osteochondral lesions, what we talk about there specifically. In this one review I saw, there were 7 studies that showed significant clinical improvement. These did show improvement in clinical and radiographic measures, meaning, hey, it looks like it's getting better and patients felt better. For osteoarthritis specifically, there's some more mixed data. It seems to be beneficial, but not necessarily greater than PRP potentially. Once again, lots of different data that you're going to find. Some will say it's the best thing in the world. Others will say it didn't do anything more than other injections. And so from a PRP standpoint, it seems like it's similar-ish to PRP and kind of works similar in that we expect to see a longer effect in this, necessarily right away, but long-term. It does seem to be better than hyaluronic acid or steroid in the long-term. And like I mentioned, long-term is really where PRP and stem cells shine in terms of like a year out, they seem to have better outcomes. It doesn't mean they're fantastic outcomes in that they're like everyone's way better clinically, but in terms of the measurements for the studies, in terms of clinical and pain outcomes, it seems like they're better at a year. In terms of bone healing, is it effective for that? Well, there's possible early radiographic improvement, but there's similar outcomes at 1 year, and regardless if they got BMAC with surgery or no BMAC with surgery. So essentially, if you had bone healing, meaning we had some sort of fracture and we got repaired with surgery and they added BMAC to that area, the outcomes seem to be about the same at 1 year, whether they got the BMAC or not. So maybe not as important. What about tendon repairs? Well, typically during a tendon repair, this is the Achilles or rotator cuff was the majority of the time. So they're in surgery, once again, giving it, seem to have improved outcomes. And we kind of talked about with PRP as well. Like, can you supplement PRP within an injection? With the surgery, is it helpful? And it seems to be like there may be some benefit from it. So, there are some things you have to think about in terms of considerations. Contraindications, typically, they do not recommend you getting stem cell injections. You have a history of cancer. Like I said, the idea is that we have this regenerative potential and we don't want to unleash some sort of oncogenic variation where we get out of control and things are growing and we can't control it. So that's generally one contraindication to this. And we have to talk about the elephant in the room, which is the price. These are thousands of dollars, and I have yet to see an insurance company cover these yet. So they're not covered by insurance, and it is very, very expensive. On top of that, this is the most invasive procedure that we have. It is a big procedure. You have to harvest it from some way, shape, or form. They said you're going to have some sort of procedure, which is the sedation and then the injection. So it's definitely something to think about. And so kind of putting it all together, my thoughts, this truly is like a new frontier right now. It is definitely very exciting in terms of the potential it may offer, and the mechanism behind it are very exciting, saying, hey, can we regrow cartilage cells? Can we, reverse osteoarthritis? That's like the idea. That's like our holy grail. Are we anywhere close to that right now? No, we're not. But it's exciting that people are doing this so that we can hopefully work towards that and maybe figure it out someday. That being said, if we thought we knew nothing about PRP, then we really know nothing about stem cells, because just like PRP, it's so heterogeneous. The mixtures are, different for every person. Every person is different, and the data is just not. You can't do huge studies on this because you just don't have a huge amount of people lining up to spend thousands and thousands of dollars. And I don't think I've seen a data set that's more confusing and that's more based on basic science than this. I was looking for, when I was doing my prep for this podcast, I was just looking through stem cells, trying to figure it out. And it's just like all these basic science for like, hey, this is why we think it will work. This is the mechanism. And that's great and everything. But man, clinical outcomes are very important and mechanisms are fantastic. But if you're spending thousands of dollars on just a mechanism and not having clinical results, then I have a problem with that. And so it's been very confusing. And like I said, where this fits into my tool belt, like I said, I don't personally do these yet. I'm not convinced enough on the data to even like look into trying to get this going for us yet. But this is kind of my last resort for an injection, and I don't do them. I'm not really convinced. And like I said, I'm also concerned for long-term safety data. We have no real safety data on that. There are some theoretical but scary risks in terms of, hey, these are some cells. What if they go awry and start building cells that we don't want to build? Like I said, there's no evidence that that's the case yet, but that's also something I'm, thinking about, kind of considering. And so at the end of the day, if you are like Scrooge McDuck and you're just like swimming in money and you want to try this, you can do that. That's very reasonable. I think the outcome seems safe in terms of it's coming from you. It's autologous, so I don't think we have a big reaction to it. What's the long-term benefit of it? I'm not sure. For me, if you want something fancy, I would go with PRP first, just because it's so much more reasonably priced, which is also saying something because PRP is not reasonably priced all the time. Sometimes it's very, very expensive. But like I said, it is reasonably priced when you consider the potential benefits when compared to stem cells. And so, like I said, that's where I would go if you're like, hey, I want to go to regenerative medicine route. Like I would start with PRP because, man, jumping to the expense of stem cell may not be worth it. And so I am open to being convinced, but man, for the price tag, this is insane at this time. And so for me, that's not where I'm going. But like I said, I am open to be convinced, and hopefully I am in the next couple of years, and I can learn more and we can all do better. Because like I said, if we're helping patients and it's accomplishing what we want to accomplish, then I'm all for it. Today we're talking all about hydrodissection injections and what does it mean, when we would use it, and why we'd want to do it, what we use it for. So let's get it started. First, hydrodissection, it's a fancy word, right? So hydro is water, dissection is kind of splitting something apart. So the formal definition here is the introduction of an injected liquid under pressure to either create tissue planes or separate a nerve or tissue layer from some other surrounding structure. So once again, let's break that down into real words, what that actually means. So we are injecting something, usually some sort of liquid, under pressure, meaning, hey, it's coming from the needle. Like there's nothing else. We're not just throwing water in there. We're using the needle, so that creates pressure. And we use that pressure to try to separate something, whether that is different tissue planes. So tissue kind of has multiple different planes that go on. If you look at your skin, you got multiple layers in terms of epidermis, dermis going on there. We go deeper than that. We're usually around nerves and joints and tendons and whatnot, but we're kind of using that liquid to help separate these layers or to separate either a nerve or tissue from some other surrounding structure. So another common example is injecting around a nerve, right? That's what we talk about. Like I said, in other words, we are injecting some liquid to help separate something from something else, most commonly at a nerve at some sort of area of potential entrapment. Like I said, the vast majority of times that I'm using these is some sort of nerve entrapment, but you can also do it for things like fat pad, behind the patellar or Achilles tendon. There's a fat pad there. You can use that to separate that. Really, you can separate it for whatever reason you want. There's no limit on what it is. That's the general consensus of what it is. Obviously, there are certain use cases that people use it more commonly for X or Y, but can really do for anything. So when we talk about this, like I said, nerve is our main use case. So I kind of want to talk a little bit more about nerves, about that, and talk about nerve pain, right? So when people have neuropathic pain, that's when I start thinking, where could I inject using this hydrodissection? And kind of at the end of the day, the pain can be anywhere and can be kind of anything, can present any different way. There's no one way. This is nerve pain. There are kind of more common ones. A lot of times people describe it as a deep-seated pain. It's like poorly localized. There's like this hurts. They'll kind of like generally point in an area, and it's like not necessarily one focal spot. A lot of times that can be one thing. They can also have a degree of pain that's not proportional to the degree of tissue or nerve damage. And like I said, this kind of falls into the whole biomedical versus biopsychosocial pain model, and that's a whole another literally probably lecture series and podcast series. But you could see like something that, hey, like everything looks fine, we don't think, but they're suffering lots and lots of pain. Then I think, well, hey, is this a nerve issue? Because sometimes when nerves are irritated, it just cranks that amp up to 11 in terms of like you're very sensitive to pain, and you're just like, man, this doesn't make sense. That's something I think about. Could this be a nerve type pain? A lot of times it's described as a soreness, maybe numbness, tingling, or electric shocks. That's a common one. People are just like, it feels like, just tingly. And that's the general like neuropathic type pain, which is pretty classic. Or they might get shocks where, they get like something buzzing and going there. On top of that, let's talk a little about the physiology of a nerve entrapment, right? So a nerve is susceptible to a pressure-induced injury when it's entrapped. And entrapped is kind of like a catch-all term, right? So it sounds like super dramatic, like, we entrapped it. All that means, we think, and like I said, this is even up for debate in terms of, if a nerve is running through an area, the tissue around there is just kind of a little tighter than it should be. That's kind of what I think of when in terms of entrapped, or maybe in nerves, if you can put them on tension, they can move typically, and maybe they're kind of more adhered and they can't move quite as well. That's another way you can kind of think about it being entrapped. But like I said, the idea is that when we have external pressure on a nerve, more so than it likes, that can lead to pressure-related injury that can happen. Essentially, can be external instruments, like if you leave a blood pressure cuff on for a really long time, or like you have a tourniquet on during surgery, that can lead to issues. Or it can be internal, meaning somehow entrapped, going through a bony tunnel, there's a bone spur that is leading to rubbing on it. Maybe a muscle is, hypertonic, or we have really a lot of excess fascia and we're leaning on it. So long story short, something is kind of pressing on it, something is kind of creating extra friction potentially on it, and that can be external or internal. Typically, if it's external, we just remove it. If it's internal, that's what we're talking about with these injections here. When nerves get compressed, though, this leads to segmental intraneural ischemia, which disrupts the blood-nerve barrier, and it may release pain-producing and degenerative peptides like substance P and calcitonin gene-related peptides. So like those are fancy words, but when we have this compression, can lead to essentially many areas of not getting enough blood. So leading to, kind of micro ischemia, and it can disrupt the nerve blood barrier, and they can releasing these things that may cause pain. And then prolonged compression, if it continues to prolong and have compressed for a long time, can lead to demyelination of the nerves and axonal loss, which is axon is a component of the nerve, and the myelin is kind of what lines the nerves to help propagate our nerve signals. And so we have a disruption in terms of either sensing or sending out messages of the nerves and propagating down the nerve, and then we have issues with the myelin, and that can lead to potential pain as well. And so when do these nerves get compressed, right? So there's lots of reasons, right? You could have this in the setting of a nerve elongation, meaning a force elongation, like a sprain or a strain of something. If you think of your ankle and you invert it and you put it on stretch, that can potentially do it. Also, potentially, if you have forced nerve movement through areas of fascial constrictions, or just kind of for whatever reason, maybe we had post-surgery, we have a lot of scar tissue there, that's a possibility. If you're forced around bony prominences, like I said, if you have, you're not supposed to, but you're trying to pushing things through there and it kind of rubs on the bone. If you have, like we said, osteophytic lesions, which are essentially bone spurs, that may happen to it. If you alter the course of the nerve, you have trauma like surgery, all these things can lead to a potential compression of the nerve. Like I said, it's not necessarily definitively clear why, but it can happen as well. And so when we do this, how does it work? That's the idea. Once again, like most injections, we say, we think it works like this. We're not exactly sure how things work, but this is what we generally think about. Kind of what we think about is this injection provides a mechanical effect to release and decompress an entrapped nerve, but also a pharmacological effect on relieving pain, depending on what we inject. So when we inject there, when we talk about mechanical effect, we're saying, hey, theoretically, when we inject fluid around there, are we separating that nerve from what's being entrapped? That's the mechanical separation. And then we talk about pharmacologic, depending on what we're injecting. We'll talk about that. The substance we inject may also act on those nerves and have some sort of effect. So we may release the pressure on these nerves by supplying the main nerves, or have the blood supply backed up due to compression, right? So maybe we're having compression of the blood supply and then have a buildup of potential toxins there because we had that little microischemia. And if we free it from that area, we might be able to clear out that area, and that's why we might have improvement. We'll see. But also when we're looking at nerves, how do we know when nerves are pathologic, right? So first of all, obviously pain in that area is going there. If you just see a nerve and there's no pain involved with it or no problem in that area, I'm not going to go in there, stick a needle and try to inject around that. We'll typically have some sort of issue with it. But if you're looking on ultrasound, you typically see a swollen nerve. You'll have a bigger cross-sectional area. So a lot of times you're like, what does big mean? Well, like, it's different. There's some standards for some different nerves, but generally what we do is compare one side to the other. And if you look at one side's big and angry, and when we look at cross-sectional area, you push pause in the ultrasound, you kind of measure all the way around it, say how big is it, and that can lead you to say, hey, this is big and we have symptoms over here. Okay, maybe this is an issue. Another thing we look at is something called sonopalpation over the nerve. So essentially you put your probe over the nerve that you can see, and you either push with your finger in front of it or push down with the probe, say, hey, like, is this reproducing your pain? And if someone's like, yeah, that's it, then you say, okay, then maybe this is a pathologic issue right here leading to that. On top of that, inside of a nerve is kind of a bundle of bundles. So it's like one big circle, and inside of them are these mini fascicles. You might see a single fascicle that's huge inside there. That can happen. And then also you can do ultrasound. You may show some snapping or sudden motion of a nerve over a bony prominence. So it's kind of in your area of irritation. That can happen as well. So there's multiple different ways on ultrasound where you can kind of take a look and say, hey, this may be a reason for why we're having symptoms. Once again, it's never as easy as just, hey, that's what it is because that's what I saw. I kind of have to put it all in the clinical picture of, does this imaging confirm the symptoms that we're already presenting with as a patient? And so let's talk about the procedure itself. So the procedure itself is always ultrasound guided. I would not recommend someone try to hydrodissect a nerve if they can't see a nerve. They're just doing landmark based. So we don't want that. Always using ultrasound guided. We're technically doing our normal steroid prep here like we do for any sort of injection. And we can do these in plane or out of plane. It's essentially up to your doctor's preference and how they do it. When I mean in plane versus out of plane, just technically speaking, I'll try to explain this in words for our audio listeners. If you are pretending that a nerve is going in a straight line, right? An in plane means your probe is lined up with that straight line. It is completely parallel with it. And then your needle is going to go in the same direction too. So on the ultrasound, you'll see the needle the entire way, and we're all going in one direction. When you say an out of plane injection, a lot of times what it is, if you imagine that straight line of the nerve and then you had the probe that's in line with it and just turn that 90 degrees, so now it's perpendicular to it, that's out of plane. And then you would inject where it's injecting into the middle of that probe right there. So the middle of the probe right underneath there, and all you see is a dot on your screen, the white dot. And that sometimes is the best you can do for the best approach. But like I said, typically it will depend on the location where you inject at and whatnot. So that's up to the doctor. It's kind of above, everyone's pay grade until it's actually their job to do it, but can be either of those, both they can do it. And then when we're doing that though, typically what we do is we inject these tissues above and below the nerve. So we'll find the nerve, we'll go in there, we'll inject above it, spray it. You'll start to see the separation around the nerve. It's really cool. And then once you're done there, you come around and try to go underneath it and do the same thing. And then trying as best you can to get a circumferential release. Obviously it's hard to get all the way on the other side sometimes just because of needle bend and whatnot, but you can try to get all the way around it, inject on top. That'll cover hopefully 180 degrees of it, then go underneath, get the rest of it to completely release the nerve. It's such a cool and just rewarding feeling when you get a complete release, when it's just like boom. Sometimes depending on where it's positioned and what it's up against, you try your best and you can get a percentage of it off. You can't get the 100%, but it's really, really cool to when you inject it and you can see fluid completely surrounding the nerve. That feels pretty awesome there when we do that. From a injection standpoint, in terms of just some tips and tricks, if you think you go inferior first with the bevel up, what will happen is that injectate gets pushed up and it pushes the bevel down as to avoid the nerve, and the opposite is true. So when you go superior, then bevel down, so when you release it, it gets pushed down and it comes on up and kind of keeps the nerve away from that. So we should hopefully see a halo around that nerve and then injectate all around. That's like the ultimate goal, is to do that and just kind of get this all around kind of halo, circumferential separation of the nerve. That's like what we're going for. And in terms of what do we go in there, we talked about, obviously we have the mechanical release of it. So we have the dilation, we just kind of boom, we get in there, we dissect away everything, and we have the fluid around it. That's one reason. And we also have the pharmacologic convention. So what can we put in that needle that actually makes a difference? So first is being steroid, obviously steroids and everything. That's always the right answer in terms of, can we do a steroid injection? Well, yeah, you can do a steroid injection for pretty much anything. It's obviously a strong anti-inflammatory agent. This will reduce cytokines, leukotrienes, prostaglandins. It reduces edema, essentially by reducing capillary permeability as well. These ones are going to be triamcinolone, dexamethasone, betamethasone, methylprednisolone, all those things. Those can be injected to kind of help calm things down. And there's definitely a role for that, but that's very common. Other things we can use are local anesthetics like lidocaine, ropivacaine. Commonly, these are mixed with something. The idea that how these works is these inhibit pain by reversibly blocking the voltage-gated sodium channels within the axon, and especially the axons of the nociceptors. So we're kind of, inhibiting these sodium channels, and that's how we get that like numbness, right, from this. So commonly when we do these, we'll produce like someone will be, ooh, I feel numbness and tingling. And that can last a couple hours depending on how long your anesthetic lasts, but that will go away after the injection as well. In terms of anesthetics, to choose lidocaine is a faster onset than like say bupivacaine, and the duration of lido is about 1 to 2 hours, and bupivacaine is a much longer onset and duration. So just something to consider as well. We've talked about those kind of being chondrotoxicity wise, but we'll think about that. And then next we're going to talk about dextrose. So dextrose, we've talked about with prolotherapy. We can use it here as well, which is crazy, but typically we use a different dose in prolotherapy. Prolotherapy, if you go back and remember, anything above about 12.5% is considered in a pro-inflammatory injection. Here we're using a much lower concentration than that, typically about 5% dextrose. So this is essentially a much more dilute dextrose here. But like I said, the mechanism is not clear, but what happened is the dextrose actually might downregulate some pain receptors or the C fiber activation. So like it has similar analgesic effects. And that's like kind of crazy. We have the sugar water injection and we go in there and actually may have downregulating of the nerve sensitivity, which is pretty darn cool. You can also do hydrodissection with PRP, like we talked about in PRP a couple episodes. This is concentrated platelets from autologous blood. These platelets then release granules, which release growth factors and triggers an inflammatory response. That can happen. We can also inject something called hyaluronidase. It's an enzyme derived from mammalian tissues, which has a lower viscosity than hyaluron, which is a part of the extracellular matrix. And essentially, what we do is this increases tissue permeability, may have effect on nerve conduction and whatnot there, and typically used as breaking up adhesions kind of one. It's not as common, but it can be used in orthopedic settings in certain situations. And we also have normal saline, right? So an isotonic solution can be used on its own or combined with other things. Essentially, it acts as a perineural space expander, but no intrinsic anti-inflammatory properties to it. But like I said, normal saline, inject in water. That's, not just necessarily normal water. Don't inject tap water. That's different than normal saline. But essentially, the normal saline we get, when you get the IV, you get fluids. That's what it is, and it's pretty much an isotonic solution. So we feel pretty good about that. That's gonna be safe. But what are alternatives to these injections, right? So someone's saying, hey, I got some nerve type issue. I'm not sure on these injections. I kind of want to think about it. Well, we can try other conservative things. So we can try splinting, right? Kind of some immobilization sometimes can be helpful to kind of calm down nerve irritation. Because if it's constantly irritated with movement, if we calm down and don't move for a little bit, sometimes that can be helpful. There's a time and place for that. I'm not immobilizing people for a very, very long time, but there's a time and place for that. Also, sometimes it may be a fact of we can try tendon and nerve gliding, where we kind of these exercises in PT, you've ever seen it, where people are doing weird head or leg turns. We're trying to help move that nerve theoretically through its normal course to see if we can kind of help it, glide a little smoother. We can also do other physical modalities in terms of things with occupational therapy, physical therapy, therapeutic ultrasound, electrostimulation, things like that. We can do a steroid injection. We talked about that. We can do a steroid injection instead of a necessary dissection. We just kind of go to the area, give a steroid injection to kind of calm it down. And then if all else fails, we can always do a surgical decompression in a lot of different cases. So let's talk about real quick, what are the use cases for this? I would say the most common reason we use this is for median nerve or carpal tunnel. Carpal tunnel syndrome by far and away. The idea behind this injection is that we're trying to peel the nerve off the overlying flexor retinaculum. So if you think about carpal tunnel syndrome, we'll probably talk about in future podcasts specifically what it is, what we're looking for. It essentially is that median nerve that is being irritated. It's getting irritated because it's kind of rubbing up on the flexor retinaculum that we're thinking about. Essentially, it gets swollen and enlarged, and it gets angry and leads to symptoms in the hand. But once again, it's the same idea. It's some sort of nerve entrapment. We think that it's because it's gotten bigger and whatnot, it's having an effect around the area. So we try to go in there, inject around it, creating that halo and trying to free it up there can be really beneficial. I've had patients who had a really good success with that using dextrose, and that's like my go-to right now. I've really enjoyed doing that. I think I get a lot of benefit from it. Also, we think about the ulnar nerve, right? So around our elbow, typically cubital tunnel. So in the cubital tunnels in the elbow, that's where we see that. We're trying to separate usually the ulnar nerve from the medial epicondyle and adjacent tissues. That's what we're going for. We can also do it for the lateral femoral cutaneous nerve, or neuralgia paresthetica is another name for it. Maybe the saphenous nerve as well. It's a commonly tried after knee replacement. We try to get the medial branch of the saphenous nerve because we have this medial type knee pain after potential knee replacement, so we can try that as well. And long story short, those are a couple of them. Like I said, by far and away, I think carpal tunnel is the most common, but it can be done at any nerve you can access safely. So even if you theoretically had a brachial plexus, you could do that. Obviously, there might be downstream effects because the brachial plexus touches a lot, but you can do it anywhere you go as long as you're safe, right? As long as you can get to that with your needle and you have good needle visualization. There's no real nerve you can't do this. So you could do it to the sciatic nerve. You could do it to really whatever you want. So the options are endless. It's just a matter of what your comfortability is doing it. In terms of outcomes, what happens here? Well, from a VAS reduction, so like a pain scale, the VAS is kind of this standardized pain scale. D5W seems to be better than compared to steroid or saline. So that dextrose solution of 5% seems to do better than saline or steroid, which is pretty cool. If we look at functional outcomes, kind of physical function or performance metrics, it seems to be better with that dextrose or PRP. And then all those dextrose PRP seem to be better than steroids as well. From a electrodiagnostic parameter, meaning, hey, when we do electrodiagnostics testing, that's like how fast the nerve conducts, dextrose and hyaluronidase had better outcomes than saline or dexamethasone. And then also PRP seemed to have some improvement as well. If you look at that nerve cross-sectional area, it's like we talked about when we measure in the ultrasound, we kind of get that big circle and measure the cross-sectional area. You seem to have the best reduction with D5W when compared to saline. And then PRP also improved when they compared that to the splinting control, but also that. And then also I saw another study that showed improved cross-sectional area with PRP compared to prolotherapy. So maybe potentially a little bit better, I'm not sure. But then D5W or PRP are probably should be considered the preferred injectates for carpal tunnel. And that's kind of what it seems like in the general trend that I've been seeing. Of note, like I said, we did still see improvements with saline injections. So, like, when we compare dextrose or PRP to saline, the dextrose and PRP were better, but we still got improvements with saline. So we may be getting just some straight benefits from the decompression from a mechanical standpoint, right? We talked about that, getting that injectate surrounding the nerve. Maybe that has something to do with in terms of the pain improvement as well. So that is just at a baseline. If we're doing something and injecting saline, I feel like we might have some improvement, and then what we inject might add on top of that as well. And so let's look about safety, right? So if we're injecting towards nerves, that can make people kind of give them the heebie-jeebies and whatnot. I'd say the rate of neuropathy or nerve issue after a peripheral nerve block is about 3 in 100. So like I said, 3% chance there. And there's been studies showing, looking at blocks before surgery, and about 16% of the time, the needle was actually introduced into the nerve. So they were watching it in ultrasound, and then people in the study were like looking at it secondary, and they're like, they just went into the nerve, but there's still no post-op complications. And so the idea is, like, even if we puncture the nerve, will it necessarily cause damage? I'm not sure. Like I said, 16% of the time they did that and still had no complications. So there might be some wiggle room in terms of getting close to the nerve might not be as dangerous as we think. That being said, I'm never risking that. Nobody I know is going to risk that, saying like, oh, let's just like go through if I transect the nerve or it's going to be no problem. So no, we're obviously very careful around nerves. But that being said, it is generally safe, it seems like, to get close to that nerve with the needle and even inject stuff around there, and it should be okay. And so overall, my take, I think this is another great option for patients. And it's another one that has a low risk of side effects, in terms of a lot of times we're injecting that D5 dextrose, which is super low. It's kind of just like physiologic. I use this quite frequently for injections like carpal tunnel. This is my thing. I think it's worth trying this before surgery, as it can be much less invasive. That being said, like, if there isn't good improvement though, I think, things like carpal tunnel, there's really good, effective, and minimally invasive surgeries. And so that's something I will do without, if I do a couple of them or I do one or two and I don't have improvement, I say, hey, it might be time to talk to surgery. But like I said, if you don't want to do a surgery, this is reasonable to try. Will it fix everything? No, it won't, but it's worth a shot. And like I said, some people get good relief from it, don't need to go to surgery, then I think that's worth it. And I typically use dextrose. I think it has good results, and the literature shows that it's super safe. So like typically that's what I'm going for when I do these injections. And so, like I said, I hope this was helpful to understanding, hey, a different injection option that we have for you as patients or providers, something we can do. So thank you so much for listening. Really appreciate it though. Today we're going to talk all about botulinum toxin for musculoskeletal indications. So we're talking about when we're using this, why we want to use it. It's definitely more fringe injection, not as common. We're going to talk about the specific uses I think it's appropriate. So let's get started. First of all, what is botulinum toxin? When someone hears a toxin, usually that's not a good thing, right? Usually that's some sort of, we're going on a toxin cleanse, right? Cleanse toxins from our body with this shake, whatever. We're not talking about anything about that. We're talking about something specifically called botulinum toxin, which is actually a toxin produced from the bacterium Clostridium botulinum. So shout out to Sketchy Medical. If any of the residents have ever seen that before, anybody who's done residency or medical school during that time, it's kind of an animated series to explain different bugs and the things they can cause and issues down the stream. And one of them is this Clostridium species, Clostridium botulinum. It produces this toxin, this botulinum toxin. So most commonly people know this as Botox, right? So people might be like, botulinum, that sounds terrible. Isn't it like a bad disease? You don't want to get that. So yes, it can be an issue if you have an issue from the toxin from that botulinum species. You can get botulism. We're not talking about that. We're talking about the toxin specifically isolated from there, used for medical purposes. All right. So this is not say, hey, go out and get botulism and it's going to solve your problems. No, it's a very, very specific use case scenario for this. But most people are familiar with Botox, right? It's very ubiquitous, especially from the cosmetic space. Most people think of Botox to think of, the injections in their head, you kind of get rid of the wrinkles. So yes, it is the same idea, but use it for a different case. And so I just want to clarify though, that is a name brand Botox. So I'm not going to talk specifically about Botox. I'm talking about botulinum toxin, which is the generic name, meaning there are several different commercially available formulations of that. There are different types, toxins like A, B, C. There's multiple different toxins. The most common ones being toxin A and B. So, botulinum toxin A is the most predominant one. And we'll talk most about that. And so the question is, how does this act, right? Like what is the point of taking a toxin and putting it into our muscles or anywhere else? And so the toxin acts on motor and sensory neurons. And so when we neurons, that's the area of the nerves essentially conducting. So the nerves, either sensory nerves, meaning sensory neurons are the nerves that are sensing pain or anything like that, whereas the motor neurons are the ones that give us contractility of our muscles. And so in the motor neurons, essentially what happens with this toxin is it reduces the muscle activity by irreversibly binding to the motor end plate presynaptic receptors, which essentially inhibits the release of acetylcholine and thus produces weakness. So if we step back here and kind of think about this, what happens at the end of, we call a motor end plate. So essentially a nerve is here and then the end plate is here. We're kind of talking about something has to be released in that synapse, that space. So that's usually acetylcholine. They release acetylcholine and that goes, to the motor end plate and then it causes a contraction. What's happening here is we are inhibiting the release of that acetylcholine, therefore decreases the contractility, right? So we're not having that contraction. So we are producing weakness in the muscle. That's the whole understanding of Botox, is that we're not allowing contractility to happen. This then decreases the ability of the muscles to contract, like I said, leading to this weakness. And the idea is that this is actually thought to last around 3 months. And so most people say, oh, I got to come back and get Botox every 3 months or whatnot, for my face. And that's the general idea. Why people say that is because it's usually lasts about 3 months, because what happens is when the toxin takes hold, what happens is this muscle inactivation, inhibiting that, you have to regrow these muscle fibers in these junctions essentially, right? So you have to form these junctions between the nerve and muscle, and it takes about 3 months to regrow that. So essentially, like I said, it's not like it's permanently closing any sort of muscle function forever. What happens is that specific receptor and that area that is affected by the toxin, that essentially is calmed down and kind of can't do anything. And so your body will regrow additional ones as well. And that takes about 3 months. And that's why it takes about 3 months, and things tend to last about 3 months. And so from a muscle perspective, long story short, that's a lot of rambling. I'm sorry. It inhibits the release of acetylcholine, therefore producing weakness and inability to contract the muscle. That's what we're going for. From a sensory neuron perspective, this inhibits the release of pain modulators like substance P, glutamate, caspase-induced duration anesthesia, or calcitonin gene-related peptides from peripheral and central neurons. So long story short, what that is, well, it inhibits the release of pain modulators. So the idea is that somehow, from a sensory perspective, we are decreasing the release of pain modulators, so we should hopefully be feeling less pain. That is the idea why it may be working from a sensory perspective. And this might actually last longer than our muscle ones. It's thought that it may last up to about 6 months, which is kind of interesting. So long story short, bringing it all back here, a bacterial toxin that we have harvested and isolated and purified, it prevents muscles from fully contracting, and it also may reduce the amount of pain that you perceive. So that's the idea as to why we would use botulinum toxin in a musculoskeletal perspective. Obviously, very different use cases for why we use it cosmetically, but that's the idea for why we do those in those settings. So let's talk about real quick about off-label and what that means for indications. Any sort of injection of botulinum toxin into a muscle is off-label. And off-label means there's no formal approved use for it. So when companies make a medication, they say, hey, we're gonna use it for this condition. For, let's say, hey, making this headache medication, it is used for headaches, and that's what we're doing. Maybe you do that and say, hey, well, actually, I found out that this medication, if we take it, it actually prevents seizures from happening or prevents something else from happening. And that's typically an quote unquote, off-label use, meaning we're using it for something other than what it was initially put up for. And from the musculoskeletal perspective, there's nothing that botulinum toxin was made for that we're specifically using it for in a sports medicine indication. There are some that you can use in terms of spasticity for looking for like cerebral palsy, things like that. There are some use cases for that are on label, but we are not using it for those instances. So anything we do is quote unquote off label. That being said, I don't want that to scare you. It sounds like sketchy, like we're going like the back alley, like, hey, you want to try this off-label thing? That's not the case. It's obviously under the proper supervision, but it's super common. Like I said, it is safe. We've seen this medication used tons and tons and tons of times in other places. We see botulinum toxin used all the time. This is just a slightly different indication for it. Once again, does not mean it's not safe. It's just not as rigorously tested. So that is something you need to consider. And like I said, I'm always going to talk about that. And I just want you to be informed, right? If you're informed, then you can make an educated decision. And I just don't want you to think, hey, this is something that like everybody does for every single situation. If someone's advertising this as like, hey, this is a fix for whatever, and it's probably coming off of their anecdote and some of the data, which we'll talk about here, but it's definitely not from an FDA approved indication mechanism. But that being said, doesn't mean it's unsafe, just that we don't have as, strong of indications for it from a governing body perspective. That's it. So I want to talk about side effects too, because it is very important. There are different side effects in every injection. We've talked about this ad nauseum if you're listening this season. If you've listened to all of them so far, props to you. But you'll know that every injection has side effects. And that's why everyone I want, when we're listening to this, I want you to be educated about this. I want you to understand the risks and the benefits, and you can make a informed decision that's best for you. But this one does have some that are unique, that are a little more quote unquote scary, right? So the big thing we talk about, if you look up the side effects that could happen, there's this big warning on the box, right? There's a theoretical possibility that this toxin could spread and cause the symptoms consistent with botulism, essentially. So things like generalized muscle weakness, we explained why that would be. Things like diplopia or double vision, ptosis or eyelid droop, dysphagia or problem swallowing, and possibly respiratory depression or difficulty breathing. Those are some pretty scary side effects. And like I said, the reason we did that is because if you think about it from a muscle perspective, right? If our muscles are weak, that makes sense why we're having our eye muscles might not hold as strong as we want to, leading to the double vision. The ptosis of the eyelid droop, maybe the same thing, eyelids. Dysphagia, the swallowing muscles, and respiratory depression, you could have the respiratory muscles be affected as well. And so those are things that can theoretically happen if you have exposure to this toxin. Is this very common? No, not at all. But it's one of those things where I'm always going to counsel about this because this is like the worst case scenario. So if you get injection with botulinum toxin and then you start having difficulty breathing, don't be like, oh, this is just a normal thing that happens. No, that's not normal. We want to get that checked out. Absolutely. The highest risk of this seems to be in children, but it can happen in adults as well. But like I said, I want you to be very aware of this. But there are a ton of different side effects that can happen. And a lot of them are based off of where you're injecting it, right? So if you just think about the mechanism in terms of inhibiting the release of acetylcholine, so we have that muscle weakness, it depends on where you inject it, right? And the face is going to be very different from the abdomen versus the legs, anything like that. So there's always going to be that risk of weakness. And on top of this, for our uses, a lot of times we're injecting these into muscles. There's always a chance that we're going to have, more weakness than we want. And so that's one thing we always worry about is like, oh shoot, like we put more than we wanted to here, or this had a bigger effect than we wanted to. And so therefore we're having more profound muscle weakness than we thought. And we also have to be careful when injecting these around nerves, right? So it can cause potentially temporary paralysis. One use case we'll talk about here is when we're doing it for chronic exertional compartment syndrome. One example we always counsel about is, hey, I'm injecting into an area that's kind of close to a nerve. So the common fibular nerve, if you inject there and the Botox gets in there, and you can have potentially paralysis leading to a foot drop. So like I said, one of those things, if we're by a nerve, it could get there, infiltrate the nerve, and could lead to some issues. And so we always counsel appropriately about this and understand, hey, that's why it's super important we understand where we're injecting this and why we're injecting it and how much we're putting in there. And so overall, let's talk about the general evidence. What is the general strength of the evidence for botulinum toxin? Overall is not incredibly robust. I wouldn't say it's super, super strong. There's not a lot going on in terms of tons and tons and tons of patient outcomes. But there are some case reports, there are some case series, there are some randomized trials, and depending on which situation and condition you're looking at for. So it kind of varies. Some have more data than others. But that being said, a lot of this is on smaller number studies, meaning the participant wise, we don't have, hundreds of thousands of participants like we do for pharmacology or pharmaceutical trials or other even steroid injections, something like that. We have thousands of people. That doesn't seem to be the case, but we take what we get and we kind of go from it. So a lot of time what we're talking about here is we do have some data, but a lot of them is anecdote as well. So it's clinician experience with some data kind of mixed in together. And so now let's talk about the conditions we can treat with this. The first one we're going to talk about is chronic exertional compartment syndrome, which is not to be confused with acute compartment syndrome, which is actually an emergency. Chronic exertional compartment syndrome is not a super common one a lot of people talk about. If you've ever had it, obviously you know it, or you know someone who had it, you'll understand it. But if you haven't had someone affected with it in your life, the odds are you probably have not heard of this. This is typically seen in active populations. And essentially what happens is the pressure in the muscle compartments builds up and causes paresthesias, muscle weakness, and exercise intolerance. The way I kind of describe it is that in compartments of the leg specifically, let's say lower leg, they're kind of like PVC pipes, right? And the muscles are inside of those. And then when you start exercising, you get increased blood flow and you get swelling of these muscles, but there's only so much room to expand inside those PVC pipes. And essentially what happens is when that pressure becomes so great, it starts to press on either the arteries or the veins or the nerves and starts to lead to kind of the downstream issues of numbness, tingling, exercise intolerance, all those things. And how we treat this typically is like, if we're running out of space, we cut open that tube or cut open the compartment with something called the fasciotomy. Now, that being said, for the chronic condition, you start running and exercising and feeling these symptoms. When you stop, they go away. So it's not like we have to emergently do a fasciotomy. Whereas if you had something called acute compartment syndrome, that is a surgical emergency, you need to go to the OR, get that cut open. That's a whole different topic that we're not talking about here, but they are very different. I want to let you know that. But that being said, the treatment for both of them is a fasciotomy. That being said, fasciotomies are the quote unquote definitive treatment, but they range in like success anywhere from like 55 to 66%. So it's not a slam dunk. And so somehow people came up with the idea of, hey, let's try injecting this botulinum toxin to give you something else to trial as well. The idea is that when we inject that botulinum toxin, it decreases the intramuscular pressure, which makes sense, right? If we're decreasing the amount of contractility that the muscle can have, we are therefore going to decrease the amount of pressure that could potentially be in those compartments. The results are somewhat impressive when you consider the general idea of why we're doing it. Overall, it's a pretty high success rate. Athletes, in some studies, were able to get back to their previous level of activity at about a 66% clip, which is pretty impressive if we're just injecting that. Also, some people use this injection as a way of understanding, hey, who would do well from a fasciotomy? So they inject it. If they do well with the botulinum toxin, they say, oh, this person may have symptoms that are caused by this and might do well with the fasciotomy. And that being said, there weren't a ton of adverse effects. So people seem to have good outcomes. Like we talked about, there's a theoretical risk of if you inject it in the wrong spot, could have that foot drop, but people seem to have a pretty good outcome. When people inject it, how do they use it? The range will be anywhere from like 12.5 to 50 units of the botulinum toxin for each injection, typically about 25 units in the proximal 1/3 of the muscle belly, and then another 25 units in the distal 1/3. And you can put them anywhere in the anterior, lateral, and deep posterior. In the leg, you have 4 different compartments: the anterior, lateral, superficial posterior, and deep posterior. So for the anterior, lateral, and the deep posterior, you're typically doing the 25 units. And then for the superficial, it's a little different, typically going about 50 units into the medial and lateral heads of the gastrocnemius, which is one of the muscles in the superficial compartment, and then 50 units in the soleus, which is another muscle in there. Like I said, that's a little probably more niche case than most people care about. But that being said, there are kind of patterns we use for injecting those, and that's what I've done. And people can have good success in this, which is kind of crazy. You think about these big fasciotomy surgeries, but then you inject a little botulinum toxin, and people can have effects lasting up to many, many months, or sometimes even years, which we talked about. We expect 3 months, right? 3 months in this, and based off of the mechanism, but people have had results up to years, which is kind of crazy for this. So it's one of those things where there's not a whole lot of data. It's a lot of case reports saying, hey, we did this and this is what we got. And that's kind of how data starts. But it's just something to consider. Hey, if you have chronic exertional compartment syndrome, this is like, hey, we should try this before we go to surgery, because I think it's a less invasive thing and kind of an option that we have. Another option that we have, we talk about plantar fasciopathy, right? So can be super annoying. Most people know about this condition, that either they've had it or someone they know has had it. And it's kind of an irritation of the fascia in the bottom of your foot. That's kind of how I think about it. And botulinum toxin can be used usually for refractory cases. So this is not one where it's like, oh, you've got plantar fasciopathy, let's go straight to Botox. Usually it's what we're going at the end of the day. We're kind of having to say, hey, okay, we tried other things, let's do this. There actually are a few randomized studies here, and it does seem to improve long-term outcomes and seem relatively safe. The injection amount seemed to be about 50 units of botulinum toxin at the point of maximal tenderness along the medial calcaneal tubercle. And so once again, not our first line. There's lots of things. Obviously, therapy is first. I always explain, if I think about treatments as a big pyramid, right? The base of that pyramid is going to be conservative things like rehabilitation exercises, eccentric training, stuff like that. And then the next level up on the pyramid is injections, and then surgery finally. And even here inside that injection ones, I would probably inject you with prolotherapy first before I go to botulinum toxin, just because potential side effects and a cost as well. And just a real quick number, talking about number cases, people throw in numbers anywhere from, botulinum toxin can cost anywhere from like $250 to $1,000, depending on, a lot of times people charge per unit of botulinum toxin for a cosmetic perspective. It is not necessarily the case for the musculoskeletal world, but like I said, this can be a rather expensive injection, kind of even to along the lines of PRP potentially. And so it's definitely not one we jump to first, because it is usually very expensive. And like I said, because we're using off-label for this, no insurance is going to cover this. And so it's going to be pretty much out of pocket, most likely, unless you're either in a study or you're in a military institution, necessarily, anything like that. Another indication we talk about is osteoarthritis. So obviously, right, we know osteoarthritis, very prevalent, can be super annoying and painful for people, and we can use this to treat persistent symptoms. Once again, not the first line therapy for it, but something we can consider. There are a few controlled trials, and overall there does seem to be some benefit, but there are limited studies. There was a systematic review in 2018 which saw improvements in the WOMAC and VAS scores, which are pain questionnaires, so showing that we did have improvement with pain. And then in 2017, meta-analysis showed improvement in pain scores at 2 months as well. There did seem to be a lack of long-term studies on this, though. It seemed that it worked out for about 4 to 6 months. We don't know how long it definitively lasts, right? Was it 12 weeks? Was it 16 weeks, 20? Was it 12 months? Who knows? But the data kind of went out to 4 or 6 months and seemed to have some improvement in their pain at that time. So something we consider, but although definitely not first line, right? Weight management, activity modification, exercise therapy, other non-joint degrading options are the things I would think about first. But once again, putting another tool into our tool belt here, saying, hey, this is something we can try if all else has failed. Another indication we talk about is lateral epicondylopathy or tennis elbow, right? So this is our classic tennis elbow. There have been some pretty darn solid treatments for this in terms of rehab, prolotherapy, PRP, shockwave therapy. There's lots of things you can do for this that have pretty good benefits and are probably going to be less expensive than botulinum toxin injections. That being said, this can be used as well. So like I said, for me, this is especially this, I feel we have lots of good options for this. Botulinum toxin is going to be kind of down on my list and something we can think about for refractory cases, but it is in the data, so I want to talk about it. Overall, though, there's generally weak evidence. One meta-analysis found it to be similar to steroids at 16 weeks, and then patients showed a significant decrease in their grip strength as well. So that was a clinically, or I should say statistically different grip strength, not necessarily functional. But like I said, we're seeing some decreased amount of grip strength and only similar to steroids at 16 weeks. And man, for me, that's not ideal situation. Well, there's another RCT that looked at, there was improvement in 1 year with some minor side effects, but it did report a case of transitory paralysis in the extension of the third digit. So once again, there are potentially side effects for this. Overall, what I'd say is clinically, this seems to be weaker in some regards in terms of the data that I see. It's something that we could try refractory, but it seems to be because we've seen some not ideal side effects. This is one where I'm like, okay, I'm going to try these other things first before I go to that, but it can be done. And like I said, not every person's getting these side effects. So it's just something we have to consider. Another condition we talk about is myofascial pain syndrome. And this is kind of a catch-all term, kind of like a big bucket saying, we don't know the cause of this. People will talk about quote unquote trigger points or hot spots or whatever you want to call it. But essentially myofascial pain is we have pain in this area right inside the muscle belly and we're not sure what's causing it. There's no formal diagnostic criteria, so it makes it very difficult to study this. So who knows what this actually is, but essentially what this is saying is, hey, this person has chronic pain in this location. We don't know why. Let's try putting some botulinum toxin in there. And that's what they did. And overall, there's mixed outcomes. No real evidence that improves things. I think there's other injections you can try for myofascial pain syndrome before you get to this. But that being said, it was done. Didn't seem to be unsafe. It just didn't seem to have awesome outcomes. And then another one we're going to talk about here is piriformis syndrome, right? So piriformis syndrome is one of those muscles in the posterior glute. You can use this toxin for piriformis syndrome. The doses range anywhere from 100 to 300 units potentially. Seems to be a safe and viable option. There's not a lot of data on this. Once again, this is all kind of case reports and anything like that. Not a whole lot going on there. A couple other things that were mentioned but didn't have huge amounts of studies on were joint contractures, Morton's neuroma, carpal tunnel even, but there wasn't quite as much there. So kind of, landing the plane here. Overall, I think this kind of goes into my special occasion bucket, meaning, the tools in my toolbox, this is not one I'll pull out unless it's really kind of scratching my head saying, hey, we don't have a lot of options. The exception for that being chronic exertional compartment syndrome. This is like going to be probably my first line other than gait retraining or other physical therapy stuff. But that makes sense from an injection standpoint, chronic exertional compartment syndrome, this is one that I would do early because I think it can be helpful and can save you from a surgery. But the other things, this is one you kind of have to earn your way to. A lot of these situations would be like, okay, well, we've tried this, hasn't worked. Like, let's give this a shot. Because I've said, I'm not sold on the data for almost any of these conditions, but it's one of those ones where, okay, I feel like it can be relatively safe as long as we understand the risks and benefits, we can go for it here. And like PRP and stem cells, this won't be covered by insurance. So it's going to be very expensive potentially. And so once again, I'm always trying to go the least invasive and least costly thing first, if possible, and then kind of work from there. And this is usually not going to be any of those to start, in terms of the least invasiveness or the least costly. So kind of, once again, think earning our way to these injections. It's still off label, so it's questionable on the long-term effects. There's not a lot of data as in terms of how much benefit are we getting in these long-term. So that's still up in the air. But overall, like I said, does appear to be safe, but the stakes are a bit higher because if something does go wrong and you have muscle weakness or a nerve issue, that can be a big issue. And so if I'm thinking about who's the right patient for this, this is someone who has failed other conservative approaches. They understand the risks, hoping to avoid a surgery. That's kind of where I think I would use this injection. So that's it for today. We're going to wrap it up. Thank you so much for following along. I really appreciate it. If you'd like, comment or subscribe or share with a friend, that would mean the world to me. And if you want to leave a 5-star review on your favorite podcast platform, that would really, really help get the word out. But thank you so much for listening. I really appreciate it. Now get off your phone, get outside, and we'll see you next time.